malignancies, ethical dilemmas, and real-world challenges. Whether you're here to present, observe, or to collaborate, you're an integral part of this meaningful dialogue.
This year, we gather around a theme that speaks not just to surgical excellence but to its purpose, delivering value based surgery at your doorsteps. This is more than a concept, it is a commitment, a promise to make surgery safer, smarter, and more affordable to every patient, regardless of geography or means. With that, let's begin the sessions and dive into a day of insight, innovation, and inspiration. Our first session is the award winning paper presentation, for which I invite the esteemed chairpersons to kindly come forward to take their seats on the dais. Professor Dr. Sheikh Sajjad, Professor, Department of Minimal and General Access Surgery, GMC, Baramulla. Dr. Shakib Nabi, Consultant Surgeon, JLNM Hospital. Dr. Amir Yusuf, Associate Professor and Head, Department of ENT and Head and Neck Surgery, GMC Anantnag, and Dr. Gulzar Ahmed Bhatt, Consultant and Faculty, NBE, Department of Surgery, SDH, Kupwara. I request the chairpersons to kindly introduce the speakers for the session.
माइक होता है माइक होता है check check check
Hello. Good morning, everyone. So, without wasting further time, I would like to call upon the first speaker of the day, Dr. Raj Sivathana Chikla, PG Scholar, GMC Srinagar. The topic is laparoscopic D3 right hemicolectomy for right-sided colonic malignancies.
Good morning, respected chairpersons and all the delegates and my co-PGs from GMC. My name is Dr. Raj Shwetan. I'm third year postgraduate from GMC Srinagar, and I came forward in front of you to talk about my paper presentation. The topic is laparoscopic D3 right hemicolectomy for right-sided colonic malignancies. In this, I'm going to talk about the safety and feasibility of the procedure and also some technical aspects of this procedure. The study period is from the year 2012 to somewhere between February and March 2025. Total number of patients which we have considered are 140 patients, and this is a prospective observational study. Mean age group of my patients is 61 years of age, and gender ratio is 3:1 of male and female. Of these, the benign diseases were 12 and malignant were 128. Most of the diseases are in the ascending colon, followed by the cecal carcinomas and hepatic flexure growths, and the proximal TC growths were also been studied. Good chunk of these diseases belong to the grade 2, and grade 3 with signet morphology are 20 cases. We have done D3 right hemicolectomy the most. Frequency is 63 cases, followed by D2 and D3 extended right hemicolectomy on equal basis. We have done side-to-side anastomosis in all the patients, in most of the patients, and end-to-end anastomosis in 27 of them. All these anastomosis were intracorporeal. We haven't done any extracorporeal anastomosis. Coming to the photographs, I want to show you a CECT abdomen finding of the CA colon. This is a ascending colon growth where the arrowhead shows hypodense lesion in the ascending colon. The port placement is as such. For laparoscopic D3 plus right hemicolectomy, we have a camera port 10 centimeters down and lateral to the umbilicus, 2 working ports on either side of the right lower abdomen in the spino-umbilical line, and a Palmer's point 5 mm, 12 mm working port. Intraoperatively, this is how the growth was looking like. There was a cecal growth with adherence to the lateral wall. To approach this, we have firstly identified the SMV, and we have made a submesenteric plane, and we started dissection from there to find the most prominent vessel of the SMA, that is the ileocolic, and we have flushly ligated. So this is the crux of CME and CVL. CME is central complete mesocolic excision, which is based on the navigating the plane of free fascia of Fredette, which is starting from the SMV. We go laterally, medial to lateral approach. It is also called as the open book approach. And idea of CVL, the central vascular ligation, is flushly ligating the pedicles to from their origin. Tracing the SMV more cranially, we find these two vessels. These are the branches of gastrocolic trunk. One is the superior right colic and gastric epiploic. And furthermore, going cranially, we find the another vessel, that is the middle colic. Now, in this picture, we are ligating the pedicle of the middle colic, since this is an extended D3. Gastrocolic ligament has been divided, lesser sac has been reached, and you can see there is a vein that is prominent here, that is the right gastric epiploic, that has been ligated. After that, we deploy an endostapler through the window which we have made between the transverse mesocolon and the gastrocolic ligament, and we resect the transverse colon. We do the same with the ileum, terminal ileum. We deploy the stapler and divide it, resect it. Now we have to mobilize the cecum and the ascending colon hepatic flexure from the white line of told. We do the intracorporeal anastomosis here from the terminal remainder of the ileum and the transverse colon. This is a side-to-side anastomosis I am showing here, and we close the Peterson's defect. Specimen is retracted from the right-sided lower abdomen working port, and drain is placed in the anastomotic side. This is how our surgical specimen looks like. You can see the entire transverse colon to terminal ileum to transverse colon, and you can see the entire mesocolon with the omentum also. That is why it is a D3 plus omentectomy, because we have taken the omentum also. This is a short video. Firstly, do the diagnostic lab and check for the liver mets or anything, and place the optical ports. Sweep the small ball laterally, locate the growth, do the adhesiolysis of the growth to free the growth from its find the SMV. This is the first jejunal vein which you can see. You lift the anterior leaf of the mesentery and navigate the submesenteric plane. This vessel is the right colic, which we are going to ligate it and divide it in between the clamps. Next, we also skeletonize the SMV more cranially to look for the gastroepiploic trunk and divide the branches of gastroepiploic trunk individually and ligate and divide them. Furthermore, cranially, we can see the middle colic somewhere around here. If we carefully delineate here and look for the middle colic, you can see the pedicle of the middle colic and right and left branch of the middle colic. And this is where it has to be ligated right at the pedicle to achieve a D3 extended dissection. We have ligated the middle colic and divided it. Now the transverse mesocolon is been opened to create a window to deploy a stapler. Gastrocolic ligament is been divided and omentectomy is performed in that plane. The gastroepiploics are being divided in between the clamps now. We deploy a stapler on the TC and we resect it. We revert back to the place where we have ligated the middle colic, you can, the ileocolic. You can see the entire SMV completely stripped naked of its fascia. And you can see the duodenum down below and the pancreas also. This plane is created by doing the mesocolic excision completely, following the free fascia of adult, which is the embryonic plane. Now we are trying to mobilize the colon from its lateral attachments, following the white line of code, which is also the coelomic plane, where we can encounter no bleeding. Care has to be taken about the right gonadal vessels and right ureter in this dissection. Now the hepatic flexure is being mobilized. The entire right hemicolon along with its complete mesocolon is being removed. Flushed ligation of vessels has been demonstrated and the entire SMV can be seen. So this is the idea of complete mesocolic excision in a D3 dissection. Later on we do the side-to-side anastomosis. We use 20 V-lock for this, and we close the enterotomy with the same 20 V-lock. Now the Peterson's defect, which is created from the ileocolic mesentery and transverse colon, is being closed. The anastomotic leak rate in our cases was 2.14%. We had 3 patients who had anastomotic leak and 1 mortality. Patient died on the 4th postoperative day. And all these anastomosis from 2 of these anastomosis were from the end-to-end anastomosis, and 1 is side-to-side anastomosis, and no covering stroma was being created in these patients.
Dr. Raj, nice presentation and beautiful demonstration of the dissection. So this presentation is open for the question answer session. Any questions? Dr. Raj, you said that some of your patients, the pathology was benign.
Yes, sir.
What was the pathological report in those cases?
Sir, few of the patients were having ileal stricture diseases. Tubercular strictures were also being reported in the histopathology, and patients of IBD were also being taken into the study.
Did you exclude those patients or you included them in the study?
Sir,
what was the pre-op histopathological report, biopsy report, and what was the post-op report?
Sir, pre-op and post-op report were the same, sir.
Same.
Pre-operatively, for few patients, the report was benign, and post-operatively, yes, sir, pretty much same, sir.
So did you exclude those patients?
Sir, initially, sir, when we started doing right hemicolectomy, we started with D1, D2, and later on we started with D3, sir. D1 and D2 we have confined for only benign diseases, especially D1, sir. And D2 we have started only for T1 and T2 diseases also initially with no nodes, sir.
So what was the benign disease most common?
So most common, we have 12 benign lesions, sir, benign cases, and 8 of them most commonly were IBD, sir.
Okay.
So literature says the advantage of D3 is we have an extended lymph node dissection, so the lymph node yield in D3 is high, sir. So what that does is we have the lymph node ratio, which is a prognostic factor and also indicative for starting early adjuvant chemotherapy. The number of lymph nodes, positive lymph nodes, is to the number of total lymph nodes harvested. That is the lymph node ratio. Also, sir, if we imagine a case of T2 and stage 2B disease where the lesion is T2, the tumor size, but there is no lymph node, T2 N0 M0 basically. So it is kind of hard to imagine a lesion that is crossing the serosa but not involving the node. So that is the clinical staging. There we are downstaging the patient. We are staging it as stage 2 because the clinical stage is T4 N0 M0. But once we do a D3 dissection and harvest all the lymph nodes, we do the complete mesocolic excision And then we see the histopathological report. The stage will be PT3, PT2, N1, or there can be skip metastasis also, sir. Like in our case, we have found skip metastasis in PT3 and PT4 patients. 7 patients we have found the skip metastasis, which would have been missed if had we done a D2 dissection. Sir, as such, sir, there is equal survival benefits on D2 and D3, but in D3, since we are harvesting lot of lymph nodes and we are starting the adjuvant chemotherapy on an early basis, and we are accurately staging the patient, so obviously there is a survival benefit. But in my study, sir, I have a limitation. I haven't followed the patients for long term, sir. So oncological aspect, I'm not very confident about how D3 hemicolectomy is oncologically sound. But I can say that it is a safe and effective procedure, because I have only followed the patients for 30 days. The early mortality was only 1 patient, sir. That is due to an anastomotic leak.
You said you had 3
I think we are running short of the time.
Okay.
Let us continue with the second speaker.
Thank you so much, sir.
The second speaker is Dr. Pooja Devi, postgraduate scholar from SKIMS.
I request audience to limit the number of questions to 2 or 3 maximum, because we have already started the session very late. No, but this is a competitive presentation, so we have to ask the questions. We need to ask. Let us give an equilibrium. Ask 2 or 3 questions, everybody. Okay, Dr. Pooja, you can.
Good morning, respected chairpersons, faculty members, delegates, and my dear colleagues. I am Dr. Pooja, a second year postgraduate resident in the Department of General Surgery at SKIMS SORA. I will be presenting today a study done on post-operative wound infection, a surgical perspective at a tertiary care hospital in Kashmir. Just a basic introduction. Surgical site infections, as we know, are the second most common healthcare associated infection. CDC defines surgical site infection as the infection occurring within 30 days of a surgical procedure and within 1 year if an implant is placed in situ, and the infection appears to be related to the procedure. So the study that I'm going to present was conducted in SKIMS SORA on patients who underwent clean and clean contaminated surgeries. Objectives of the study were to determine the incidence of surgical site infection, to study the clinical profile of patients developing SSI, to assess the microbiological profile, and to identify risk factors associated with surgical site infections. So it was a prospective observational study which was conducted, as I told, in the Department of General Surgery in SKIMS SORA on 117 patients who underwent clean and clean contaminated surgeries for a time period of 1 year. This study included population over the age of 14 years, patients who underwent clean and clean contaminated surgeries. This study excluded patients who were operated in emergency, patients who received antibiotics for more than 1 week, patients who were reoperated, and then patients who were lost to follow-up. So overall, it was found that the incidence of surgical site infection was 13%. So out of 117 patients, 15 patients developed surgical site infections. The rate was 6.5% in clean surgeries, and the rate was 19.4%. That is 7 out of 36 patients developed SSI in clean contaminated group. This study found that the incidence of surgical site infection was higher in males. It was 12.6% compared to 9.3% in females. The incidence was found higher in the age group of 51 to 60 years. And the various risk factors which were associated were anemia, diabetes, smoking, and prolonged surgery. Then the relation of duration of surgery and surgeon experience with surgical site infections. It was found that surgeries who were prolonged for more than 150 minutes, they had a higher incidence of surgical site infections. Surgeries that were done by junior surgeons, they had a higher incidence of surgical site infection. And patients who were first in the OT list, they had a lower incidence of surgical site infection. Clinically, the patients presented within 3 weeks. Most common presentations were cellulitis, as we can see in the first image. Then it was wound abscess, and 3 of the patients, out of the 15 patients who developed SSI, they had wound dehiscence as well. So microbiological findings. It was found that the common pathogens which were isolated were Staphylococcus aureus. It was the most common, isolated from 45% of the population. Second most common was E. coli. Third most common was Klebsiella, and the other organisms that were isolated were Pseudomonas and Streptococci. The organisms were sensitive to coamoxiclav, cefuroxime, amikacin, but were resistant to penicillin and cotrimoxazole. So hospital stay and outcomes. On an average, patients who were infected stayed in the hospital for 5 days, and then patients who were infected, who developed surgical site infection, stayed in the hospital for 8 to 25 days depending upon the presentation. Out of the 15 patients who developed SSI, 11 patients required surgical intervention in the form of incision drainage, debridement. There was no mortality in our study group. Now the most important slide, that is the preventive measures for surgical site infection. The preventive measures have been divided into pre-operative measures, intraoperative measures, and post-operative measures. Pre-operative measures include patient optimization, that is control of blood sugar levels pre-operatively, treatment of anemia, smoking cessation, then adequate skin preparation, which includes use of povidone, iodine, and chlorhexidine solutions. Then part preparation also plays a role. Shaving has been advised to avoid clip hair if necessary. Then antibiotic prophylaxis, it has been told that antibiotics, as per WHO, antibiotics are to be given within 60 minutes prior to the incision. Then intraoperative measures, maintain aseptic techniques strictly, minimize OR traffic and crowding, maintain normothermia, prevent hypothermia, shorten operative time wherever feasible, and use sterile surgical instruments and gloves. Then post-operative measures include regular and sterile wound dressing, avoid unnecessary dressing changes, and educate patient on wound care and hygiene at home. Conclusion. So I conclude my study with the saying that despite modern surgical and sterilization techniques, despite prophylactic antibiotic use, post-operative wound infections still remain a major contributory factor for patient morbidity. In our study, it was found that the incidence of surgical site infection was 13%. In the clean surgery group, it was 6.5%, which was higher than the expected. So the overall goal is to reduce the incidence of surgical site infection to less than 2% in clean cases, and it can be attained by strictly adhering to the protocols and following the preventive measures. Thank you.
Yeah, Dr. Pooja, I would like to ask, did you took any pre-operative any sample of skin swab or something?
Sorry, sir?
Did you took skin swab before surgery?
No,
Pre-operative?
not
No,
pre-operative period. No.
So what was the agent used to prepare the part in all the cases? Was it same everywhere or you had?
Part preparation.
Yeah.
So part preparation in the pre-operative period, it includes, so the best way.
What did you use? I'm asking about the study.
For part preparation, sir, povidone iodine.
In every patient?
And chlorhexidine solution, but in every patient mostly it is povidone iodine that we use in our setting.
Dr. Pooja, a very good presentation here.
So thanks.
Yeah, I want to ask you one thing. You were including clean and clean contaminated cases.
Yes, sir.
Did you include hernia patients in it, elective hernia cases?
Yes, sir.
But in that scenario, because you are putting in a mesh in hernia,
Yes, sir.
and as per CDC guidelines, the mesh infection or the infection in terms, once you use the processes, for 2 years, you cannot say whether it is an infected case or a non-infected case. For 2 years, you cannot, because your study is only 1 year length.
Yes, sir.
And for 2 years, if you have to follow up the patient for 2 years and there is no infection, then only you could include that as a case.
So,
And if you have included them, then I think your study is biased.
so as far as I know, as per the CDC guidelines, if the infection occurs within 1 year of an implant, then we consider it as surgical site infection. So since this study was conducted for a period of 1 year only, we had included hernia patients in this surgery. Yeah.
Beta, my question has 2 parts. First, what are the biases in your study? And second, how do you prepare the part? You said you excluded cases who were given more than 1 week of antibiotics per pre-operative. Why do you need to give antibiotics for 1 week in clean and clean contaminated cases?
Sir, ideally in clean and clean contaminated surgeries, if patient is taking antibiotic for some other reasons.
Why have you excluded patients who had taken antibiotic for more than 1 week?
Sir, because we are not going to get a positive culture, and if
But then that's a bias, na? Even if you give it for 1 day, it's a bias.
Sir, the ideal time to give antibiotic in such patients is 60 minutes. As per the WHO guidelines,
Can you go to your presentation, exclusion criteria?
Yes, sir. So in this, it has been mentioned that patients who received antibiotics for more than 1 week, but that antibiotics
Why
might...
more than 1 week?
So more than
Why
1
not
week for
less
some
than 1
other
week?
reasons, like other than the
Agreed.
surgical reasons.
Antibiotics are antibiotics. You give it for any reason, you are giving antibiotics. So there will be bias. My question is, why 1 week? Why not 2 days? Why not 24 hours? Why 1
The
week?
question is, if somebody had taken antibiotic for less than 1 week, did you include that patient?
She has included. Why?
So that means you have included those patients.
So that's a bias. How did you prepare the skin preoperatively?
So the best time to prepare the skin is in the operative table itself.
That question was already answered.
I want to. She's preparing the skin. For how much time is she taking chlorhexidine, and for how much time povidone iodine?
Yeah, that was my second part, but I deliberately did not ask you because of the time shortage. Otherwise, that was the point. After
So
preparing the part, how much time did you wait to make the incision? That was.
Should I answer that, sir? Sir, we prepared the part with povidone iodine, and the minimum duration for which it has to be kept there is 30 seconds. For minimum duration, sir.
Okay, thank you.
Okay, thank you, sir.
Third speaker is Dr. Elizabeth. She is the DNP scholar in Department of Surgery, GMC Anantnag. She will be talking about GIST, stomach, laparoscopic management in our 5-year experience at GMC Anantnag Hospital, Associate Hospitals. Dr. Elizabeth, please start. Please be on time.
Learning is experience, rest everything else is information. A very warm good morning to one and all present here, our respected delegates, seniors, mentors, and my dear colleagues. Today I will be presenting a topic on stomach GIST, laparoscopic management, and our 5 years experience at GMC Anantnag. So, GIST is the most common type of a mesenchymal tumor found in gastrointestinal tract, arising from anywhere between from esophagus to an anal sphincter, but most commonly it is seen in stomach and intestine. Global incidence is about 10 to 15 cases per million population, and age group ranging from about 50 to 70 years with a slight male predominance. As you can see in the picture, histologically, GIST is broadly classified into spindle type, epithelioid, and mixed category. KIT and Dodge positivity are the immunohistochemical marker, and they are very diagnostics. CT is the investigation of choice, and diagnosis is confirmed via biopsy in immunohistochemistry. In CT imaging, we can see well-defined exophytic mass in the arising from the gastrointestinal tract, and central scarring and ulceration is specific to the stomach. Tumor size, mitotic index, and rupture status determine the risk and prognosis. Now I will briefly walk through the pathophysiology. GIST arises from the interstitial cells of Cajal, which are the pacemakers of the GI tract. Genetic mutations of the c-KIT and platelet-derived growth factor receptor A are the central trigger. So the most common one is c-KIT gene mutation, and then platelet-derived growth factor receptor A, and then wild type, which has none of it, but they are SDH deficient and BRAF mutant, and we can also see this in neurofibromatosis 1. There is constitutive activation of tyrosine kinase pathway. As you can see, the RAS, RAF, and MAPK pathway is for cell proliferation. PI3K, AKT, and mTOR pathway is for cell survival, whereas JAK-STAT is for cell growth. Angiogenesis and local effect of the GIST is that it is very, very low, vascular tumor, and it has a huge mass effect. And then what it causes is just because of that you have some intestinal, some symptoms of abdominal discomfort as well as ulceration and bleeding can be seen. According to Gensu modification criteria, it is divided on the basis of tumor size, mitotic index, and primary site of the tumor. Treatment. Surgical resection is based on the local treatment. There are on the location type 1, that is whether the tumor is on fundus or greater curvature. Type 2 is in that we do stapled partial gastrectomy. Type 2 in pre-pyloric and antral region. We do laparoscopic transgastric resection. Adjuvant therapy post-surgery is given in high-risk GIST cases. In intermediate GIST, it is dependent on the case basis, and in lower risk GIST, we don't usually give the adjuvant therapy. Neoadjuvant therapy in pre-op is done by imatinib. It is done usually in the large tumors or whether the GIST is in the critical area of the esophagus or rectum. And we must confirm whether there is KIT or PDGFRA mutation before starting the imatinib therapy. If it is D842V PDGFRA mutant, then that is resistant to imatinib, then we start avapritinib. Targeted therapy is also done. If their KIT is on the axon 11 or 9, it responds well to the imatinib, especially in the 9, or we give higher doses, and rest you can see in the slide. In GMC Anantnag, of our past 5 years experience, there were 19 patients who were diagnosed with GIST and underwent operation. In this, 8 were females and 11 were male. Initially, 4 were performed by open laparotomies, 3 were laparoscopical, but they were then converted to open, and 12 were managed laparoscopically. Our youngest patient was 22 years old, whereas the oldest was 70 years old. This is the type of resection we did. Out of this, 12 laparoscopic resection, 6 were sleeve resection, 2 were distal resection, and 4 were wedge resections. The mean age was 53, mean operating time was 145, and mean hospital stay was 4 days plus with a deviation of 1.5 days. We had complication. There was staple line bleed for one patient for which re-exploration was done and staple line reinforcement was done. In one patient, we had wound site infection and wound site infection from the retrieval port, and it was managed conservatively. Follow-up. Patients were being followed-up in oncological department as well as in general surgery department. 5 of these patients were treating with imatinib therapy as they were having high mitotic index and on their basis on their HPE report. You can see a few pictures. So this is a brief video. As you can see in the video, the stomach is being resected, and then we are opening up, and then we will go and find the tumor. This is the identification of the tumor, and the tumor is being resected now, and it is very safely being placed in the endocath bag for the retrieval, as the pseudocapsule shouldn't be destroyed as it can cause the peritoneal migration. So you can see here, it is very carefully being taken out and it is being closed. Now the defect is being closed. So this was the gastric GIST, and neoadjuvant therapy was given for reduction of the size. This is the laparoscopic view of the GIST. The complete excision was done, a wedge excision of the stomach was made, and specimen was taken into endocath bag. Conclusion: early diagnosis and complete surgical resection. Targeted therapy based on the mutation status are the key for the improvement of survival of GIST. Surgical resection with R0 margin is the mainstay of the localized tumor. No lymphadenectomy is needed as there is no metastasis to the lymph node. Long-term surveillance is essential due to the risk of late recurrence even after the curative surgery. Multidisciplinary approach improves the outcome of the complex and advanced cases. Thank you so much.
Dr. Elizabeth,
yes,
what was the common presentation of these tumors?
Sir, they presented with As our youngest patient, which was 22 years old, she was having abdominal discomfort. She was just saying that she was feeling heaviness in the stomach all the time. And some of them were having anemia, chronic anemia, because there was some mucosal bleed there. That was the presentation. Yes, sir.
Dr. Elizabeth?
Yes, sir.
Wonderful presentation, and I like the way you were presenting.
Thank you,
Honestly,
sir.
claps to you for that.
Thank you, sir.
I just want to. What was the size of the GIST that you have removed? The range of the size?
Sir, it was all laparoscope. They were all less than 5. They were actually less than 5.
What was the smallest? I'm interested in the smallest, not the largest.
Sir, it was 3, the smallest one.
Problem with laparoscopy is that you don't have tactile feedback
Yes.
and a small size. My question is, how do you identify less than 1 centimeter GIST in the stomach once you're doing laparoscopy?
Sir, EUS can be done.
Do you have it here?
No, sir, we don't,
So what do
unfortunately.
you do in the OT?
Question. I'm
Yes,
a
sir.
non-professionalist, but I just want to clear. You yourself said IHC is essential for confirmation.
Yes, sir.
IHCs in all cases?
Yes, sir. After when it was after the sample was retrieved, yes, they were sent for immunohistochemistry.
Mentioned in their presentation.
Yes, sir. There is a slide I can show you of the patient.
Good morning.
Yes,
Nice
sir.
presentation.
Yes, sir.
I'll just inform the audience what Dr. Arshad was speaking. All small GIST, because we have a problem with laparoscopy. You can do tattooing.
Yes,
because
sir.
you will not be able to feel it, so that is the way you identify, because you have to reach the exact spot. You do the tattooing 1 hour exactly before surgery and you will get the results.
Yes, sir. Thank you, sir. Thank you so much.
Thank you, doctor.
Amir, sir, this is the immunohistochemistry.
Okay, thank you. So now next speaker is Dr. Gurveen Kaur, PG scholar, GMC Srinagar. She will be talking on comparison between pneumatic and laser lithotripsy in management of CBD stones, experience at SMHS Hospital.
A very good morning, everyone. Myself, Dr. Gurveen Kaur, a PG scholar from GMC Srinagar, is going to present on the topic comparison between pneumatic and laser lithotripsy in management of CBD stones, experience of SMHS Hospital. I have done this study under the valuable guidance of Professor Dr. Iqbal Salim Mir, HOU and HOD of our department. A brief introduction. Choledocholithiasis is a prevalent issue present worldwide. There is a prevalence of about 10 to 18% of simultaneous common bile duct stones and GB stones. So, laparoscopic CBD exploration became a cornerstone in today's time for concurrent management of both the stones. The aim of the study was to compare the efficacy of pneumatic and laser lithotripsy in laparoscopic CBD exploration. This study was conducted in GMC Srinagar between March 2023 to March 2025 in a prospected manner in 38 patients who underwent laparoscopic CBD exploration. Randomization was done by coin toss, heads were subjected to laser and tails to pneumatic lithotripsy. All procedures were performed by the same team and all patients received the same post-operative care. Written and informed consent was taken by all the patients. Institutional Ethical Committee approval was obtained before starting the study and a statistical analysis was done. This is a flow diagram. We had a total cases of 44, laser had 20 and pneumatic had 24. But we lost to follow 4 patients in laser and 2 patients in pneumatic. So overall we analyzed 60 patients who underwent laser lithotripsy and 22 patients who underwent pneumatic lithotripsy. This is a short video showing the pneumatic lithotripsy being performed in our hospital. We use a 24 French rigid nephroscope through which we use a lithoclast to break the stones. This is showing the same. We can see the stone being broken up into smaller pieces which are later on retrieved endoscopically only. This is another short video showing the laser lithotripsy. We use a 9.5 French flexible ureteroscope through which a 230 micrometer diameter laser fiber is introduced and we use the laser to fragment or popcorn the stones which are again removed laparoscopically. This is a video showing a clear CBD which we try to obtain Post both the procedures, you can see the duodenum, the sphincters, and the distal part of the CBD. This is all being shown through the flexible ureterorhinoscope, and then this is the proximal part showing the left and the right hepatic ducts and the sectoral ducts with the free flow of bile coming out, showing the proper clearance which we try to achieve in every patient. Now coming to my results. First, the age. The maximum number of patients lied in the age group of 41 to 50, being 6 in the laser and 8 being in pneumatic. My mean age of laser was 43.17 plus minus 4.86. The pneumatic had 41.82 plus minus 5.31, with the p-value being insignificant as 0.7331. The pre-op CBD diameters on USG had the maximum range of 16 to 20 mm, with the laser having 18 plus minus 2.36 and the pneumatic having 19 plus minus 2.18, and the p-value being insignificant 0.9227. The MRCP diameters lied in the range of 2.1 to 2.5 centimeters. The laser had a mean of 2.17 plus minus 1.32, and the pneumatic having a mean of 2.26 plus minus 1.89, and the p-value was again insignificant. Now coming to the intra-op findings, the number of stones, we had the maximum range in 5 to 6 stones in laser being 44%, and pneumatic had the maximum range in 4 to 5 stones being 34%. The mean was 3.61 of laser and pneumatic have 4.23, and the p-value was insignificant. The number of stones did not change the efficacy of both. Now coming to the most important thing, the fragmentation time. The laser took the maximum time of 30 minutes and the pneumatic took the maximum time of 30. But the minimum time taken by pneumatic was 10 minutes. My mean of laser was 23 plus minus 4 minutes, and the pneumatic had the mean of 11 minutes, and the p-value was very significant, being less than 0.001. But the laser, although took a longer time, it allowed us the clearance of sectoral ducts also. Now coming to the conclusion, in cases of larger stones, we would recommend to go for pneumatic lithotripsy, but in cases in which we have the sectoral duct involvements, we would like to go for laser lithotripsy. But in order to ascertain which is the better of the two, I would like to have a bigger study group and more follow-up to tell which one is better. The limitations of my study were that we did not have a cost analysis being done. We were a single center, a very small sample size, and it was not a double-blinded study. I would like to end by saying that we need to reclaim the duct. When we have come this far in laparoscopy, why stop short of a complete solution? Because leaving the stones behind is leaving complications behind. This is an interesting case. We did a laparoscopic CDD and we retrieved 61 calculi. This stone art is done with the stones of the same calculi made by me, put up by my guide. These are my references. Thank you.
A nice presentation.
Thank you, sir.
Hello.
A very nice presentation. What was the average size of the stone which had been subjected to pneumatic or laser?
So we had around 3 to 5 centimeters.
Size.
Centimeters, 3 to 5. The maximum size was 5 centimeters, which we have retrieved.
Okay.
But because they were broken up inside, we could not actually ascertain the size.
But pre-op
MRCPs, the size were between 3 to 5 centimeters.
Did you get any sample for stone analysis? Was it done?
No, sir.
No, it was not. Any long-term complications? What was the longest follow-up you did?
Sir, actually the study was on only the clearance of the CBD. Post that, we had done different procedures for the different studies. So the complications were mostly of the surgery which we did. It was either CDD or HepJ. So they had strictures. One patient had a stricture, two had bile leak also.
Which arm? The pneumatic or the laser one?
Sir, one was of laser and the bile was of pneumatic.
Okay, thank you. Any questions from the
Dr.
audience?
Gurveen?
Yes, sir.
Could the patients have been randomized and categorized on the basis of CVD diameter?
So we could have done it, but then it would have led into bias. Like if we knew that the patient had more number of stones, or if they were OCH, we would have given them laser before. And if we knew the patients had a lesser diameter, we would have given them pneumatic. But because we wanted the bias not to be there, we did a randomization by coin toss.
On follow-up of the patients, how many patients reported with the recurrence of the stones?
Sir, actually, recurrence we had of one patient because we had done CTD for the patient and not HIPJ because he had OCH, but that did not give us a clear indication if it was because of laser or pneumatic or because we did a CDD and not an HIPJ.
Okay, thank you.
Did you drain, use any drain for in the CBD? Did you use a T-tube drainage in all patients or in none? Or
No.
did you do primary closure?
No, no, sir, not for all patients. We did primary for few and we did CDD for few. Yes, sir. Yes, sir. Yes, sir.
Okay, thank you,
sir.
Dr. Gurveen. So the next speaker for the session is Dr. Manveer Singh, PG scholar, Escoms Hospital, Jammu. We will be talking on efficacy and future of negative pressure wound therapy in the treatment of non-healing ulcers, a case series.
Good morning, everyone. Today I am Dr. Manveer Singh, PG scholar, Escoms Hospital. I will be presenting my paper on topic of efficacy of negative pressure wound therapy in treatment of non-healing ulcers and post-traumatic wounds, a case series under the guidance of Dr. Manish Sharma, Assistant Professor, Escoms. As negative pressure wound therapy is widely used treatment for non-healing ulcers that has gained popularity in the recent years. It involves the application of negative pressure to a wound bed, promoting wound healing by decreasing the interstitial fluid levels, removing excess fluid, improving the blood flow, tissue approximation, and rapid tissue formation. Aims and objectives of my study were to study the outcome of negative pressure wound therapy, dressing in non-healing and post-traumatic wounds, to evaluate the impact of negative pressure wound therapy on granulation tissue formation. Inclusion criteria were patients with chronically infected wounds and patients with post-traumatic wounds were included. Exclusion criteria included septicemia, malignancy, osteomyelitis, fistulae, and wounds with exposed vessels. Now, introduction. Practice of exposing a wound to subatmospheric pressure was first described by Fleischmann et al. In the year 1993, who first reported the use of subatmospheric pressure. However, the first reports about the use of negative pressure wound came from Argenta and Markiewicz in the year 1997, and the term coined the term VAC that was first used. And by the design, continuous negative pressure dressing provide a homogeneous distribution of negative pressure over the wound bed, even if the surface contour is irregular. Now, the mechanism of action of negative pressure wound therapy. First is the macro deformation. The wound shrinkage occurs approximately 80%. Second is the micro deformation, that is the cellular changes at the wound interface levels, and then removal of fluids and maintenance of a moist wound environment. So this enhanced blood flow implies an increase in inflammatory mediators, growth factors, leukocytes, and antibiotics. So all these things explain how a VAC therapy can stimulate the closure of wound and reduce bacterial burden. So in the negative pressure wound therapy, the healing process is meticulously monitored with wound assessments typically conducted every 4 to 5 days. This frequent evaluation allows the health provider or doctor to observe the progression of the healing. A crucial element of negative pressure wound therapy efficacy is precise regulation of pressure applied to the wound site. In adult patients, standard pressure is minus 125 mmHg, and this pressure helps in drawing out exudate and reducing edema, thus optimizing the conditions necessary for tissue regeneration. Now we will see the cases. First, this is, you can see, 46-year-old male patient presented with necrotizing fasciitis, and on debridement was done on follow-up, and negative pressure wound therapy was applied. Now these are pictures of negative debridement and application of negative pressure wound therapy. Later on, you can see above, this is after the first session of negative pressure wound therapy, the wound. Now after second session of negative wound pressure therapy, and this is after the final session of negative pressure wound therapy. You can see the granulation tissue formation and the wound progression. Now case 2, this is a patient of pressure sore over the ischial region. It is a 64-year-old male patient with diabetes, presented with pressure sore over right gluteal region with infected and foul smelling discharge. Debridement was done and the soft tissue infection was present up till the popliteal fossa, so debridement extended up till the knee. So these are the post-op pictures of debridement. Now after 3 sessions of VAC, this was the wound. Now case 3, a 24-year-old male drug abuser presented with an infected wound in left inguinal region. Wound debridement was done and 2 sessions of negative pressure wound therapy were given. So after this is the healed tissue. Now a 46-year-old female patient with diabetes presented with a necrotic patch over left flank of her abdomen with spreading cellulitis on the anterior abdominal wall. Wound debridement was done. You can see the debridement pictures, and after on follow-up, this is negative pressure wound therapy was applied and the well-healed scar you can see, granulation tissue. Now this is a 75-year-old male patient presented with the pressure sore over left trochanteric region, approximately 6 into 5 centimeter. 2 sessions of negative pressure wound therapy were given, and these are the pictures after the therapy. Now, this is a patient of 56-year-old male patient with diabetes presented with non-healing ulcer over plantar aspect of the foot. Debridement was done and later on negative pressure wound therapy was started. Now, these are pictures post debridement and first session. Grafting was done later on and that is the healed scar. Now, this is a 58-year-old female patient with diabetes presented with non-healing necrotizing ulcer over dorsal aspect of left foot. Debridement was done. You can see the pictures now. These are the debridement pictures. Now VAC was applied and 2 sessions of negative pressure wound therapy was given. Later on grafting. Septic foot, approximately ulcer 4 into 6 centimeter. Debridement was done and negative pressure wound therapy was given. So this is a 46-year-old male patient with diabetes having a history of IV drug abuse, presented with non-healing ulcer over the heel pad area of the left foot. Debridement was done, negative pressure wound therapy was initiated and follow-up grafting was done. These are the pictures after the session of negative pressure wound therapy on the heel pad area. And this is the healed scar after grafting. Now this is a 11-year-old you can see the granulation tissue formation. So this is one more case of 62-year-old male patient presented with non-healing ulcer over anterolateral aspect of his leg, and debridement was done, and after that negative pressure wound therapy. These are the after granulation tissue formed after negative pressure wound therapy, and later on grafting was done. So this is one more case of diabetic patient presented with, these are post negative pressure wound therapy pictures over the posterior aspect of his leg, and later on grafting was done. So in my percent were the necrotizing fasciitis, 13% were children. So in conclusion, I would say 13% were children. So in conclusion, I would say negative, it's
Any patient with a bleeding diastasis was included in your study?
if there were exposed vessels.
Only exposed vessels?
Yes, sir.
Suppose
And
patient has a PT of 2, you'll apply VAC.
No, sir. If there is normal coagulation profile.
Wound
should
is
be there.
oozing actively, you'll apply VAC.
No, sir. If there
Then
is.
where is it? It's not written in your exclusion criteria.
Yes, sir. But with patient with normal coagulation profile, and yes, sir.
Just a comment. Kindly do not use the term drug abuse. It's better to use substance abuse.
Yes.
That's a better thing.
Its pressure can be adjusted according to the type of the wound. Yes, sir? Sir, that machine negative, that vac machine, vacuum assisted closure.
So we are short of time. Can we start on next speaker? Thank you.
Thank you.
Dr. Akhilesh is from PG, is a PG scholar in GMC Jammu. He will be talking about pediatric trauma and overview and single unit experience. Please start and be on time.
Good morning, respected seniors and my dear fellow colleagues. Today I, Dr. Akhilesh Angurana, under the mentorship of my esteemed guide, Dr. Sanjay Kumar Basin, will be presenting an overview of pediatric trauma in our single surgical unit in GMC Jammu. Pediatric trauma is the leading cause of death after infancy. 25% of all traumatic injuries are due to pediatric trauma, with mortality as high as 20%. Children are at usually higher risk of trauma due to lack of communication skills and inability to protect themselves. Serious injuries in a child may not be evident initially, as pre-hospital providers are not well trained to handle child injuries. Children are not just small adults. There are significant anatomical, physiological, and psychological differences which lead to higher incidence of multi-system trauma. Risk factors for pediatric trauma are poverty, frequent family household moves, male childs, single parent, household crowding, other siblings, poor maternal health, marital discords, child abuse, inadequate adult supervision, and exposure to hazardous environmental circumstances. Infants and toddlers are usually at higher risk of falls, non-accidental traumas, burns, ingestions. Preschoolers are at higher risk of falls, pedestrian injuries, bicycle injuries. School-age children are at higher risk of bicycle injuries, sports injuries, motor vehicle collisions, and adolescents are at higher risk of motor vehicle collisions, sports injuries, violence, intentional injuries, etc. Whenever a pediatric patient comes to our ER, we must do a primary survey, that is airway, breathing, circulation, disability, and exposure. Early signs of shock, that is tachycardia, poor perfusion, altered mental status, should not be missed. We must resuscitate the patient with fluids and escalate to blood products when necessary. For external, if there is external bleed, we must use direct pressure, and fast and other imaging should be done to rule out internal hemorrhage. For disability, we should use Glasgow Coma Scale, pupillary response, motor function, signs of raised intracranial pressure. We should consider non-accidental trauma in a cause of head injury. Importance of serial neurological examinations should not be undermined. Hypothermia can be prevented by using warm fluids, warm blankets, etc. Therefore, a multidisciplinary approach consisting of physicians, surgeons, physiotherapists, nurses, social workers should be there to handle pediatric cases. We must ensure pain management, nutritional support, and rehabilitate the child as early as possible. Our objectives are to study the mortality due to pediatric trauma. Our secondary objectives are to study mode and pattern of pediatric trauma, system-wise injuries, and management of our patients. We collected 10-year data from 2014 to 2015 to 2024 from our emergency admission database, which consists of demographic details, residence of our patients, mode and mechanism of injury, organ or system-wise injury, and treatment that our patients received. We analyzed the outcome on the basis of mortality, and I am presenting you the data in the form of numbers and percentages. In the last 10 years, the total pediatric admissions we had were 3,116, out of which 1955 patients, that is 66.7% of patients, were of trauma. Adult patients were 11,944, out of which 4,758 patients, that is 39.83% patients, were of trauma. Out of total 1955 pediatric trauma patients, 1249 patients, that is 63.8% patients, belong to rural area, whereas 706 patients, that is 36.11% patients, belong to urban areas. Out of the total 1955 patients, 1187 patients, that is 60.7%, were males, and 768 patients, that is 39.2%, were females. On the basis of mechanism of injury, the number one cause was falls, that is 1282 patients, making it a percentage of 65.57%. The second most common was RTA, that is 358 patients, 18.31%. Third most common was burns, that is 222 patients, 11.35%. Other causes include assault, 1.2%, animal induced, 0.6%, fall of heavy object, 2.35%, and cycling. The most common system affected was brain. Traumatic brain injury, total patients were 828, making it a percentage of 42.35%, out of which 569 were males, 259 were females. Spleen trauma patients were 20, that is 1% of total patients, 16 males, 4 females. Liver injury patients were 10, 0.5%. Burn patients were 222, 11.3%, out of which 146 were males, 76 were females. Urinary or renal trauma patients were 12, intestinal patients were 7, face injury patients were 84, chest injury patients were 121. Management that our patients received: traumatic brain injury patients, 635 patients were managed in our parent unit, that is 76.6%, whereas 193 patients were managed by in the neurosurgery ward, and 19 succumbed to their injuries. Spleen injury patients, 11 were managed conservatively, 9 were managed operatively. Liver injury patients, 8 were managed conservatively, 2 were managed operatively. Burn injury patients, 213 were managed conservatively, and 9 succumbed to their injuries. Urinary patients, 4 were managed conservatively, for 6 we did trocar SPC, and for 2 we did bladder repair. Intestinal injury patients, 7 were managed conservatively, and for chest injury patients, 81 were managed conservatively, and 29 were managed operatively. Prevention is always better than cure. 90% of pediatric injuries can be prevented. We must ensure child safety environment at home. We must use window stops, guards, smoke alarms, safe storage of medications, water safety, safety in kitchen, prevention of falls at home. Children must use bike helmets, car safety devices. Education of parents and caregivers on child safety should be ensured. Strengths of my study are: it is the largest cohort of pediatric trauma over a decade in our institution. Limitations of my study are: it is a single center, single unit study. We do not have lack of data on surgical management of traumatic brain injuries and lack of long-term follow-up. Conclusions: pediatric trauma constituted 1/3 of trauma cases presenting to ER. 60% of the patients were males. Rural area accounted for 63% of the cases. Number one mechanism of injury were falls, number two were RTA, number three burns. Most common system affected: number one were traumatic brain injury, number two were burns, number three were chest. Most cases were managed conservatively with good outcome. Pediatric trauma is preventable. We must use orchestrated management. Primary and secondary surveys should be done. We must never hesitate to admit for observation, ask for help, or consult specialty services. By saving the child, we are saving the future generation. Thank you.
Very nice presentation. The topic is now open for questions.
Good morning, everyone. Wonderful presentation. I must congratulate GMC Jammu for such an extensive record keeping, over a decade of record, and I know it is still in the books. Every single patient, even if he comes after 5 years, you can track that patient down in your registers. Yes, that is absolutely fabulous. I just wanted to know one thing, the type of fall, you said the maximum mechanism was fall. Did you interrogate what caused those falls?
Sir, mainly the patients were from rural areas. There were fall from bed or fall from height. Usually these patients come to our emergency, and mostly they are from rural areas.
Okay, so it was mainly fall from the
bed and fall from height. Yes, sir.
Height was in the house or somewhere?
Sir, from the roofs or fall in the house, fall from bed, they mostly come to our ER.
Basically, this is data from my unit, and because
Sanjay sir,
he will lose marks.
Sorry to interrupt you, sir. So it's a competitive, so faculty is not allowed, sir. Sorry. Sir, most of your patients, Dr. Akhilesh, were brain injury, traumatic brain injury. What type of injury they had?
So mostly they were having contusions
or small
How
injury.
did you manage those all patients in general surgery rather than in a neurosurgery? They should have been managed in a neurosurgery setup.
So those patients that require extensive neurosurgery care, they are being shifted to neurosurgery ward. And those patients who can be managed in parent unit, neurosurgeons come on their rounds and we discuss with them the management of the patient, and these patients stay with us.
So the title change is not a single unit. So it's
No,
two
sir,
departments.
I have mentioned it.
Beta,
it
how do you check for the size of the cervical collar in a child?
Was there any spine injury? Was there, Dr. Akhilesh, was there any patient of spine injury? A fall from height, we expect a spine injury, especially a cervical spine. How did you stabilize the cervical spine in these patients? I think that should be the first step in while you are doing the primary survey or the assessment.
Yes, sir, we must immobilize the spine on.
So how did you stabilize it? By using what?
Tapes and the collars.
I have a question, a wonderful presentation, a wonderful data keeping. You mentioned that you were using age-adjusted GCS. Could
Yes,
you
sir.
elaborate further? How do you assess GCS in a 1-year-old or a 2-year-old or a 3-year-old?
Sir, the V score differs from adults and pediatrics. V5 means a child which can respond, which can talk, or which can fix or make a social smile. V4 is
Age-wise, it differs. There are many versions of Glasgow Coma scale as per as the age criteria. Less than 1, you use one particular GCS, 1 to 3, another 3 to 10, and then for the adult scale. Are you aware of that or not?
No, sir.
Okay, not an issue.
With this, we conclude this session. Thank you, everyone.
One more thing which is very good that because I can search with that only 30 mortalities in last 10 years. That speaks volume about their age. Just 30 mortalities.
Definitely, it's a commendable job.
It is a total 1.58% mortality.
Okay, thank you, Dr. Akhilesh.
We extend our heartfelt gratitude to the respected chairpersons and speakers of this session for their valuable insight and impactful presentations. As a token of appreciation, I now request Professor Dr. Nazir Ahmad Salru to kindly felicitate the dignitaries with their mementos. Professor Dr. Sheikh Sajjad. Dr. Gulzar Ahmad Bhatt. Dr. Amir Yusuf. Thank you, sir.
Now, I request Professor Dr. Ejaz Malik to kindly come on the stage to felicitate our judges for the session. Professor Dr. Sheikh Sajjad. Dr. Ravindra Kumar, Dr. Altaf Malik, and Dr. Gulzar Ahmed Bhatt.
With the permission from the dais, I want to speak a few words. All the presentations were exceptional, and down the memory lines, way back in 2012, I was given an opportunity to present my paper. So it is my request to all the postgraduates here that they should convince their colleagues, their juniors, their seniors to register for ASI and JCOSI, because this gives them the platform and it is one of the eligibility criteria for your exams as well. Thank you so much.
Thank you, sir. We now move on to our next scientific session, that is faculty presentations, and are honored to invite the chairpersons to the stage. Professor Dr. Munir Ahmadwani, Professor, Department of General and Minimal Access Surgery, Sikkim's Medical College, Sohra. Sikkim Sohra. Dr. Ravinder Kumar, Associate Professor, Department of Surgery, Government Medical College, Kathua. Dr. Altaf Malik, Assistant Professor, Department of Surgery, Government Medical College, Doda. Dr. Khalid Bashir, Associate Professor, Department of General and Minimal Access Surgery, Government Medical College, Anantnag. I request the chairpersons to kindly take a seat and introduce our speakers for this session.
Good morning. Good morning, everyone. We are session 2 of day 2 today, and there are faculty presentations. And the first speaker is Dr. Jasmeet Singh Ahluwalia. He is the Chief Department of Bariatric and Minimal Access Surgery, Star Hospital, Punjab, Jalandhar. He will be speaking on techniques of mini gastric bypass.
Many thanks, sir, and it's a real honor to be here in front of such an esteemed gathering. So my topic for the day is the technique of mini gastric bypass. I'm Dr. Jasmeet Ahluwalia from Jalandhar. I bring greetings from Punjab.
We'll request you to finish it off within the time frame.
We have loaded a different presentation. ये नहीं है। मैं अपना लैपटॉप लूँ। नहीं कोई नहीं। आपने उल्टा वो सेशन 2 वाला कर दिया शायद। कौन सा सेशन? इसमें से कोई है? नहीं, सेशन पोस्ट लंच में था ना 2 बजे, वो वाला आपने इधर कर दिया शायद। फोर्थ सेशन में देखिए, ये बताएं ना, आप वापस जाइए फोर्थ सेशन में देखिए, यहाँ डे 2 पे जाइए, फोर्थ सेशन में देखिए, ये वाला होगा। So actually he has loaded the other presentation which was in the afternoon in this session, so I'll just come back to the same session. So this is basically a video on technique of mini gastric bypass. So since it's just a video, I'll straight away jump to the video. This is the OT setup. the window, and then you see the posterior surface of the stomach as well, because sometimes the dissection is not appropriate and the stapler enters in the inappropriate plane. So this is being fired from the right 12 mm port as shown in the diagram depicted there. So initially in the make sure that you have enough, at least 2 centimeters of space left from the residual stomach towards the pylorus, so that the secretions of the residual stomach, they are able to travel well. And then make sure the stapler is horizontal, it's not twisted, because this is the point where usually the twist of the stomach tube happens. So if the first firing is good, then the twisting is less likely. So after this fire, we'll start firing upwards towards the OG junction. So the second fire is again from the same port, and make sure you have wide stomach tube there, so that we have to create anastomosis also, and there is no ischemia between the staple lines. And after this second fire, we'll introduce the bougie. We can introduce the bougie between second and third fire. So in this case, we are doing it in the second fire. So this is the bougie, 38 French standard bougie that we used for all our pediatric patients. And then we'll start firing from the midline port. But always check your crotch. There may be a loose staple, so always check it and remove it before we start to fire the stapler. So this is quite a frequent happening, so always look for that. And then we'll be going straight towards the OG junction and leaving just enough width as of the bougie that we have introduced. That's the 38 French bougie. So we can just hug the bougie and keep on firing towards the OG junction. So this is the third fire from the 12 mm port on the left side of the patient. Again from the same port, we'll keep on firing. The fourth fire usually takes 5 to 6 fires to divide this stomach tube. And again, just hugging the OG, the gastric calibration tube, we'll fire one more. And before we fire the final one, we'll create a window. The window should not be very far off from the OG junction. Just have a good look underneath and divide the attachment of momentum towards the stomach. You can use an energy source because there may be small bleeders there, so make a good window before we introduce the last fire. So that's the posterior window. And then from the same port, we'll introduce the stapler right into that window and visualize the posterior end of the stapler anteriorly before we fire it. So always make sure you have that visible and leave not more than 1 centimeter from the OG junction, so that the fundus is almost resected and the patient has good loss of appetite. And achieving that, we can fire. So in this case, the fire is just adequate, it is not divided. So at this time you can decide either just leave it as such, or you can put a clip on the medial side and then divide, or use another stapler. Since this is an MGB, so we just cut it across, or we can just leave it as such and then proceed towards the next step, that is the anastomosis with the stomach tube to the jejunum. So we'll make a small hole at the tip of the tube that we have created. Make sure you see the bougie inside, so that this opening is through and through. Sometimes the hole may not be through and through and there may be a submucosal tunnel. And then we'll decrease the head up, we'll make the patient almost flat, and then start looking for the ligament of Thyroids in the left side of the abdomen, and make sure the Thyroids is properly identified, because the whole concept of bypass is based on the measurement from this ligament. So expose it well, look for its attachment well before we start to measure. So that is the ligament of Thyroids, and from there we are going to bypass anywhere between 150 to 250 depending upon the patient's profile. So I know that the metallic portion of these two graspers are 4 centimeters. So depending upon that, I am taking 5 centimeters run on the jejunum, and then we'll keep on shifting whatever bowel we have already measured towards the patient's left, and keep on shifting the bowel that is remnant towards the patient's right, so that the bowel is properly oriented before we do the anastomosis. So with these two instruments, we will just run the bowel. and the anastomosis is anywhere between 150 to 250 depending on the patient profile, but usually for a given patient of around BMI 40, it's around 180 centimeters. So once we have determined the point where we have to anastomose, we'll just hold that point, make a small opening using again the same hook. We can use a hook or a harmonic to make that opening. Okay, sorry. So once that opening is made, we just take the same stapler from the midline port, we introduce the blunt end into the bowel, and then take it upwards towards the stomach. So once we are taking it upward, we again elevate the liver, expose the stomach tube, make the head end again up, and ask the assistant to push the omentum that is in between downwards. And then with the help of the pushed bougie, we can push the opening towards this stapler and introduce the sharp end of the stapler into the stomach tube. So once it is inside the stomach tube, then you can withdraw the bougie. You can withdraw the bougie before that also, but keeping it there at times helps in taking your stomach tube towards the jejunum. Make sure your anastomosis is away from the previous staple line so as to avoid ischemia in the in-between tissue. And once that is done, the only thing left is to close this defect. So we usually close it with a 2-0 PDS running suture. We start from the upper end and then we start going towards the lower end. So we'll take a few bites from the upper end and then come towards the lower end. This is the lower end, and then tie it somewhere in between so both the angles are taken when the excess staples are removed in between. And then we'll just do a leak test by insufflating some air and then eventually close the ports. Right. Thank you.
Nice presentation, Dr. Jasmeet Singh Ahluwalia. As we are running short of time, I think questions will be taken at the end of the session. Thank you.
Our next speaker for the session is Professor Dr. Sheikh Sajjad. He's a professor, Department of General Minimal Access Surgery, GMC Baramulla. And the topic is laparoscopic management of gastric GIST, our experience.
Pendant.
Very good morning to all of you, respected seniors. I would like to start my presentation. It will be about minimal invasive approach for gastric GIST. Our experience from Medical College, Baramulla. One presentation has already been done on this topic. These are mesenchymal neoplasms of the gastrointestinal tract, cell of origin being the interstitial shell of Kajal. These are fibroblast-like cells located around the myenteric plexus and the muscular propria. Most common benign non-epithelial tumor of the gastrointestinal tract, 1% of all GI cancers and around 2.2% of primary gastric neoplasms. Stomach being the most common site, followed by small intestine and colorectum. For GIST involving upper GI tract, the most common presentation is GI bleed. It can be overt or occult. For GIST involving the lower digestive tract, constipation, bowel alteration, urinary retention are the frequent presentations. In pediatric population, GI bleed and with anemia is a frequent presentation. Diagnostic evaluation is done by upper GI endoscopy, CT for initial evaluation of the primary cause. MRI is done in cases where rectal tumor is the primary cause. Upper GI endoscopy with ultrasound and EUS biopsy is frequently done in cases who are not amenable to diagnosis. Colonoscopy is done for cases where the distal part is involved in colon, rectum and anal canal. And indications for surgical resection in these cases for the disease that cannot be safely biopsied when initial biopsy attempts have been unsuccessful or non-diagnostic. In case of unresectable and metastatic tumors, if it requires immediate surgical intervention due to hemorrhage, tumor rupture or bowel obstruction. GIST are soft and fragile tumors. The decision is based on the suspected tumor type and extent of the disease. EUS guided biopsy and FNA biopsy of the primary site is preferred over percutaneous biopsy due to the risk of tumor hemorrhage and tumor dissemination. Mitotic rate is measured in the most proliferative area of the tumor and is reported as the number of mitosis per 50 high power fields or equivalent to 5 square mm of tissue area. Most GIST express KIT receptors. Tyrosine kinase is found in around 80%. Platelet derived growth factor receptor tyrosine kinase in 5 to 10%, CD34 in 70%, smooth muscle actin 25%, succinate dehydrogenase deficiency, loss of function mutation in the SDH gene subunits or loss of SDH gene protein. Prognostic markers are tumor size, mitotic rate, and most widely used features for the risk of stratification of the gastrointestinal tumors. Tumor site also may have a greater role. Female sex is an independent prognostic factor. GIST with succinate dehydrogenase mutations are less sensitive to tyrosine kinase inhibitors and they typically arise in the stomach and are observed in young patients. Tumor genotype has been shown to be independent prognostic marker. Oral disease-free survival has been shown with KIT mutations and large tumor size and high mitotic index. Platelet-derived growth factor exon mutation has been shown to have a better prognosis. AGC tumor staging is T1 tumors less than 2 cm, T2 tumors are between 2 and 5 centimeters, T3 tumors are between 5 to 10 centimeters and T4 is more than 10 centimeter. Although the feasibility and safety of the laparoscopic approach of GIST resection has been demonstrated in many retrospective studies in European Society for Medical Oncology, NCCN and Asian GIST guidelines, laparoscopic surgery is suggested only for GIST in favorable locations such as those in the greater curvature or anterior wall of the stomach. The last 2 decades have shown the results for unfavorable locations like those of the lesser curve or the posterior wall of gastric body, fundus and antrum to determine the feasibility, safety and oncological outcome of laparoscopic resection of gastric tumors in these locations. Last 2 decades have seen more and more of such cases. Our experience, most of the patients belong to unfavorable positions like the proximal stomach, posterior wall of the stomach, antral region. Presentation was most common GI bleed, vague abdominal pain and early satiety. Diagnosis was done by upper GI endoscopy, CT of the abdomen, routine investigation to seek fitness for surgery were done. Patient position was spine, reverse Trendelenburg position, leg split. Port position was similar to upper GI laparoscopy with 10 mm umbilical port and 12 port in the mid-clavicular in the right subcostal region, 5 mm port in the left subcostal region and epigastric port for liver traction. This is one video of the upper GI endoscopy of this of one of the patient where we can see the GIST tumor. This is an video of the surgical procedure. Here we can see the bulge in the proximal stomach. The video presentation of the same case. Anterior gastrostomy being done. This is the tumor being delivered. Base of the tumor being, a stay suture being taken at the site. Since it was in the proximal portion of the stomach, Rise tube was inserted to see that we have not included the G junction. Stapler has been fired. Checking for any stapler bleed. Preparing the stomach for closure. Suture line bleed is being sutured. Since we are having paucity of time, so I am making this video a bit faster, and this tumor is being taken out in a polythene bag. Tube drain was placed later on. A second video of a similar case. Again anterior gastrotomy, tumor being delivered. Stay suture on the inferior aspect of the tumor, then staple stapler being fired at the base. This is the tumor. A similar case where no staplers were used is the post-op specimen. A similar case where no stapler was used. This is the photograph of the case where anterior gastrostomy was done, tumor was delivered, and the anterior gastrostomy was sutured without any stapler being used. Average time of the surgery was 2 hours and 15 minutes. Average blood loss was around 80 ml. Rise tube was removed on post-op day 2nd. Oral sips were started on post-op day 3rd. Liquid semi-solid diet on post-op day 4, and tube drain was removed after post-op day 5th. That's it.
Thank you, sir, for a nice presentation. As we have already said that the question answer session will be at the end of this session. We want to make an announcement that Dr. Afaq is conducting a workshop on basic life workshop down in the hall B. So people who have to join that, please go to hall B. We have our next lecture, which is an online lecture from UK. Professor Dr. Ghulam Nabi, Chair of Surgical Uro-Oncology and Breast Imaging. He will join after 5 minutes, and till that time, if anybody has any questions regarding first 2 presentations, they can answer. Sir, next speaker, Dr. Nisar Hamdani, has not yet arrived. So, it is just 5 minutes. He will join at 11 exactly. We have given him time for that. Dr. Jasmeet Singh, is he here? Dr. Sheikh Sajjad is here. If there is any question regarding this presentation on GIST, experience from GMC Baramulla.
Again, you have specific indications. You cannot do all GIST by laparoscopy. First of all is the size, second is the location, third is the presentation of the patient. For example, if the patient is having severe bleeding, it's better not to venture by laparoscopic approach. It's better to do an open. So there are specific indications for GIST. Most of the GIST that lie on the greater curvature extending into the G junction Again, it's very difficult to manage them by laparoscopy because most of the times it turns into a stenotic area later on, becomes difficult to manage. So once you do a laparoscopic approach, there are two main important approaches. Either you can go from outside after doing an endoscopy. It may not be necessary to do an intraoperative endoscopy. You can have even an intraoperative ultrasound. We're having that facility, you can localize it, or by the bulge, you will come to know where it's at. Second important thing is that you can have a pre-op endoscopies to localize the area so that the surgeons becomes easy for the surgeon to do the job. Now there are two ways to operate this. One, either go from outside the stomach. So you can do that also, you can do a sling resection, and another way is going inside the stomach, the way our worthy doctor has just shown you. So both the approaches are there, but one has to be careful that there is no leak.
Sir, we have got you. Thank you. We are connected.
Go ahead
Professor Dr. Ghulam Nabi.
Yes, I can hear you very well. How are you?
Welcome, sir. Welcome. And we know that it has been a little bit problems with the connection. Now we are on, sir, and we have already introduced you to the audience, and you can go ahead with your presentation.
Thank you. Thank you very much. So, can you see my slides on screen?
Yes, sir.
Yeah, thank you. Thank you very much. Apologize if I'm late a bit because it's just morning here. First of all, I'm grateful to Professor Nazir for inviting me to speak in this meeting. We always look for opportunities to connect with the place we have been from, and it's a great honor to be interacting with you. In the next 10 to 15 minutes, I would be speaking briefly about my journey so far, which may have some implications for all of you, and especially if you have students there, they may get some insight into what I have been through, and maybe that may be useful to them. Then I will talk about that how we use the anatomical basis for teaching surgical skills and how we have managed to generate some of the resources which can then be used for simulation, and what's the importance of simulations in transforming somebody like me who had no knowledge of surgery into a reasonably good surgeon. How you co-create knowledge and skills with working collaboratively with colleagues across different specialties, certainly interacting with people who are from basic surgical sciences. And that all has impact on surgical safety, and for which we all are committed to. And then briefly about how we can learn skills from other industries and use that in surgical training, and what the future lies ahead. I started my journey from Kashmir. I belong to Karna, where I was born. I graduated from School of Medicine many years back. I don't remember now. Fortunately, I went to 3 eminent institutions in India. First, I went to PGI Chandigarh, stayed there for a few months, and then went to All India Institute of Medical Sciences, where I did masters in surgery, and subsequently I spent some time at Sanjay Gandhi in Lucknow, and then came back to AIIMS to do my MCH in urology. And finally, for some reasons, I left India and started a new journey in United Kingdom, where I went through the surgical training, what they call certificate of completion of surgical training through higher surgical training scheme. Got into Germany and France, did my fellowship, and finally settled in Scotland for reasons which I don't know. So your life takes twists and turns which you have no control on. When I landed in Dundee, I was given a job of to start surgical training in laparoscopy and robotic and laparoscopy, for which I was trained. But besides that, they asked me to start an academic program at the School of Medicine in University of Dundee with no resources. I was told to bring up surgical research as well as establish teaching and training of undergraduate and postgraduates. Unfortunately, in the last 15, 20 years, we have been able to establish a Center for Medical Engineering and Technology, where we teach and train people not only from medicine, but also from biomedical sciences. And the last couple of years, we have been able to establish a huge training program with Republic of China, where 120 students from China would come and spend time for their biomedical engineering undergraduate. Then they would go to the postgraduate, do their masters in biomedical engineering, and then some of them will end up in PhD. There's a vibrant program with the Middle Eastern countries, including Kuwait and Saudi Arabia, to train people. Because one of the things which we lack in India is that we use all the equipment and stuff for surgical services which are made in Western countries, and we don't have that within our reach so that we could actually have control on production of these equipments which we could be using in our daily practice. But this brings a lot of revenue for which we can do the research and interact with industry to start what's called entrepreneurship. So this is a program which has been going on for the past few years and has benefited a lot of surgeons and trainees who come through the surgical training. But more important than that, we established what's called Dundee Institute of Healthcare Simulation. And we run around 65 courses in surgical training, which includes right from brain surgery to anything you can talk about in surgical skills. And this is now expanding into non-surgical skills. And I'll talk about in the next 5 to 10 minutes that how we have transformed surgical simulation into patient safety by developing skills. And then we transfer those skills from lab into surgical practice to make surgery as a safe specialty. You can see the distribution of the courses which we run across United Kingdom and across the globe. How I landed into this situation is because of strong link between Scotland and Kashmir. Kashmir's first allopathic medical center was started by somebody who was born in this place. And there's a hospital close to perhaps your medical college, which was established first hospital, maternity hospital in Kashmir by a Scottish missionary. And recently the football training has been imparted by Scotsman who has made Kashmir its home. And we are not ungrateful. We always return that back. And that's perhaps the destiny which brought me to this part of the world in order for me to teach them some surgical skills and do some research, including the patient services. And that perhaps was the reason that I established this program. This is a gentleman who is well connected with missionaries, had a robotic-assisted radical prostatectomy under my care 2 years back, and he's cancer-free as we talk today. So this is how the medicine is connected without boundaries, and this is one of the reasons that I have been now based in Scotland for the past few years. Recently, I would be moving to perhaps Saudi Arabia to establish a surgical simulation program as a training director. We have already procured a robot, and hopefully there should be some more opportunity for me to grow into this area. Why we need surgical training, especially for the healthcare workers, because if you look at the WHO, we need 11 million healthcare workers, which includes surgical workforce as well by 2030. Despite having a number of medical schools in Srinagar and elsewhere in the world, it's impossible to get that 11 million workforce trained in the next 5 to 6 years. So because we don't have the resources and we don't have no ways that we can achieve those competencies by these workers so that they can deliver the safe care, and how we can ensure that we achieve that goal. The only way we can do that is by having the simulations. And if you look at the training, what's a training? The definition of training is a process of learning skills which you need to do a particular job. Pardon, can you hear me?
Breathe out, blow in for 1 second. See, again, important clear responsibility.
For that, you need a training, you need a trainer, and you need a curriculum. So these are the three essential things which you need, and there's no doubt about that. Wherever you are training, whether you're training in Scotland, or you're training in Anantnag, or you're training in Srinagar, you need these resources. But the most important is that you need a model which is validated and perhaps similar to patients. And what are those models? And also the delivery of training has changed, because previously, if you were supposed to be trained as a surgeon, you just spend a number of years with somebody who is trained and get proficiency into your skills and knowledge. But that has gone away. Now we are more and more focusing on what's called competency-based training. That means we want to make sure that people achieve professionalism, employability, and that's for one reason that what I was trained 20 years back, I'm no more doing that. I was never trained in robotic surgery when I was in surgical training. I never did radical prostatectomy at R&D Institute of Medical Sciences when I did my MCH in urology. But now I do different things. So what you are training specialists today might not be doing the same surgery in 20 years from now. But what you need to teach them is into professionalism, employability, and ability to adjust to an ever-growing surgical field. So that's something which we need to teach them and achieve those competencies so that they can be safe surgeons, having a aptitude towards professionalism as well as ethics. Simulation is one of the ways by which we can generate those skills, both technical and non-technical. It's basically you imitate the environment of theater, outside theaters, and try to put these individuals into situations similar to what they would be doing in operation theaters. You can teach them skills, you can teach them non-technical skills, and you can also teach them, and then you can also assess them so that they can be safe when they start doing surgery. And one of the barriers to that is that you need to have models, and nothing can be as good as patients. And that can only be possible through having the cadaveric surgical training program. In the past, the cadavers were not available, so we resorted to having the animal tissue models. This is the model which we used in our center from the, it was used from cows, cadavers, and trying to get this anatomical knowledge similar to human beings, but it's not as close as it could have been possible. So we do need the models which are obtained through the efficient cadaveric program, and then those models are going to be used for human beings. If you look at the models which I had access to training in my days were mostly formaldehyde-based models, and it's extremely difficult. First of all, it's not attractive to walk to an operation to an anatomical dissection hall because of the smell you get from a distance. But also, if you look at those models, they are not even close to something by which you can teach a surgical training to obtain the skill and knowledge which is necessary for becoming a surgeon. And how we transform that in Dundee, and you can see it, this is the one which is the model which is available in most places within India and certainly in Kashmir. It's a formaldehyde-based cadaveric model where you can't even bend things. With the help of this lady who raised 15 million pounds through the charities, we established what's called teal cadaveric models, and you can see these are, you can bend them in any ways. They are very supple and they are very soft, and that's called teal cadaveric models. So how we achieved that, these are the models, so let's go ahead, yeah. And you can do endoscopies, you can do upper GI, lower GI, you can do cystoscopy. This is a picture where we have done a flexible cystoscopy examination, and you can see this becomes a news for people, and as journalists are very used to getting into places where you don't want them. You can see a BBC journalist present right in the simulation theater with me. What we do is we obtain the bodies, immerse them into tanks where you have an imbibing fluid, which is called teal cadavers fluid. And this is the resource which we have developed with the anatomy department, where these models are preserved for a couple of months into these tanks, and then they can be taken out and used for multiple procedures. And this is one of the model where we can put them through an endotracheal tube and intubate them, and then use just like patients. You can make them to breathe. And this was a big news in BBC recently, that living deads were something which we created in our center so that we can teach people exactly the environment which they would be exposed to in their lifetime as surgeons. This is a laparoscopic nephrectomy where we are doing it on the model similar to lifting the ureter, getting into the kidney, putting the ports, and doing laparoscopic surgery, which most of you would be doing anyway. But how you train somebody who has no knowledge of laparoscopy to become a safe surgeon, this is the perfect model which we have generated. One of the things which is essential is that they don't bleed. So if something doesn't bleed, it doesn't put surgeons under stress. And that leads to something which they become very complacent with. So if they do something nephrectomy on a model and would be, patting themselves that they have done a great job. So how can you make the model to bleed? We use the heart pump to put the fluid into the vessels when the surgeon is doing surgery. And if the clip is not going onto the right artery, that would start bleeding. So this is the functionalized model which we have created in our center. And if you look at the number of courses which we run, right, endoscopies, upper GI, gynecological courses, advanced surgical courses. So there's a huge number of surgical training based on anatomical models which are delivered from our center.
Am I audible, sir?
One of the things which we have, sorry.
Sir, your time is already up. We are all loving your presentation, but we have time constraints. Please try to conclude.
I'll wrap that up, yes. So 1 minute and I'll wrap that up. So we have gone into surgical trainings, and it has a huge impact on research and surgical trainings in terms of producing papers and publications. Finally, the surgical impact has gone into really areas where it's making huge difference. Of course, the virtual and anatomical laboratories are coming up, which would have another dimension to the surgical training. And the most important thing is that what's the evidence that if you train somebody in these labs, that person would be actually would get to trained as a safe surgeon. And there is a lot of systematic reviews and randomized control trials which are coming up supporting the surgical training and simulation. And these trainings then can help to reduce the errors during the operation theaters. Learning from other industries is essential for us to sustain our surgical trainings. As I said, that we are surgical, the repertoire of surgical trainings and is changing. So we need to learn from other industries, for example, aviation, military trainings and teams, and most importantly, from the industries we need to be in touch is the ones which makes instruments and equipments for us. In conclusion, we need to have sound anatomical knowledge in order for us to deliver surgical training, and there's no doubt about that, or there's no debate about that. Surgical simulation is essential for safety of the patients, and there has been significant improvement in production of models, and now we have been able to use those into our simulation program, and we have shown that has a huge impact on patient safety. The more future would be in data analysis, machine learning, and artificial intelligence. which is already being investigated as a tool to enhance surgical performance of surgeons within theaters and in their practice. Thank you very much, and sorry if I'm late about, delayed session. Thanks. Thank you.
With due permission from chair, I have slightly deviated from my topic. My topic actual was comprehensive management at a tertiary care setup in HPV unit, but I felt that will be too technical, so I tried to make a presentation which is more inclusive. I'll be presenting a brief overview and approach. Why to know about bile duct injuries? The significance of bile duct injuries, their impact on our surgical practice, and the patient safety. Bile duct injury are a significant cause of mental agony for the patient party as well as for the surgeon. It increases 3 lakh rupees. So patient has need for repeated hospital admissions, multiple interventions and or maybe surgery is needed. It decreases the quality of life. It is associated with increased litigation. In fact, it is reportedly the leading cause of medical legal suits at places where all medical legal cases are recorded. It has been found to decrease the overall survival if not managed initially properly. Liver resections, post-hydrated liver surgeries where liver resections are not done, or even surgical reexplorations, especially in a patient with infected pancreatic necrosis. So what are the risk factors associated with bile duct injuries? A complicated cholelithiasis with local inflammation like acute cholecystitis, post-ERCP stented patients, patients with acute pancreatitis, patients with Mirzi syndrome or short cystic duct. Anatomical variations which are more than a routine than an exception found in almost 40% or more than 40% of patients. Previous abdominal surgeries, emergency cholecystectomies, cystic duct stones, or enlarged liver, which we often see in our practice because of the prevalence of NAFLD in our area. Gallbladder cancer can also present as a difficult cholecystectomy, which will be causing difficulty during surgery. A biliary enteric fistula, or a limited surgical training and experience. There are various classification systems, but the most commonly used is Strasbourg's classification, which is based on site and nature of injury. It divides it into type A to E. Bismuth classification further subdivides E, is basically a structure classification from E1 to E5. There are some more modifications in the classifications which are not of concern in this presentation. So Strasbourg Bismuth classification is a very simple to follow classification, where in type A leaks we have a cystic duct leak or a duct of Laschkal leak. In type B there may be occlusion of the biliary tract, usually aberrant right hepatic duct or a right anterior or right posterior sectoral duct. In type C, there is transaction without ligation of an aberrant right hepatic duct. In type D, there is lethal injury to the common hepatic duct or the common bile duct. Type E is basically a benign biliary stricture with varying stump lengths from more than 2 centimeters to less than 2 centimeters to lack of confluence or the disconnected duct syndrome. You can appreciate that it is only type A, type C and type D where we will be having a bile leak. In rest of the biliary injuries, bile leak may not be present. Clinical presentations, it most commonly presents as bile leak, controlled external biliary fistula when the drain is in situ and we detect it postoperatively or intraoperatively, which may be uncontrolled when no drain is placed or the drain gets blocked or it gets misplaced. Patient usually presents with pain, fever or biloma or wound soakage. Acute obstruction of biliary tract like a clip across the common bile duct can cause jaundice and cholangitis in the immediate post-op period. Late complications, patient may present with strictures, recurrent cholangitis or liver atrophy, or patient may present with secondary biliary cirrhosis and portal hypertension with its sequelae. Initial management is very important. Stabilize the patient with fluid resuscitation, antibiotics, and correct fluid electrolytes if there is a significant biliary fistula. Better to refer the patient to a HPV surgery unit. Early referral to HPV specialists has been found to decrease morbidity and mortality. The dictum of our teachers when we were doing our MS training, put a drain and refer the patient, still holds true. Why do we need to refer? Because patient needs a multidisciplinary care for appropriate management. A hepatobiliary surgeon should coordinate the management. Interventional radiologist is needed to drain the collections or USG or CT guided, and a medical gastroenterologist may be needed for an ERCP. Unfortunately, in our practice, we see most of the patients getting referred to ERCP specialists. And ERCP specialists, without understanding whether this patient needs ERCP or not, first undergoes ERCP and then is decided about whether the patient has to be referred to surgery or not. In that process, the patient further accumulates the complications of ERCP. And a naive, non-infective system is rendered infective by the intervention of a ERCP scope. And pain, infectious management, and nutritional rehabilitation is needed in major biliary fistulas and even bile refeeding in very selected cases. Diagnostic workup, we have to do LFTs, while no need to mention this, that we find elevated bilirubin if there is an obstruction of the system. ALP and GGT will be usually raised. AST-ALT if there are associated cholangitis. Ultrasound, CT, and MRCP are needed in our armamentarium. ERCP or percutaneous procedures may be needed in selected cases. So, endoscopic and radiological management of bile duct injuries. I presented this slide before surgical management, so we get an idea about when to refer for ERCP. Indications are limited for ERCP. It is useful only when biliary enteric anastomosis and biliary enteric continuity is maintained, which can be seen in type A, type C, or type D injuries. Advantages that it decreases the bile output and it may hasten the closure of the fistula. Disadvantages and the overkill associated with ERCP, it may not be beneficial in all bile duct injuries or benign biliary strictures. It does not allow the intrahepatic biliary radicals to dilate, which may cause a difficulty for the operating surgeon when the surgeon is planning a definitive repair. It is associated with more difficult dissection at the time of definitive surgery, and risk of post-ERCP acute pancreatitis, bleeding and perforation leads to higher morbidity and mortality in a patient of bile duct injury. In ERCP, a stent placement or a sphincterotomy is needed, or a PTBT decompression may be needed if ERCP fails, if cholangitis is present in a closed system with a high stricture. Anastomotic stricture not amenable to redo hepatococygenostomy due to high location of anastomosis or a complex location of the complex nature of the stricture may be amenable to PTBDs. Surgical management, the gold standard for treatment of benign biliary strictures is Roux-en-Y hepatococygenostomy. The surgical challenge in this situation usually are we have to do an extensive adhesiolysis. There are adherent duodenum and colon in the right subhepatics area, which may add to further injuries. Identification of ducts is a challenge which needs good amount of expertise, good preoperative cholangiographic readings, and access to intraoperative cholangiography. Lowering of hilar plate definitely is a very, very important step, and getting adequate stoma and performing an adequate hepatogenostomy, which has its own criteria, is very important. In some difficult situations, we may need hepatoductoplasties when ducts are separated. We may have to do a stented anastomosis in high benign biliary strictures like E4, E5, undilated ducts, multiple anastomosis, or associated biliovascular injury, or unsatisfactory mucosal approximation. The stents are kept for at least 3 to 6 weeks to maintain the critical diameter of the anastomosis. Cholangiojejunostomies can be done in very high injuries, but for that we need a percutaneous transhepatic catheter. The catheter is crossed across the bile duct, and it helps in the intraoperative identification of the segmental or sectoral ducts. Access loop is needed in selected cases. Some centers do. At our center, we do in complex biliary strictures. And liver resection is needed in long-standing tight strictures, disconnected ductal segments with associated liver atrophy, with or without recurrent cholangitis. So managing a bile duct injury is not only doing an anastomosis with the bile duct and the rule loop. It involves all these and preparation for all these procedures wherever needed. Timing of surgery, it has been classically divided into early, intermediate, or late. Early repair is less than 6 weeks, which includes on-table repair. And early repair is usually not encouraged. Ideal timing for repair would be 6 weeks to 12 weeks. Minimal inflammation, when there is a minimal inflammation is settled, ducts get adequately dilated, the patient has been adequately worked up, and we know biliary anatomy, and if there is any associated biliovascular injury, that has been ruled out, because that has been seen with increased morbidity, mortality, and recurrent stricture rates in the repairs. Sepsis and cholangitis gets treated during that time, and general condition of the patient is better. Early repair has its technical difficulties, and patient is usually inadequately worked up, and it can be done in selected subset of patients only when we have an access to experienced hepatobiliary surgeons with fair experience in biliary surgeries, when there is no associated biliovascular injuries, when patient is not having any comorbidities. Patient is fit enough to be taken for a major surgery because the patient has been initially taken up for a lap chole. Lap chole is by and large a small, comparatively a small procedure, and the patient has to be now seen from the point of view of a biliary repair. When adequate setup is available, instruments are available, and anatomy is well defined. Late repairs defined as more than 12 weeks are again difficult, and it has been associated with secondary biliary cirrhosis, and we have to anticipate portal hypertensive changes, which is associated with difficult repair and increased bleeding. Late strictures can be managed if we have an adequate stump. We can redo hepaticojejunostomy, or otherwise PTBD or PTCs can be done. Take home message: bile duct injury is largely preventable. We must follow the principles of safe cholecystectomy. Bile duct injury requires timely recognition. If identified on table, stop and seek help, opinion of your colleague, whoever is available in the OT, or now with the advent of this social media, it will be an adequate usage of social media to seek an opinion or a video opinion from your colleague, which may not be sitting in the hospital. Do not add further harm to the patient. Primum non nocere. The principle still holds true, which have been written in our old surgical textbooks. If identifiable post-operatively, do not panic. Counsel the patient, discuss and refer to hepatobiliary unit, and do not hide information. Management of bile duct injury is not a single step, it's a stepwise process of stabilization, non-surgical interventions to recognizing and typing of bile duct injuries and ruling out associated injuries, and then planning a definitive repair for surgery, because first repair is always considered to be the best repair. During preoperative planning of a lab chole and intraoperative findings, identify the factors that potentially increase the difficulty of lab chole, either keep a colleague or do it in a better setup. There is no substitute for good dissection and identification techniques. And referral to hepatobiliary surgery centers improves the outcome because patient needs follow up for a long time. There was a consensus multi-society practice guideline published in Surgical Endoscopy in 2020 for prevention of bile duct injuries. Two very take-home important messages in this were that identification for bile duct injury should be stressed upon on table and immediate post-op period. And the strong recommendation is that bile duct injury should be transferred to the experienced facility or a team. Thank you.
Thank you, Dr. Nisar, for wonderful presentation on important and interesting topic, giving deep insight into the bile duct injuries and their management. Thank you, sir. Any questions from the audience? Okay.
Thank you.
Thank you.
We sincerely thank our respected chairpersons and speakers for adding scholarly contributions to this session. I now request Professor Dr. N.C. Dhingra to kindly come upon the stage to felicitate our chairpersons. Dr. Ravinder Kumar, Dr. Altaf Malik, Dr. Khalid Bashir, thank you, sir. Thank you, sir. You can have a seat.
Now I request Professor Dr. Ejaz Ahmed Russell to facilitate our speakers. Dr. Jasmeet Singh Ahluwalia. Professor Dr. Sheikh Sajjad. Dr. Nisar Hussain.
Thank you, sir. Proceeding with the third session of the day, which is the much-awaited guest lectures, I invite the esteemed chairpersons to preside over the session. Professor Dr. Ejaz Ahmed Rathar, Professor and Head, Department of Surgery, SKIMS Medical College, Bemina. Professor Dr. Mushtaq Ahmed Chalku, Dr. Kanchan Kaur, Oncoplastic Breast Surgeon, Medanta Mediconsult Center, and Dr. Zahid Mohammad Rathar, Associate Professor, Department of General and Minimal Access Surgery, GMC Anantnag. I request the chairpersons to have a seat on the podium and introduce the speakers.
We start with session third. So we have for the first speaker, we have Professor Mahmuda Khan. She's the honorary treasurer, Association Surgeons of India. Professor Madhu has come from all the way from West Bengal, and we are honored to be here, ma'am. So you have come all the way from West Bengal. So welcome you all here.
Thank you, sir. Thank you so much. So, good morning, everyone. Initially, when I was asked to speak on this, so I thought, let me speak about this, which is a burning topic. It was always there, but right now, let me just speak on this. So, about surgeons and ladies, there have been a lot of studies in the West, but there is always an Indian perspective. There is an Indian perspective to everything. So, in West Bengal, we had done a small study regarding the problems faced by the lady surgeons, especially the junior lady surgeons. And we came up with a different kind of result from the West. So my thing is to talk about the Indian perspective. Before I start, as the treasurer of the Association of Surgeons of India, I'd like to tell you all that we have a program known as the ASI WINS. ASI WINS is a mentorship program by ASI for lady surgeons, especially the junior trainees and the young doctors. WINS means Women in Surgery, W-I-N and S. So whenever there's a lady in surgery, I say it is always a win-win situation. This program is actually, there are a list of mentors in every state, and we have that in the ASI website. So if anyone has a problem or any difficulty, anything, if they need some advice or any mentorship, there are people who are there, and you can always check in the ASI website. Now, often I've been asked for a lot of days, it's almost 20 years since I've been in this profession. I've often been asked, say, what it is like to be a lady surgeon or what it's like to be a female surgeon. Now, if you think of this situation, think of the Department of Gynecology. They do surgery over there. Most of them, or a huge chunk of them, are females. But no one ever bothers that whether in the Department of Surgery, in the Department of Gynecology, no one asks them, how does it feel like to be a surgeon? But it is always there in general surgery. Or again, in another perspective, you hardly ask a male resident what it is like to be a male gynecologist. So say from 10 years, even 10 years from now, the things are fast changing, because till now we have almost in the medical colleges right now, we have almost a 50-50 ratio of girls and boys in the surgical residency. But this was not there when I was a resident. So it was at that point of time, when you first join a residency, surgical residency, it was almost like just walking into an all-boys club. Like you don't know how to face it, and they don't know what to do with you. It is always a bit of an embarrassing situation. Then it started, all this kind of talk, it started sometime after the post-COVID, when there was an article in one in the US and one in the UK, telling that female surgeons have better outcome. And then people started talking, different people, they had this kind of, they had their own opinions. People started talking about this. Even I remember my principal, he put it up in a WhatsApp group. What do you think about it? So people started talking about it. So just a bit about the studies what were there. In the studies what is there, in the UK study, in the BMJ, this is what they said. This is the European perspective. Almost a third of female surgeons report having been sexually assaulted. This was the point. But there was a catch to it, that 23.7% of male surgeons were also assaulted. So if you think of that, in that area, if the assault was a part, it was not much on females and males, both had their part in it. In a study in the USA, there were, by Katrina Hutchinson, there was these kind of things like workplace problems, gender bias, few other things which they thought that it was is a commonplace in their society. Now coming back more towards in our subcontinent, in Asia, there was a study in Karachi which said that 70% of medical students were women. In their medical association, it was found that 70% were female medical students in their MBBS, but a very small proportion entered the surgical specialty. The reasons? Family resistance, number one. Number two, they were shown a list of responsibilities that women have these responsibilities, and if you become a surgeon, you will not be able to do justice to them. And even if they managed to join the surgical field, they were subjected to gender discrimination. So this was a study from Karachi. Now back home in Bangalore, they said 40% of female surgeons were satisfied with their job. That means 60% were not. Now if you think of it, of the job satisfaction, in any field, hardly 50% are satisfied with a job. So even this is not a problem. But the sincere, a bit of problems was definitely delaying your pregnancy, the way they were treated at work, gender bias. So these were the things which were a subtle problem. So we did a small study in Bengal, which included junior surgeons and trainees. It was a bit different, rather quite different from the West. Over there it said gender discrimination, 60% said yes. Sexual harassment, no. So what I find from the Indian perspective, the harassment factor is not there. Postponing your first pregnancy, 90%. They were told not to become surgeons, 76%. Credibility issues were again there. So what are the actual real problems that we face? Small things. There are no proper restrooms. The scrubs, the OT scrubs are quite large, and it's actually made for a man. The gloves, again, it doesn't fit everything. Height of the OT table, those are problems. There are credibility issues, definitely. Availability of washrooms, again, that becomes a problem. So there was this lady called Jamie who had made a study, and she said the problem was oversized and overlooked. So the thing is the same thing as I was saying. Excuse me. It's like you have things which does not fit you, things which are not up to your height. So these are the subtle problems which we all learn to adjust. Then there are problems of, in the private sector, there is a discrimination in pay. Male surgeons tend to get paid higher. That's what I heard. I didn't face this because I'm always in a government sector. Then when a junior surgeon, you're posted in some periphery, the nurses, if there's an abscess, they call the female surgeon. If there is an appendix, they sometimes call the male surgeon. So these are the things that we gathered from the study. Now what are the actual thing? You're mistaken for someone else. It's always there. Suppose you're standing with 4 surgeon colleagues. You're always mistaken for someone else. Either you're the gynecologist, or the anesthetist, or the nurse, but you cannot be a surgeon. Another problem which I often faced earlier was, like when I was asked, where do you work? Okay, you're a doctor, what do you do? I say I'm a surgeon. First say, oh, surgeon means cesarean sections. So I had to tell them, no, it's not cesarean sections, it's like, it's gallbladder, appendix, that sort of. Then the next question, so where do you work? So I say it's a Diamond Harbour Medical College. Oh, it's a medical college, that means you teach. You don't do surgery, right? So again, it becomes a bit different. Like, it's very difficult to tell the people, the common people, that yes, I do teach, I do surgery, even I teach the male surgeons how to do surgery. So these are the things, and you're again always under scrutiny. Like, how are you working? When I was a first year resident, I remember a senior surgeon in Department of Gynecology, he was standing there, and one of my friends came and told me that he was saying that, I just came to see how this girl, what are the surgical skills of this girl. Now he has come from a department where most of them are female residents. He never bothered to think about whether a first year trainee had the skill or not. But when it comes to general surgery, you're always under scrutiny. I just put up this picture because depending upon the questions that you're asked. It's a picture of Lady Margaret Thatcher, the previous Prime Minister of UK, and her husband Dennis Thatcher. So Margaret Thatcher was once asked in an interview, what does Dennis Thatcher do, or what does your husband do for a living? So she had replied that, did you ever ask the British Prime Minister what his wife was doing? You know, whenever we have some sort of an interview or something, there are male surgeons and a female surgeon. The kind of question that we get is, the male surgeons are asked, what is the secret behind your success? Whereas the female surgeon is often asked, how do you maintain a work-life balance? Now, as if the males do not have a work-life balance at all. So these are subtle things which is still it's there in the society. Then there was this controversy about this chairperson of Larsen and Toubro who said that you have to work on Sundays, how long can you stare at your wife? So the common perspective is that gender roles, typical gender roles, on a Sunday the wife has to be at home. So that is taken for granted. Other problems that we face often, even I face these, when you go for your counseling, why go for surgery? Gynecology seats are available. Another thing is, which I often face, is people tell me, you're too nice to be a surgeon. Now, I take that as a compliment. You know, we are often told, be a man, talk like a man, have the mentality of a man to be in surgery, right? Okay. So when a man has that bold mentality, it says that this person is very bold, good. When the lady talks like a man, you have said that the lady is rude. So this is the way we keep on adjusting. We cannot be rude, but we have to be bold. So it's again a difficult situation. This is Dr. Snehata Deshmukh. She was the one and the only lady to be the president of the Association of Surgeons of India. After that, no one else has become a lady president. But even at her time, she was denied entry into Tata Hospital's surgical oncology program because she was a lady and she had to go into pediatrics. So, you know, this kind of discrimination was always there. This is decreasing. Slowly and slowly, these are decreasing. Another problem which ladies often face is there's no return to work policy in surgery. Like if you have a gap and you have to come back, you don't actually have something which will help you out of the situation. I think we need to have that. Till now, I was speaking of problems which can be adjusted, which we have taken in stride, which will soon go away sometime or the other when the gender ratio becomes same. It will become. This is the last problem I'm talking about. That's a biological clock. You know, this actually cannot be changed. At the time when the resident is doing her work, she's actively working. At the time when she's a junior resident somewhere, when she's a senior resident somewhere, and that is the actual time when people of her age are actually starting their families. And this is the biological clock, and this is slowly, it keeps on ticking away. So this is one problem, this is one genuine problem. Other problems, you don't really have to bother, that will soon change. So these things are something that you need your family support, your friend support, your colleague support. This is one problem which is always there. You are guilty that you're not giving adequate importance to your career. Again, if you give a career importance, you're guilty that you're not giving adequate importance to your child. You're not a good mother. So again, there's always that guilt-ridden conscience is there. All said and done, let me tell you, I'm not telling things about a male surgeon. See, I'm here, I'm a surgeon, and I'm on this podium today because of a male surgeon who once told he's no longer alive, but he was the person who first gave me an idea, yes, I can be a surgeon. So I'm here because of a male surgeon. That definitely is there. And there's definitely light at the end of the tunnel. Earlier in our times, it was like this, a lady and lots of residents, male residents, you are always under scrutiny. Right now, the time is like this, equal ratio, no gender discrimination, we are all equal and friends. Thank you. Thank you so much.
Thank you, ma'am, for your wonderful talk on the female. This is the era of female empowerment at present, and it reminds me of my teacher and teacher of my teachers, Professor Mahmuda Khan, who is a living legend at present. She headed the Department of Surgery for more than a decade, and just 3 decades back. and she was an age surgeon, strict disciplinarian. We all are taught, and there's a session of oration just of this session. I wish if you could attend that before leaving. So thank you very much.
Now, I know there's paucity of time, but as a female surgeon sitting here on the podium, I must congratulate you on a wonderful talk. I did my MS General Surgery from Jammu Medical College, and 2 of my revered teachers are sitting in the audience. We were a batch of 8 doing post-graduation in MS surgery, out of which 3 were women, 2 were girls from Srinagar. And we were never meant to, or never led to feel like women in an all-males club. So that goes to my teachers in Jammu Medical College. And you're right, you know, there is light at the end of the tunnel, but it always was there for a lot of us. That's why we're sitting here. Thank you. Now we will invite.
Can I make some comment? Just small comment. Madam was mentioning about Dr. Snehlata Day-2. I know her personally. She has been a very dynamic surgeon, dynamic person. She remained head of Department of Pediatric Surgery, and she was President of Association of Pediatric Surgeons of India, ASI. And she was Vice Chancellor of Maharashtra University of Health Sciences. I happened to meet her personally, a wonderful person. And then I think there was another lady surgeon from All India Institute of Medical Sciences. Dr. She's no more, Dr. Rohtagi. So she was from Bengal, and she was another dynamic person. And I think we have been seeing there is a rise of female surgeons, in spite of having so many difficulties. And the last difficulty which you were mentioning, I think that is really very has to be seen from a very compassionate angle, not as a fathers, not as a surgeons, and as a human beings. That is the basic need of this. I congratulate you for such a stimulating lecture. Thank you very much.
Now we will invite our next speaker, Professor Ijazaman Malik, sir. Professor and Head Department of General and Women Surgery, Sickness. His topic is evaluation of thyroid surgery and sickness, a journey from past to present.
A very good morning and warm welcome to all the people here, respected chairpersons, senior faculty members, and other august gatherings sitting in the hall. First of all, I thank the organizers for giving me the opportunity of having a guest lecture here regarding thyroid. This is the area which has been least touched by most of the general surgeons everywhere. And I thought today this is the right forum of the state where I should try to make possible to have a glimpse of the endocrine surgery being done in our UT of J&K. The reason why we are trying to go and advance the thyroid procedures is that, number one, it is a department is existing in our institute. That's a division of general and minimal invasive surgery as endocrine and breast surgery, where we offer MCH program. To some patients I have seen, because this is the most high volume center for colorectal surgery and endocrine surgery, and I am finding some patients are moving out. And third thing, this has not been done in any academic institute in the UT of J&K. And fourth thing, it's really beneficial to the patients where you use laparoscopy in these patients. They don't get a scar in the neck. It is very nice for the patient's outcome. It has a fast track strategy, and it reduces the overall burden to the hospital from effect of cost effectiveness. We know introducing thyroid right from the past up to present, there have been so many advancements. Initially, it was said that no person should tried to do thyroid surgery in 1805, that's Samuel David Gross. But later on, there was no-go area which was declared a conservative limited resection, and nowadays a total thyroidectomy and then approaching the thyroid by minimal invasive procedures. That's robotics and rabbit. Rabbit is the robotic way of doing the thyroids. The father of thyroid surgery is considered to be the Theodore Cocker. Everyone must be knowing it. He radically changed this approach and the perspective of using thyroid surgery. Now, there was progressive advancement in thyroid surgery from 19th and 20th century and mid-20th century and late 20th century, different ways of diagnosing the thyroid problems came into play from the pathology, nuclear medicine and others. And ultimately now in 2025, we have advanced to the management of applying the minimal access approach, the laparoscopic approach, that is the endoscopic ones. These can be done right from the mouth, that's the totua or mevat, and the pure endoscopic remote. There are various indications, as all of you must be knowing, for thyroid surgery. You can do a hemithyroidectomy, you can do a total thyroidectomy depending upon the disease process, depending upon the risk stratification criteria, and you choose the procedure accordingly. Now, there is a shift in management of DTC, the differentiated thyroid cancers, especially, which was initially being done a total thyroidectomy, but now the approach has changed, even hemithyroidectomies, according to the risk stratification criteria, pre-op and post-op, using masses. The traditional open thyroidectomy, most of the senior colleagues sitting here must have done it. There is a standard transverse neck incision, that's a Cocker incision, always visible. Direct visualization of the thyroid and the vasculatures. Then excellent exposure and suitable for all cases, but the disadvantage is being the visible scar and risk of complications, especially the recurrent laryngeal nerve and spirolaryngeal nerve, and hypocalcemia, very important for overall outcome and the presence or absence of complications postoperatively. We at SKIMS have been doing this procedure for more than 3 decades by our predecessors also. There has been a shift of using sutures to the Mitchell's clips. Senior colleagues must be knowing here what Mitchell's clips were. Then later on, a sutureless thyroidectomy, where we do not use any suture material in the thyroid because it has been associated with higher rates of complications, especially the nerve injuries and the disease recurrence, because you take good folds of thyroid tissue into the sutures. There are various studies that we have done. I have just added the recent 2023 up to this. This is a sutureless thyroidectomy in a PubMed journal. Another one where we had a comparative analysis of sutureless and conventional thyroidectomy, again a PubMed journal. Then a thyroidectomy with or without drains, that has been used, again a comparative study. Then a lateral approach to the thyroid, where this is an alternative for thyroid reoperations especially. And using the molecular diagnostics and genetics in thyroid surgery, we have not been behind, and we have presented good papers in world-renowned journals. Latest, this is one of the hemithyroidectomy where we have found a safe bet for differentiated thyroid cancers. This has been again published in Indian Journal of Surgical Oncology, which is again a PubMed journal. There are various types of surgeries. We do advanced procedures, the various types of neck dissections, coring, total cuts, SLNDs, and others. Now, there has been, as I have told you, an evolution towards minimal access approach, that's application of laparoscopy. We have advanced most of the procedures in our department. This was lagging behind, and I thought it's better to venture into this area also. There are various procedures. The MEVAT had initially got some hope, but later on, because of the vertical scar in the neck, it again was not to be done, not acceptable to most of the patients. Then the transoral thyroidectomy, again a very good procedure in different centers, but the most important problem in these patients is not to have a good post-operative period. They get a lot of edema because, you know, mouth, lips, mucosa, it's very sensitive to trauma, especially if we are putting three trocars from the labial end. This is the transoral thyroidectomy. Now the endoscopic thyroidectomy, which I have found to be very nice, we have done good number of procedures now. We go through the cervical, axillary, breast or retroauricular approaches, but we have chosen only the axillary and breast approach. Here you have hidden remote scars, and this is better acceptable to the patients and public. There are countries like Korea where a scar on the neck is considered to be a bad omen. And I have found so many young girls having big benign nodules in thyroid who are unmarried and want to get some form of relief in form of a remote access surgery. Definitely it is technically challenging, it needs a learning curve, and initially takes little more operative time, as it is evident in other forms of new procedures. We have also modified the technique of endoscopic thyroidectomy in a way that I'm using the conventional laparoscopic instruments and without using special retractors that most of the centers use. And this study we have done now, and we have also sent it for a publication to a PubMed journal. It is under review, and let us see what is its fate. There is a rabbit, that is robotic assisted thyroidectomy. Again, a good procedure, but little costlier, and it has a high cost with a longer learning curve, and it is not ideal for large tumors which can be managed by endoscopic way. Current trends have been an emphasis on scarless and minimal invasive approaches. They have involved a high-risk open procedure to a safe, cosmetically favorable technique, but the patient selection remains very important before subjecting such patients to this procedure. This is one of the patients recently on 12th June I have added this video here. It's a different diagnosis, was follicular edema of right thyroid, unmarried girl of around 18, 19 years of age, where we performed a right hemithyroidectomy. We use the working ports. There is 5 mm port as the camera port. Later we can use a 5 mm camera also, because we have to take out the specimen from the 10 mm port. These are the incisions are exactly in the anterior axillary line, thus in the breast fold, the breast mold, and one 5 mm port we use in the perialveolar region of the breast. This is the entry where you have to be very careful. You have to localize the thyroid, you have to localize the various points which we mark. This is the, these are two 5 mm ports and the 10 mm port. The most important thing once you dissect this area is to remain in the exact right plane, to have the subpalatesimal plane. Now this takes little bit of experience, because once you are well versed with the open surgery, you can easily go into these planes. But if you go into a wrong plane, that will be devastating. You have to see the clavicle, you have to see the suprasternal notch, and try to enter the neck, and try to find the sternocleidomastoid, SCM. Nature has provided us with two heads, both a sternal and a clavicular head. We try to go in between the two heads. We can go medial to the head, or we can go lateral to the head, but in between the two heads, it has become easier. Now here you have to localize the dissection and remain in the subpalatesimal plane. Try to find the strap muscles, that is the sternothyroid, sternohyoid, omohyoid, and the other muscles there. The deeper muscles need not to be cut. We have to just open this area, try to remain in the capsular plane. This tries to help save the recurrent laryngeal nerve and the parathyroids. Now this field is usually bloody, if not an experienced surgeon, because muscle, everywhere muscle. So you have to be very careful, have an energy source, try to go to the lateral area and try to use harmonic for the middle thyroid vein. That gives access to the inferior pole which you have seen just now, separating the parathyroid, then go into the tracheal area and remain just on the trachea, removing the isthmus right up to the superior pole. This is the superior pole done last of all, which is exactly reverse to the usual thyroidectomy. And here we come inferiorly just to avoid the ligament of Berry, the area where the recurrent laryngeal nerve enters the larynx. This is the area very important which you have to cut, and here you can preserve the recurrent laryngeal nerve. Next comes the parathyroid, superior parathyroid. Again, these are the strap muscles area which we have not been able to dissect initially because the thyroid was not mobile. So we use energy source there, remove these strap muscles from the superior pole, try to localize them. Here, neither you have to be too far nor you have to be too close, in between the two, and remove the superior pole as well. This is the specimen which we later change and take out from 10 mm port. These are the two sternocleidomastoids. This is the tracheal area, and then the parathyroids here and recurrent laryngeal nerve, which are posterior and are saved. We usually put a JB drain here because a hematoma in this site can be very, very dangerous. This is the 4 months after surgery where the patient is very happy. Most of the people who have found nice results, and I request all the laparoscopic surgeons here try to venture into these areas because our patients also need such care for management. Thank you very much.
Thank you, sir. A nice presentation and nice video also, sir.
Let's start this. I had bronchial surgeon on the previous. Probably venture bronchial surgeon. It is bronchial surgeon.
Not audible, sir. Not audible, sir. Sir.
I say thyroid bronchial surgeon only.
Yes.
It was not taken by ANT people, but in 80s or early 90s, it was taken by ANT people now. And I am sure now will be back to surgeon again for thyroid dissections. Thank you for the nice presentation.
Thank you very much.
Sir, actually in CKMS there is no competition in the ENT department, but in JVC we have. So we get 50% share as of now, but they have taken most of it. And because patient is the next problem, they mostly land up in the ENT department.
But most of the referrals we are receiving from all the corners because we're doing good volume of adrenal surgeries, we're doing good volumes of parathyroids, we're doing good volumes of pancreatic tumors, we're doing good volumes of thyroid. So that's how you get a lot many patients. And I have found, a simple, this procedure costs around 5 to 6 lakhs in Delhi. It's very, very costly. So taking everything into view, and because our course was going on, I found it's better to start this procedure here because it's good for the learners also. We are having already 3 batches of MCH there. And we have a minimal access fellowship and a colorectal fellowship also going on there.
Professor Malik, that was an absolute delight. What a comprehensive presentation.
Thank you
so much. The next speaker, Professor Dr. Karun Mittal, who's Vice Chairman and HOU Senior Consultant and Professor at RIPMA. I think he's going to be coming online and he's going to be talking about redo fundoplication.
Zahid.
So while the online presenter comes on, I had a little question for Professor Dr. Malik. Sir, being a breast surgeon, I was quite intrigued to know which plane you take when you put your ports through the breast. Is it in the glandular pectoral muscle interface? Are you on the, or are you going through the breast tissue?
No. We are making a subcutaneous plane, right? Then we try to keep the pectoral muscles and fascia down. okay, reach this clavicular area up to the clavicular fascia. Once we enter the neck, we try to remain in the subplatysmal plane. So this avoids the dangerous areas also.
How do you manage subcutaneous emphysema? Is it not progressive?
It's not a problem. Not a problem. I have not found any problem in any patient.
Any other question to our next speaker will take 2-3 minutes. Professor Fazil has a question.
I think what I wanted to convey that probably many things we have left on our own, like the thyroid surgery. That's why it is being taken by others. Our department at SKIMS never stopped doing thyroid surgery, and after Ajaz created the division of endocrine, I think this is the way to grow ahead in a particular field. Once you go with a particular interest with divisions, this is the way forward. And I must congratulate him. There are very few people in the country who are doing laparoscopic thyroidectomies, and he is doing a wonderful job, and even Professor Munir, who is the other person, they have really taken it far ahead. But yes, congratulations for that.
I would like to inform why did it happen that thyroid was lost. The problem was that we were sending for indirect laryngoscopy. So that was the reason that they were getting diverted from there, and now the time has come, like in our hospital we have a very strong department of ENT. Now they are not even coming to the surgery. Okay. So that is the reason, because, but still, Unit 2 headed by Professor Shakil and Dr. Rajan, they are doing an excellent job. Thyroids, parathyroids, and lap adenectomy is a common procedure in our place. Even lap pancreas is something. It's only laparoscopic thyroidectomy is not being done. Well, I hope that my juniors take it up as a challenge, because now we are going to fail that where I don't want to have any problems.
About the thyroid surgery, I'm not against ENT surgeons. It is their baby also, but only I will request them to be opting only the benign cases. Because once you manage DTC, that is differentiated thyroid cancer, and medullary cancers and anaplastic tumors, which are very rampant, I tell you honestly, and young people are affected by differentiated thyroid cancer, because of being there. I see so many patients that it really becomes very hard to manage them. Most of the times, everyone tries to have this facility under one floor, under one roof, rather. You have a preoperative first management strategy, how to do it, pathological backup, radiological, advanced radiology. Then second thing, a good surgery. Third thing, you need to have a nuclear medicine department where gamma camera should be there. Then fourth thing, the availability of radioiodine, which is not present in every center in India. There are only specific centers in India where radioiodine is available, both for the diagnostic as well as the therapeutic approach. Because no chemotherapy works in DTCs, no chemotherapy works in medullary carcinoma thyroids. So I think this should be always with the endocrine surgeons. What I have found in good centers like PGI or SGPGI, KGMU or Vellore or Madras Medical College, I visited all these places. They have a complete set of management protocols for these patients, which I'm trying to introduce and carry on in our institute as well. I am myself a nodal officer of the State Cancer Institute in SKIMS. So I try to stratify patients in a way that they are being best managed in our center, whether they belong to GI malignancy, they belong to other malignancies, hematological, thyroid, and others. I think that should be the approach, because a patient should get the facility of management at one place in the best possible way, in the best possible hands.
I have a question, please. Can I ask a question about parents?
So, you mentioned about, I'm an ENT surgeon working here, so we are doing thyroidectomies. So, what's the issue? What's the problem when an ENT surgeon does a thyroidectomy?
No problem. I have told you first sentence. I have told you that you can manage. But you see, I think people from ENT should be more concerned with. There's a big chapter on ear. Then you have nose. Then you have throat. Why should you venture into areas which are of least importance to you?
So we're dealing next. So it's all
You see, you have supra-hired area. No endocrine surgeon touches that. So you should do that. Right? Parotids you should do. Submandibular pathology you should do. Salivary gland pathology you should do. See, these are the areas which have been cut off. There's nobody is, there are ENT surgeons I have seen managing DTC in the best possible way. There are even senior surgeons and so many insurers who are managing it. Nobody can deny that. But I think what Fazal Saab was just now telling you, it is better to diversify in areas where you try to give the best care. For example, in ear, a person in ENT, a group of ENT surgeons can manage simple ear pathologies. I think they will become masters one day. Similarly, a group of ENT surgeons managing nasal areas. I think they will become one of the best surgeons, one of the best groups in managing such pathologies. Diversification is a must in a broader perspective. Please.
So the approach you just so videos, it was a wonderful video, sir, where you did this laparoscopic approach. That is one different thing that you do. Otherwise, the approach is the same. We approach the neck for neck dissections. We can do the thyroid in the same way.
You see, my dear, we have a surgical oncology department also. Okay, they are also managing neck surgeries, including DTC and medullary carcinoma thyroids. But even I have seen over a period of time, even from my surgical oncology department in SCIMS, they are also referring patients to us because they remain now concentrated with their own areas. They are doing neck, they are trying we had a neck surgeon who has unfortunately left, you must be knowing him, but he was doing commendable job. I appreciated his efforts of doing so much value. Yes, of course.
We are sorry for the delay. Our next speaker is online, just is connected, take 1 or 2 minutes. So please.
You see, overlaps are everywhere. We have surgical gastroenterologists here. Even our students are here. There are fellowships from minimal access surgery doing surgical gastroenterology. Then there are general surgeons doing surgical gastroenterology. Okay? Senior as well as the new people. So you cannot stop anybody. Once you are well versed with a particular procedure or a particular period of time, you are trained, there's no problem. But diversifying is not a problem. What is there in it?
Boss,
कोई किसी को कुछ खाता नहीं है.
If you are doing it, continue doing it. There is no problem. Sir, now it's getting late. Do it afterwards because orations are an important part of the. Tell him to do it afterwards.
So I think we start with the next oration session now because we are running short of time, and we'll do the oration and lecture after this.
A heartfelt thank you to our chairpersons and speakers for a thought-provoking session. Your presence and wisdom have truly elevated the discourse. We kindly invite Professor Dr. Nisar Chaudhary to felicitate our chairpersons with the token of appreciation. Professor Dr. Ejaz Ahmed Rathar. Dr. Kanchan Kaur. Dr. Zahid Mohammad Rathar. Thank you, sir.
Now I request Dr. Tashi Motab to please come on the stage and felicitate our speakers for this session. Dr. Tashi. Professor Dr. Madhumita Mukhopadhyay. Professor Dr. Ejaz Malik.
Excuse me, sir.
Thank you, sir.
We have concluded the sessions up to this point, and they have been immensely impactful. As we move forward, we warmly pass the proceedings to our next host, who will steer us into oration lectures. Thank you.
Good afternoon, respected delegates. We hope you had a delightful experience so far. We shall now begin with the oration lectures. For Professor Dr. Mahmuda Khan oration, I would like to invite our chairpersons on the dais. Professor Dr. Nisar Ahmed Chaudhry, former head of the Department of General and Minimal Access Surgery, SKIM Saura. Professor Dr. Rukhsana Najib, Principal, Government Medical College, Anantnag. Professor Dr. Ejaz Ahmed Rathar, Professor and Head of the Department of General and Minimal Access Surgery, SKIMS Medical College, Bemina. And Professor Dr. Madhumita Mukhopadhyay, ma'am, Head of the Department of General and Minimal Access Surgery at Diamond Harbour Medical College, and the Treasurer to the Association of Surgeons of India.
कितने बजे?
Now, I would request Dr. Ejaz Ahmed Rathar, President Jakasi, to kindly invite the speaker.
We have the oration on a living legend, Professor Mahmuda Khan. I think there cannot be a better person to deliver the oration than Professor Fazal Q. Pare, who is one of the founder members of Jakasi and who has also worked as a Sanjay Kumar. So I'm sorry, Dr. Sanjay Kumar Basin, he's one of the founder members of Jakasi, and he's professor of surgery at Medical College Jammu, and he has been the past president of Jakasi also, and this was in the presently he's in the council of Jakasi at all India level. He's president Jakasi also. So he'll be giving the oration. I think we should start with the introduction of Professor Mahmuda Khan. Can you please run the slides? Professor Mahmuda Khan is born on 23rd of December 1934 in the capital city of Srinagar. She graduated from Lady Hardinge Medical College, Delhi in 1956, got married to Professor Sayyid Zuhur Ahmad in 1959. She did her house job and registrarship from the same college till 1960. Then she chose to be a surgeon in spite of being best outgraduate student in gynae and obstetrics. Going against the tide and strong willpower, she came from a background, from army background, was the daughter, has been the daughter of Colonel G.A. Khan. She specialized her training in general surgery and got trained from Temple University, Philadelphia, USA. Did her FRCS from England in 1967, then FRCS Edinburgh, UK in 1967, did her fellowship in International College of Surgery in 1978. Then she worked as a locum in UK hospitals from 1964 to 1967, the time I was born. She has been the senior assistant professor at Albert Einstein Medical Center, Philadelphia University, USA from 1967 to 1968. Then she returned back to her own state in 1969 and joined as associate professor in the Department of Surgery in Government Medical College, Srinagar, and worked there from 1969 to 1973, and as professor from 1994 to 1998, and professor head from 1980 to 1993 when she superannuated, and she is still in her practice at present. She is a doyen of surgery. She is a soft-spoken lady, a strict disciplinarian, taught innumerable surgeons who have been the teachers and even who have retired from the teaching services at present. Then she operated on all challenging and complex surgeries. She is an excellent teacher, teaching skills with artistic surgical craft. So she has been named as a rose because she has all qualities which a rose, the fragrance and the beauty. Working with her would send shivers through the spine. Dr. Fazal must be knowing very well. He has worked for 6 months as a house job did with her. I have been her student also, and my teachers are here, Professor Salru. They have been her postgraduate teacher, student, sorry. I have been the undergraduate teacher, student of Professor Mahmuda Khan. Listening about her from Galaxy of Surgeons made us feel proud and fragrant like a rose. She is blessed with 3 kids. Her daughter is in US at present. Her son is presently heading the Department of Critical Care in Delhi. Her husband, Professor Sayyid Zuhur Ahmad, has been the ex-principal of Government Medical College, has been also been the director of Sher Kashmir Institute of Medical Sciences and ex-officer secretary. He has been a par excellent physician with a humble human being. May Allah bless his soul. He is no more with us. Madam sees her outfilled dreams fulfilled through her kids, grandkids, and her students. May Allah Almighty keep her in sound state of health and gift her with Sukuni Kalb. Ameen. Thank you very much. So I request Professor Sanjay Bhasin to come to the rise.
जब मैं क्लास लेता हूँ तो मुझे तब भी मज़ा नहीं आता जब स्टूडेंट्स क्लास में कम हों, और ये तो वन ऑफ द प्रेस्टिजियस लेक्चर्स और ओरेशन है। इसमें जो बाहर लोग बैठे थे उनको अंदर आना चाहिए था। बेसिकली थ्रू ओरेशन वी आर एक्सटेंडिंग आवर ग्रेटिट्यूड and respect to the doyens. Esteemed founding chairman of J&K State Chapter of Association of Surgeons of India, the national leader, honorary treasurer Dr. Madhumita, principal Anantnag, my dear friend and incoming chairman Jakasi Azaz, galaxy of surgeons sitting in front of me, Professor Naseeb, Professor Fazal, Professor Ajaz, my very dear elderly friend, Dr. Salru Sahab, my dear close friend Iqbal Salim, who is outgoing chairman, dear friend Wakar Sahab, treasurer Shamsul Bari, Honorary Secretary Harvinder, and all other galaxy of surgeons delegates. Very good afternoon. Before embarking upon my subject, I am confident that Jakasi, while choosing me for this oration, had gone through the guidelines, and after a consensus, they have chosen my name. For that, I am thankful to the Jakasi and thankful to the Jakasi Khan. My influencers, my mentors in my life, my father, who died very early, Buddha, who taught human beings the principles of liberty, equality, and fraternity, the international icon, started his journey from a very, very humble background and went on to become international icon and the father of Indian Constitution. My mother, who is still alive and inspiration. My first HOD when I joined as a PG, Professor Kapoor. My mentor and guide, Professor J.G. Langar. Another mentor, Professor Goswami. Another mentor, Professor Shittal Singh, whose daughter, intelligent daughter, is sitting here. My elder brothers and friends, Professor Sarab Saab, Professor Naseeb Saab, Professor Tariq Azad Saab, and there are so many influencers in my life who have shaped my journey. I am a very aggressive person, but I have learned something from all these people, including my founder chairman, Professor Nisar, my very dear elder brother, with whom I was secretary for 5 long years of association, Professor Fazal, and all other people. Even from my dear friend Iqbal, I have learned so many things. How to be patient, how to smile actually. So thank you very much, my mentors, my influencers. It was difficult choosing a title. When my friend Nazir told me 10 days back that you have to deliver Professor Mahmuda Khan oration, first I thought, am I capable to deliberate upon an oration which is of a doyen of doyens and which is a lady, which Dr. Madhumita was saying. And for disclosures, lady surgeons, they have contributed a lot in surgical specialty. And the first lady surgeon of India was Dr. Mary Ponan Lucose. She came back to India in 1916 and she was basically an obstetrician, but she went on to become chief surgeon of state of Travancore. She did gynecology, she did obstetrics and general surgery also. So choosing the title was a difficult thing. When I began my career as a surgeon, I was enthused with this aphorism, bigger the surgeon, bigger the incision. But minimally invasive surgery had involved. I thought my next frontier, and before I demit the office as a surgeon, I stopped practicing general surgery. and laparoscopic surgeon shall be the final title. But 10 years before my retirement, robotics started knocking the doors. Technology and innovations are unending and they are core of medical services. Last frontier can never be achieved in medical sciences, more so in surgical sciences. It is with this spirit of wonder that I decided to develop upon and investigate into the topic with sole purpose to dedicate this talk of mine to one and only, the living surgical legend. He did not mention my name anywhere, and neither he presented me that book. He's a dear friend. That is just a joke. So I would like to dedicate few of the pictures of mine, my surgery. There are more than 2,000 pictures, but few pictures which Professor Mahmuda Khan, if present here, would have definitely liked them. So, giant ovarian abdominal masses, so many, 50 cases reported, Rapunzel, all are doing all these things, but just a gesture to the living legend. She was a dynamic conventional surgeon. Breast tumors, many operated, giant phyllites, biggest phylite, you can see 7 inches knife, 7 years in the duodenum, 20 years back. It was a nightmare for me while operating upon that patient. Giant perpusal cyst, smaller one and bigger one, almost 4 into 4 centimeter. Foreign bodies, counting for others but silently. We never criticized any other person, but I say we should never. Hernia laparoscopically done, but mesh removed, gauze removed. One picture, gauze presentation like this as a swelling in the abdomen. Another story of gauze, then hemicolectomies, nephrectomies, everything done. Large jejunal GIST, biliary ascaris. Second picture, black and white, is the ascaris coming along with the tube. We put in tube and dermatofibrosarcoma protuberance. I have a series of 10 rare locations and it is printed, published. Rare situations, bilateral petal triangle hernia, big hernias. And the third picture is a liver abscess presenting like this. Mucosal of the appendix, big ones, sebaceous gland, tumor, a rare proposition, huge plexiform degeneration in neurofibromatosis, devising a small incision. And this is a single unit data which one of my PGs was presenting, and I am more than confident that the digitalization was not available at Professor Mahmuda Khan's time, but this is the beauty of digitalization. It can be used for research, it can be used for mortality meetings, anything. And it has a legal importance also. Thing was available in ancient and medieval time. These are some of the tools. If you look at these tools, they in fact are newer tools, they are replica of these tools. Only a little bit of design has changed, but they are tools of ancient and medieval times. Surgery was basically established during 19th and 20th century before surgeon being established as a specialist and surgery as a specialty. There was concept of subacute surgeons, and surgery was revolutionized thanks to knowledge of human anatomy, control of hemorrhage, hemostasis, abolition of anesthesia, sepsis, antisepsis concepts, and more antiseptic ORs. But the most consequential achievement by surgeons during the early 20th century was ensuring the social acceptability of surgery as a legitimate scientific endeavor and the surgical operation as a therapeutic necessity. This was the biggest achievement before technological advances. Diagnostics, convenience of 24 hours, nursing, OTs, and so many things, they made the things easy for today's surgeons, and the biggest role is of anesthesia and the antisepsis. World War II, after World War II, we saw a lot of innovations and these things. And from 1920 to 1950, plethora of surgeries were done in all the cavities, be it thorax, be it abdomen. Whipples, one time the captain of surgery, it was said 25-30 years back, whosoever has done Whipples is a very good surgeon, and whose Whipples survives for 1 year, he is an excellent surgeon. But now Whipples is a very small surgery. One thing which I have noticed is that minimally invasive surgery has gone hand in hand with the open surgery. The minimally invasive surgery concept dates back to era of Hippocrates. The first description is reported in the era of Hippocrates. 79 AD and then 1865 endoscopes and other things. And these are the people we must salute. These are the real heroes who paved way for laparoscopic surgery. How? From after Hippocrates, it was Maximilian who introduced this system of, you can say, lightning system. George Kelling, he introduced cilioscopy. Hansen Christian Jacob, he did laparoscopic and thoracoscopies without implying pneumoperitoneum as back as in 1910. These are these things. When actually the modern surgery started, it went into disrepute and severe criticism. And the two people who faced severe criticism were, one is Muhe, who did first laparoscopic cholecystectomy. He was imprisoned for that. And other is a Kurt Semen. He was basically a gynecologist, but he went into disrepute because of our own surgical faculty. How and why? He basically was a general engineer and a gynecologist. He introduced automatic insufflator, thermocoagulation, loop knots and what not. But once while making a slide presentation, an ovarian cyst, suddenly the projector was plugged off with explanation that such unethical surgery should not be presented. This was the criticism and resistance. In 1970, after becoming chairman of Gynae and Obstetrics at University of Yale, his co-workers demanded that he should undergo a brain scan because they said only a person with brain damage would perform laparoscopic surgery. So 1975 there was a huge debate, and as a result laparoscopy was the target of intense scrutiny including United States, and in 1980s represents what can be said as arguably as the most controversial year in the laparoscopic entire history. Conspiracy against common man was the common aphorism amongst the surgeons itself. They said, say no to laparoscopy. This was the slogan. We entered into SILS, but when I went into the literature, I found that it is not the Pelosi who is pioneer of single incision laparoscopy, but it was Redock in 1934 who designed a single puncture operating laparoscopy and its accompanying instruments with which biopsies could be taken. Then came the beginning of 21st century and lot of revolution. Natural orifices, surgery, 2000 experimentation, 2007 first transvaginal cholecystectomy by a French digestive and endocrine surgeon. There was a debate going on who should do thyroid, but there are superimpositions. And this is today's talk of surgery amongst every medical specialty, artificial intelligence and robotics entering into the surgical domains. We must salute the AI inventors. The first conference in this regard, artificial intelligence, was held as back as in 1956. So what is artificial intelligence? I'll not dwell upon in details about artificial intelligence. I have already dwelt upon on this topic, separate topic in two conferences. Basically, it is a study of algorithms that enable machine to reason and perform cognitive functions, including problem solving, objects and word recognitions, and decision making. In nutshell, it is an area of computer science that can emphasize the creation of intelligent machine that works and react like human beings. So there are four main fields, subfields of artificial intelligence: machine learning, natural language processing, artificial neural network, and computer vision. These are four subfields. People are venturing upon this, and they are saying that there is problem solving, objects and word recognitions of diagnostic accuracy, optimize treatment strategies, and execute procedures with unprecedented precision. This is a debate going on in medical sciences. These are the domains: task dimension, use dimension, technology dimension. I'll only focus on technology dimensions. And this is a robotics. World first surgical robotic, 1983, 87, Puma cholecystectomy, Da Vinci. Then now robotics has also gone so far ahead. Technology is advancing. Technology is unendingly advancing, but how it is impacting upon the surgical and medical fraternity, you are going to see in next slides. This is how the changes in evolution in robotics was 1909, 2014, and now presently we have robot, we have monitor, and we have arms of the robot, all those things. These are the future predictions which the proponents of AI and robotic surgery, they are putting forth. The future of surgery will continue to integrate the ever-evolving and maturing technology of artificial intelligence, thereby improving pre-operative, intra and post-operative management. Prediction 1, better operative planning and automated analysis. Prediction 2, ability to avoid adverse events. Prediction 3, better recovery rates and post-operative monitoring. But pitfalls, several concerns and negative impacts. Number 1, challenges with data collections, data privacy, and data security. Biases in algorithms, overfitting, data quality issues can lead to distorted and unfair outcomes. Exacerbation of healthcare disparities. The black box nature of many AI systems. These are all things which are chapters in themselves in artificial intelligence. But I am only giving the references. Job displacement fears among healthcare professionals persist. Unfortunately, surgeons already have limitations in their understanding of regression, such as relative risks and odd ratios, and even in interpretation of p-values. Current regressions and models of AI are complex, making it increasingly important for modern surgeons to know and understand certain fundamentals of statistics. The hope is that AI can interpret regression analysis for us via machine learning and deep learning, thus bypassing need for surgeons to understand regression models. Ethical and legal considerations in AI are privacy, cyber crimes, and concerned parties should adhere to code of ethics to ensure the new technology such as gene addition, bioprinted organs transplant for long-term human production are associated responsibility to build trust among humans and AI technology gradually. And these are the researchers' issues: data, algorithms, and healthcare practices. There is a need for protection of data, the ability for algorithms to be manipulated, and the fear that AI will destroy the doctor-patient relation. This is one ethical issue. Number 2, blind reliance on AI without quality data may lead to unintended biases and loss of empathy, which is fundamental to healing. And number 3, facial recognition software has been shown to be susceptible to racial discriminations and could be particularly dangerous in plastic, ENT, head neck surgeries. Issues for future consideration. As the capability of medical robots towards various levels of autonomy evolves, most of the role of medical specialists will shift towards diagnosis and decision making. So, could this shift also means that medical specialists will be less skilled in terms of dexterity and basic surgical skill as the technologies are introduced and what would be the implication on future training and accreditations? If robotic performance proves to be superior to that of humans, should we put our trust in fully autonomous medical robots? Right? And now, the second thing which I want to emphasize, the black thing, after that sky blue color, the black full stop, not fearful of this picture, but definitely of this picture. It conveys so many meanings. समझने वाले समझ गए, ना समझे वो अनाड़ी. It conveys so many meanings. Not fear from this, but fear from this. And it takes, why fearful of that? Because it takes decades and decades to produce one Professor Mahmuda Khan. You can see the pictures, how one Mahmuda Khan is produced. But the black spot, black dots, full stop, healers under stress. As an atheist, I can give this statement. Doctors healing more people than God since 2750 BC. But healers, they are turning sufferers. There are scores of data available here. The first data was given by IMA, but today's society, see the dichotomy, see the picture, and then I feel this picture is a reflection of mindset of our profession. Sponsor, sooner or later we will all sink if we don't unite and take decisive remedies. Please unite. Who will heal the healers? Changing societal demands compel surgeons for innovations and technology advances. But learning technology is a need. Vis-a-vis understanding social, ethical, and legal domains of technology advances should be learned. Why? Because allegations of malpractices, exaggerated expenses, unnecessary operations, organ stealing, they are rampant. They are front also and back also. My worrying areas, the black full stop, after the sky is the limit, the sky blue color, violence and litigations. Demigods and noble professions. Society has become so fake that actually truth bothers people. But unfortunate part is that doctors have started reflecting values of society in their profession as well. It may be a controversial statement. 50% may like this, 50% may not like this. But I have to put it to the domain. Are surgeons contributors to their distress? Jealousy, ego, role models, sense of grandeur, lack of communication, shy of refreshing, sycophancy, and encourage officials to act against own colleagues. So, what I want to basically convey and attribute and dedicate to Professor Mahmuda Khan. Surgery as a specialty has evolved over centuries with well-defined laws and codes regulating medical and surgical practices in different civilizations that define the growth and progress of profession, which is continuing even today and shall remain so. Challenges such as generalizability, cost effectiveness, and ethical considerations remains, necessitating continued research and collaboration to maximize the benefits of evolving surgical techniques. In view of uninterrupted evolutions, the surgical fraternity must understand the basics of AI and then learn to better understand its potential benefits instead of insisting on resistance. Innovations. Every device or innovation that provides any form of automation and improves patient care must be celebrated, studied, and if appropriate, embraced. And artificial intelligence is one such innovation that needs attention of medical fraternity. Never ever ignore fascinating history of our profession. Significant personalities and outstanding scientific and social achievements. It may not necessarily help us predict the future of surgery, but it does shed some light on surgical practices of different times. If future generations of surgeons wish to be regarded as more than mere technicians, they must appreciate the value of reading Evolution of Surgery that has a distinguished heritage which is in danger of being forgotten. Future of art, craft and science of surgery remains unknown, but its glorious past is well known and should be remembered for all times. I once again repeat this. Future of art, crafts and science of surgery remains unknown, but its glorious past is well known and should be remembered for all times. Professor Mahmuda Khan is one such glorious past of surgeons of Jammu and Kashmir. So I end, the illiterates of 21st century will not be those who cannot read and write, but those who cannot learn, unlearn and relearn. And focused surgical specialty. Tell me and I will forget. Tell me and I will forget. Teach me and I will remember. Teach me and I will remember. Involve me and I will learn. This should be the principle of all teachers, all senior surgeons sitting here across the domains. It cannot be inherited, nor it can be purchased. I have earned it with blood, sweat and tear. I own it forever, the title surgeon. Thank you very much.
Hello.
Hello.
Thank you, Dr. Sanjay, for a comprehensive and a wonderful talk. It was a very interesting and evolving topic, very well justified. You really deserved this oration. It was a great tribute to our teacher, beloved teacher, Professor Mahmuda Khan. I would like to reiterate that Dr. Sanjay Bhasin is one of the most important backbones for the development of our society, Jakasi. He has worked so hard in difficult times. As a secretary, then as a chairman of the society. He does everything meticulously and as per rules and regulations. Hats off, Dr. Sanjay. Really, I congratulate you. I would like that you should continue to be an advisor for our future executives of the JKRC. So, questions are not allowed in orations, but any comments are welcome. If somebody, I think the students of Professor Mahmuda Khan are sitting in the hall. If anybody has any comments about Professor Mahmuda Khan, he is most welcome. Professor Fazl sir.
Sir, I had the honor of working with her as a house surgeon, as pointed out by Professor Ajaz Saab. Basically, once we also were taken for an interview that which unit do you want? None of us said unit 1, to which she was heading. Out of the fear cycle. So everybody said that she's a very tough person, you should not join that unit. And ultimately, she started banking Professor Rafi, late who was his Registrar, Rafi Veda. And ultimately, Rafi Veda prevailed on me and Parvez. Only Ghazala had opted, and ultimately we two were practically pushed into the unit. But trust me, The amount of clerking we learned, the amount of basics we learned there, amount of love we got from madam, and we remember that day we had to leave, Professor Mahmuda Khan herself told them that these house surgeons have worked very hard, never leave them without a farewell, and we were accorded a very, very warm and a grand farewell. We remember how motherly she was. And working with her would really make you to know the meticulous attitude, the care about the patients. I remember for a sick patient, I have seen him as professor and had coming at 2 in the night, coming at 12 in the night to personally attend to the patient. And the patient was the most important. Thank you, thank you.
Thank you, Professor Basim. So, should we stop it here now? Or felicitation?
Thank you, sir. I would now like to request Professor Dr. Fazil Q. Pare, Principal, SKIMS Medical College, Bemina, to kindly felicitate our chairpersons. Professor Dr. Nisar Ahmed Chaudhary, Professor Dr. Rukhsana Najeeb, Professor Dr. Ejaz Ahmed Rathar, Professor Dr. Madhumita Mukhopadhyay, Thank you, sir. I now request the chairpersons to felicitate our speaker, Professor Dr. Sanjay Kumar Basin.
Now moving on to the Professor Dr. Shittal Singh Oration, I would like to call upon stage our esteemed chairpersons. Professor Dr. Umar Javed Shah, former Head of Department, Surgical Gastroenterology and former Director, SKIMS Saura. Sir is unfortunately not present here today. Our next chairperson, Professor Dr. N.C. Digra, former Head of Department, General and Minimal Access Surgery and former Principal, Government Medical College, Jammu. Professor Dr. Iqbal Salim Mir,
Head of Department, General and Minimal Access Surgery, GMC Srinagar, and Chairperson, Jakasi. Professor Dr. Iqbal Salim Mir, Head of Department, General and Minimal Access Surgery, Skim Saura. Ejaz Ahmad Malik, Head of Department, General and Minimal Access Surgery, Skim Saura. Now I would request our esteemed chairpersons to invite our speaker on the stage.
All right, let me take this privilege to introduce the orator. We have Professor Fazl Pare, who is presently the Principal and Dean, SKIMS Medical College, Bimina. He is one of the pioneering surgeons. He's one of my colleagues in the department who has been recently given an additional work of being the principal, SKIMS Medical College, Bimina. He is basically a general surgeon who now has diversified into a colorectal a few years back. He has tried to do the best not only in starting the services of colorectal surgery in SKIMS, but also in delivering and starting the hospital and the college along with me and our predecessors in starting the SKIMS Medical College, which is one of the best colleges in the country this time. So he has been always working tirelessly, and I know he has a lot of energy. In fact, unfortunately, fate gave him little bit of problems, which Almighty, he has most probably taken him off also from that. He has been courageous. He has delivered the best not only in the local chapters but also in the national ASI forum. He is one of our representatives at almost all the bodies, the professional bodies of the associations, including the Association of Colorectal Surgeons of India, Association of Surgeons of India, Minimal Access Surgeons of India, and so many other associations. He has been with me right from the inception, and I think we have grown together, we have learned together, we have shared things together. And I'm not so much close to any of the faculty members till now as compared to Professor Fazl. I request him to come to the podium to deliver Professor Shittal Sir's oration. Thank you.
Respected chairpersons, Founder Chairman Jakasi, Professor Nisar Chaudhary, Professor Salru, Dr. Ruxana Habib, Principal, and my batchmate, Dr. Wakar, Dr. Madhumita, Dr. Ejaz Rathir, Dr. Sanjay Basin, Dr. Nazir Organizing, Dr. Shamus, and many of my dear students and colleagues, a very, very good afternoon to all of you. First of all, before I start the oration, I think I am humbled by the words of which were, I would say, humbly overplayed by my dear friend, Professor Ejaz, I have tried to do my little bit, but I'm sure there are people in this hall who are going to do much, much better than us, inshallah, in coming years. That has been what has been our mission of taking the chapter ahead. And what gives us pleasure that the seed sown by Professor Nisar Chaudhary, myself, Ajaz Saab, Digra sir, Sanjay, it has blossomed into, I would say, a very good plant, and that's what gives the gardener the ultimate satisfaction. Thank you so much for being here, and thank you, Jakasi Executive Chairperson, considering me worth to deliver this oration. What makes it very important for me, because I have grown, I have done my schooling, I have done my early college days from this town only. I belong to this town. So what makes it very, very, and I have a very strong emotional bond with this part of Kashmir, because the birthplace, you always remember my ancestors, my parents, they are all buried here. So that's what makes this a very, very special and a momentous occasion for me. Thank you. So let us start. This is the first time Professor Shittal Singh Oration was started with the kind intervention of his wonderful daughter, Dr. Kanchan, who this oration introduced just on a single phone call from some of our members. And Professor Shittal Singh, we know how enthusiastic, the senior people know how enthusiastic we were always to see him in the conferences, in the meetings. That's how we know him, even though I never had the honor of working with him. I never had the honor of, by being his junior, by being his colleague, but there are many in the hall who have done that. So just to introduce him, he was born in village Kanihama, Tangmag in August 1944. He had done his schooling from Sopore and Srinagar. He did his MBBS from Calcutta Medical College. He did his MS in General Surgery from AIMS in 1973. So this is once he was the recipient of the Lifetime Achievement Award from our worthy honorary Union Minister that time, Ghulam Nabi Azad Sahab and Janab Farooq Abdullah Sahab. You can see it in the picture. Then you can see him once he would be in his usual attires as a surgeon, in his OT, working day and night ruthlessly, and always saying, giving a welcoming gesture to the new crafts introduced in the Valley of Kashmir, our J&K state. So he has done his service at GMC Srinagar till 1984, a commendable service in the Department of General Surgery. Then he went to GMC Jammu in 84 onwards. He headed the department of GMC in Jammu. He was the principal and dean of GMC Srinagar. And Dr. Shittal Singh was among us the first batch in India to train in laparoscopy surgery under Dr. Uduwadia in 1994. So that is where you can see how much ahead he was from the rest of the crowd. So his contributions as a surgeon to start lab surgery in J&K, it was a huge contribution. Then he had, to his credit, the highest number of lab surgeries which have been performed by any surgeon in J&K. He has successfully performed a mini laparoscopy on a 4-year-old child in 2015. He has been a great academician. Teaching was his passion, known for his gentle nature, philanthropy, and charity. And the biggest thing is there are so many things which he would not even reveal to his family members whenever it would come to charity, whenever it would come to helping some poor patient. That has been one of the greatest quality of a strong man and a strong pillar. And we can very well see from his daughter, Dr. Kanchan, how well she has been brought up, how the mannerism speaks it all. Thank you, and we really miss our Professor Shittal Singh on this day. So my topic, which I chose as a tribute to this great surgeon of the J&K, is I have been dealing now with rectal cancer. So what have been my experiences, how we took this, maybe somebody takes a lead, how to go ahead in the careers, maybe it's of some help to somebody among us, the juniors. So once we go to the RCC data, it was first called the Regional Cancer Center. Once you go to their data, you can see, first of all, the cancer rectum. It is a 3-year data from January 2009-2011. Cancer colorectum, we had around 342 patients. And percentage was 6.6, but if we go to the females, it was 274. So slight preponderance for the females were there. So by and large, if we consider, it was roughly over a period of 3 years, the colorectal was getting around 600 patients for 3 years, so 200 per year. Once we compared it with the national data, what was found? National data shows that incidence of rectal cancer is higher as compared to colon cancer. That is the national average. But in our place, it almost was equal, and it is only the rectal cancer data. We had 157 registrations in 2021, which is the latest in this. Then females were 76, males were 81. Again, the ratio was almost same. Now it is the latest data. If we now see the present scenario of 2023 and 24, it is hospital-based cancer registry of SCIMS. What we see, colon cancer has markedly increased. It has gone to 541 in 2 years, and rectal cancer has 283. You can see how huge the barriers have started widening, and this is of importance to the and concern to all the budding of surgeons. So what have been our milestones once we started the colorectal division, once we, under the guidance of Professor Nisar Chaudhary, once I started working as a colleague with him. So what have been our milestones from April, once I became a faculty? I remember in 2001, we had 2 surgeries being performed in our department for colorectal. One was APR for rectal cancer, one was low anterior resection. And I remember those days, no patient would be on the list with minimum 2 units of blood, because it used to be a very bloody surgery those days. So staplers then started becoming the in thing, and I remember Professor Khurshid Alam, Professor Ajaz Malik were the first to start the use of a stapler in 2005. Then since Nisar Sahab and me had started dedication towards the colorectal cases, so we started then using it regularly on a regular basis in the coming years, because our ultimate aim was to decrease the number of APRs and do the more and more sphincter saving surgeries. So what is very important, it's not that you complete your MS, you complete your MCH, your training stops there. No, keep on training yourself. So during your training, you may get many teachers who impress you. You may get training from outside your state. You may go to some high volume centers, and like Tata, you may go to high volume centers like in the West or in the anywhere, China, Singapore, where you get a chance, and keep on upgrading your knowledge. It really recharges you, it really spices you up. But if we get posted in a place like Handwara and stop thinking that my growth is stopped, I cannot do, no. Use your vacations, use your everything for these trainings, for recharging yourself, and trust me, this will do a great help to all of you for growing further. So, what was the outcome of these trainings and other things, and focusing on one thing, the goal got redefined for us. We started doing more and more sphincter preservation surgeries. We started doing more and more low anterior resections. We started more and more ultra-low anterior resections, total mesorectal excisions, and total mesorectal excision with pelvic autonomic nerve preservation. That became the goal. And once we did a good number of patients, what was the problem? Because every cloud is accompanied by a silver lining or a bad thing at times. So what happened? We encountered some patients coming back with Lars syndrome, low anterior resection syndrome, because now we were preserving sphincters, doing a very low anastomosis. And what we found in our study, that patients who had a higher BMI, who had a lower tumor height, who had lower anastomotic height, and whose postoperative period at times was complicated by a leak, those patients were more prone to get these Lars syndromes. So we tried to find out a solution. We started doing the colonic J pouches. We gave it as a thesis. We started writing a paper on it. We wrote a book chapter. We wrote a paper. So what happens by that? You come to know and know. You are compelled to read more and more about a particular topic, and this gives you more insight into things. That's how we started doing these colonic pouches, because our purpose was to decrease this anterior resection syndrome, to create an artificial neoreservoir, but it had some evacuation difficulties, because your peristaltic wave travels towards the anus, but it was going towards the J pouch, and it was giving some evacuation difficulties in some patients. So we tried a new thing that's known as coloplasty. Coloplasty is more physiological. It has the same principles like you have in pyroplasty. You make a vertical incision in the last part of the colon, which is to be anastomosis, and then you close it transversely so that neurectum is created, so that a bigger pouch is created. It acts as a reservoir. But what we found in this total coloplasty group, the leak rates were more. So leak rates were a little more than colonic J pouch. So otherwise bladder and sexual dysfunction showed no significant difference, and the leak rates, however, did not reach any statistical significance, but still for the betterment of patients, we stopped it. So what were the lessons learned? We believe that milestones make our journeys more memorable. Never feel small to learn, relearn, train and retrain. That is the one mantra I am going to give to all the junior surgeons. Learn to give up a procedure fraught with complications. If you have started a procedure, never fight to the end. If you find it is having more complications, no, it is right, it is right. If you find it is giving complication, please stop, for the betterment of the safety, and ultimate aim is safety. So then came the era of the MRIs. MRIs became a very, very big milestone in the staging of rectal cancers. Why? Because with MRI, we could see things, how much is the puborectal muscle involvement, how much is the nodal involvement around it, how much are the EMI planes involved, how much is the extramural invasion. So this all information was not probably got so well from the CTs. So MRI became a very, very profound weapon in our hand, a productive thing in our hand, where we could easily take a decision as per the internal guidelines that whenever we have a locally advanced rectal cancer coming to us, which is the usual picture in our country, whenever it is T3 or more, please go for chemoradiotherapy. Never go for an upfront surgery. So whenever you are doing MRI pelvis, it differentiates very well between T2 and T3 lesions. So if a lesion is up to T2, you may go for upfront surgery, but as soon as it goes to T3, please go for downstaging. So tumor board discussions are very, very productive. Never think I am a surgeon, I know everything about it. No, your medical oncology colleagues, your radiotherapy colleagues will always make you learn better things. It's quite effective. What happens in chemoradiation, mucinous and signet rings, they show less response. And we started even one study giving short course radiotherapy. I think Mushtaq Lave was the person, but after some time, the head of radiotherapy came and said, sir, we are getting many complications, let us stop it. So there are many centers in the country who are giving short course radiotherapy, but our experience has been, please don't do it, we stopped it, just for the betterment of the patients. So these are the old pictures of our tumor board. So that's what I said. It always helps you in borderline cases, complex cases, and you benefit from such discussions. Then came the eras of the laparoscopy, and we started introducing the advanced laparoscopy in our colorectal cases also. So what is my advice to all of you, whosoever wants to be a part of the laparoscopic journey? Learn it well from your high volume centers. Assist with a few masters, go ahead to practice your craft on low BMI, never select obese patients in the first instance, and primarily look for sigmoid colon growths. Don't go for right colon growth. Somebody may tell you should start from right colon. That's a very, very wrong advice, absurd advice, I would say. Sigmoid colon is something which you should start with, and it will be easier for the beginners. And then follow-up is very, very important in all the patients. Then decision making. Many a times you have made a decision, I will do a low anterior resection on this patient. But please and please, whenever you give anesthesia to the patient, again do an anesthesia under examination. And never be very, very adamant about your decision. Maybe you have to change your decision on table. Maybe you think on table now APR will be a better decision. So please and please examine them. This time patient is relaxed and you will have the better appreciation of the rectal canal, and you can comfortably assess whether this particular patient I should go for sphincter saving or sphincter preserving. So lesson at defining a goal, always pursue it. Once you define a goal, pursue it always. And what is the most common thing with the surgeon is the middle age syndrome. Once you get 40, 45, then you stop thinking, nay, I cannot learn it now. Robotics is the new thing. Laparoscopy. Please and please don't say no to this. This is a very, very negative factor for your learning. Always keep on learning. Then master the gold standard procedures and propagate them amongst your students. That's a very important thing. Then multidisciplinary team management, examination under anesthesia, help always better decision making in cases of rectal cancer. So then we did couple of extra levator abdominoperineal excisions. In extra levator, we make the patient to lie prone. It is those patients who even after downstaging still have the sphincter involvement where you are doing APR, but you want to have a cylindrical specimen because the neck of the APR where they meet pelvic part and the abdominal part, that is the cause of recurrence. In ELAPE, you get the cylindrical specimen, but our series was very less in that, hardly a few patients, so we cannot comment on the recurrence and other things, but one should, as a colorectal surgeon, know about it whenever you are doing these procedures. Then transabdominal, transanal incision, intersphincteric resections, because more and more people are going for sphincter preservation, so they want to now go even below 5 centimeters. Once you have a lesion at 3 centimeters, 3 to 5 centimeters, you want Shittal sphincter preservation. Patient is that time you want to go ahead with transabdominal, transanal incision or intersphincteric resection. So what is the biggest advantage of this surgery? It is the real natural orifice surgery. It is the real scarless surgery because abdominal part you are doing by laparoscopy and transanal part you may do under normal vision. Once you see the distal end, you make a persisting suture 1 centimeter below that. So the advantage here is you have a control on the distal end. Your distal margin to the pathologist will not be positive, but it is technically demanding and should be. Please and please never try a synchronous approach. Some people, some literature recommends that one surgeon can come from the abdomen like APR, another patient can come from, it is not possible in laparoscopy because abdominal surgeon always wants the legs down, perineal surgeon always wants the legs up, so it creates a lot of technical difficulty. So always finish the upper part first, then go to the lower part. So then we had started thinking beyond TME. There are some patients who have been downstaged, but still you need to have a tailored approach because your MRI is a guidance there. You find the central compartment is still involved. You find the muscles are involved. You find laterally the nodes are involved. So at times you find anteriorly bladder is involved, uterus involved. That time you have to select a tailored approach for such patient, and you might have to do a resection which will take all the growth with it, and it should be an organ preserving, but many a times we have resected the cuff of the bladder, we have resected the uterus with it so that we achieve a T0 resection there on the table. So what are the advancements we have made from couple of years, from last few years is we have added transanal TME. Transanal TME means again through the rectum you again use a laparoscope. You again use a laparoscope, you get a bigger vision. Instead of doing a nude eye dissection, you do it under resectoscope, you do it under proper vision, and you have the magnified vision. And it is again the ultimate goal of the nodes because you are using laparoscopic. It gives you a rush of adrenaline. Once you have completed the specimen is resected, it comes out per rectum, it has no adhesions, it has a good quality specimen. Always it is a very good feeling for the surgeon. And what's very important that you need to select the patients properly and you have to focus on quality of life, but in such patients you can have more readmissions. So other advancements can be TAMIS, transanal minimal invasive surgery, TAMS, transanal excision, T1 lesions, but recurrence, margin positivity have to be taken into consideration. That would be a very, very important thing. So wait and watch has been one of the new things which is coming up in the literature after Haber-Gamma studies. A medical oncologist, a lady medical oncologist, who gave the concept that there are many patients, once we give neoadjuvant therapy, once we start down, there is a complete response. The nodule disappears. So what we do in them, we go for TNT. We continue this chemotherapy further cycles and do not take them up for surgery. But what is very important, it is still not a gold standard. The study we undertook, we had selected 31 patients at SCIMS for this study. Only 14 out of this gave a consent for this total neoadjuvant person, that is 45.1%. And among us that, clinical complete response, what we done after complete clinical response in these 14 patients, what we did, we told the patients very clearly that this is not a gold standard. 8 opted that we will go for surgery again, while 6 are still on follow-up. They are, in case anytime the nodule appears, we will go for the salvage surgery. Quality of life, LAR may not be superior to APR for low rectal cancer. Don't have this thing in mind that sphincter saving surgery is always superior. No, it may not be superior for the low rectal cancer. Quality of life after permanent stoma is equal or better than the LAR in some cases. So select your cases properly, right? So after 24 years of focused work, after 2001, once I got appointed in the faculty, I will continue to consider APR a vital tool in the armamentarium of rectal cancer management. So don't exclude it completely. So lessons learned are over-enthusiasm for nodes can be counterproductive. Never over-select your patients for nodes. So old may be gold. Sometimes you have to remember that. Learn when not to operate. Again, a very, very important lesson. Then diversion stomas, again a big question. Once you have done a very low anastomo, should you go for a diversion stoma? Yes, there are anastomotic leaks, ileus, resumption of diet, wound infection, small bowel obstruction, mortality, they might be very less, but stoma related complications can be there. And sometimes the anastomotic stoma formation, this stenosis formation, what we found, once you have diverted, anastomotic strictures may be just 6%, but once you have not diverted, they may go as high as 28% if you are not regularly on follow-up doing their DRE. There are some synechiae formed, break them, they will be saved from the recurrence. Otherwise, you will have a very, very bad stenotic anus at the time of conversion. So stoma therapist again is a very, very important person in your armamentarium. That really makes your stoma care wonderful. That standardizes your stoma construction, and we prefer a diversion post radiotherapy and in any lesion which has an anastomosis less than 6 centimeter. Never take a chance if you have given pre-op radiotherapy. Prefer to cover them always with a diversion stoma. Otherwise, you will encounter bad leaks, sir. So audit yourself. Pathologists and radiologists can be your best auditors. They can never feel small if somebody criticizes your work. That means he's actually interested in improving your quality of work. So audit yourself, your quality of specimens. Tell your radiologist after MRI, if he has a check MRI, do you think do you think our TME is complete? Do you think our specimen quality is good? They have the method of scoring that will always help you in improving. Then research is very, very important. Surgeons are considered by all physicians that probably surgeons are meant for just like butchers, for removing the organ and not thinking about it. Kindly wipe up that concept from the society. Keep on doing research. Whatever good case, you should keep on reporting it. Have the habit. Global trials are a way ahead because most of the literature now, most of the research needs money, and for us that is a huge money once you have to get an article published in a standard. So global trials are the way ahead where you don't have to pay any, it enhances the image of your center globally. Then focus, consistency, sincerity and teamwork could get our colorectal unit on International Journal of Surgery multiple times, British Journal of Surgery, couple of times, World Journal of Surgery, Annals of Surgery, Anesthesia, Lancet Oncology, couple of times, and Lancet. This is how your work is recognized globally and it is acknowledged. We could write 2 Springer books on colorectal surgery. We could write more than 17 book chapters, all because of a good team around. So COVID era, again, most of the surgeons were sitting idle. They thought, oh, COVID has come, we cannot do it. But trust me, it proved a gold mine for us because we started focusing, we started working on research, and it gave us some wonderful papers which are in the highest impact journals from our colorectal unit. So lessons learned were audit and standard protocols, improve your quality, research makes you global, thinking beyond, always generates creativity. That's again a very important lesson. Then I would say colorectal journey is still on, even though now Professor Nisar is working in private sector after post-superannuation. Professor Roufani is working at SICKIMS. I have been recently given other assignment, but I am thankful to all those team members who have worked with us. They have always shown commitment, dedication. It's all because of your family support, parental support, friends, and your team support ultimately. Then ACRSI, and then ASI, and all my mentors, OT staff, stoma therapists, tumor board, radiology, oncology, medical G, all surgical specialists of J&K Health who have been referring the cases directly to us. Honestly, trust me, till date, we never had to ask our medical gastroenterology, please refer us cases. Because we had so much coming from our J&K Health specialists that we had no place in our lists left for anything or anyone. Thank you so much, and thank you so much for those referrals. But at the same time, you should remember surgeons have got nightmares. Don't think colorectal surgery is without nightmares. It has the leak rate. It has the highest bacterial count. So leaks are disappointing. At times, you suffer as a surgeon from the agony of sleepless nights. At times, you suffer from the hurt of losing a patient. At times, you suffer from the guilt of blames. So please, that should not deter you from your journey. That should keep on correcting you. That should keep on making you more and more safe for future. So what is the reward? The reward for the surgeon, it is rewarding in many ways. You keep on learning from your patients. Some have become lifetime friends. At the end of the day, I don't see any foes. Hope Almighty gives me more strength and professional wisdom to contribute more. And what are the puzzles and riddles we encountered in our journey is we saw patients with well-differentiated carcinoma developing metastasis within 1 year. Even the best anastomosis may leak, or a threatened anastomosis may heal well. Saw the patients with signature with more than a decade on follow-up. So never be in a denial. What denial does, it invites morbidity and mortality. Stop blaming. When your patient leaves, don't say it was done by my senior resident. Don't say it was done by my junior colleague. You are the team leader, you have to own it. Always rule out intra-abdominal sepsis. Never be overconfident on your rounds. No, my patient cannot have intra-abdominal sepsis. The tachycardia should be the first warning signal on your morning round that my patient is not well after colorectal anastomosis. If he has tachycardia, even if ultrasound says it is normal, please don't trust that. Please get a CT, contrast CT done, and many a times you will pick up the leaks and hubris. Hubris, what is that? That anybody thinks that I am the uncrowned king, I can have no mistakes. That is the worst enemy of a surgeon. Never be loaded with those things. So our series at SICKIMS, I was collecting the data for last 24, more than 2,200 rectal cancers in last 24 years. More than 4,900 colorectal cancers have reported, and mortality was greater than 2%, morbidity was greater than 22%. Greater than 4% developed the leaks which needed an intervention, which needed reoperation, but minor leaks settled without reoperation. Approximately 9% of patients had post-operative ileus, which was managed conservatively. So be honest and focused. That's what I will recommend to all my juniors. Never hide your complications. Examination under anesthesia is a must in rectal cancer. Build your teams. Tumor board discussions are very important. They can be the eye-openers for focus, increases the volume and outcomes. Upgradation of knowledge and skills is always needed, and you must remember Rome was not built in a day. So teamwork, there is no substitute to that. Thank you, my team, and thank you, my patients. And I would tell my youngsters, dil se jo baat nikalti hai, asar rakhti hai, par nahi taaqat-e parwaaz magar rakhti hai. You need to have passion to grow. You need to have passion to grow in the right direction. So if one believes in the adage that service to others is the rent we pay for our room here on this earth, Professor Shittal Singh paid more than his share of rent and was a very successful man who is truly an icon to be remembered, and a great father, great parent, and a great philanthropist. My salutes to him, and I feel really honored and humbled to be presenting his first oration at my hometown. Thank you so much. Thank you so much for a patient hearing. Thank you, Dr. Kanchan. Thank you, Dr. Kanchan. And before I close it, I would request all of us that we had recently seen the Pahalgam carnage here, which was a very, very painful thing. We saw Ahmedabad blast, our medical students, our other country fellowmen dying in a fateful crash. I would like all of you to stand up for a minute and pay homage, so that it is a point of solidarity for all of them. We pay homage to all of them. Thank you, thank you. And before we close, I would point out with a lot of humility to only one mistake in Professor Sanjay sir's oration. Please don't mind it, sir. You said my elderly friend Professor Nazir, so we never consider him elderly, sir. He is younger than us. Thank you, sir.
Professor Fazal, you continue to amaze me.
Nice.
You have been amazing me for the last 25 years, and of course, the silver hairs that you are getting, your wisdom is also growing. The way you speak, I told you, you're one of the few persons whom I really understand with heart, and I follow you with the passion.
Thank you,
again, sir. It was a great lecture. Can we have a really big round of applause for that?
Thank you.
And now I'll hand the mic to Professor Digra, because he has to say something about Professor Shittal Singh. He has worked with him. So it's important that we honor his soul, because it's something we have started, and I think it's time that we continue to honor our seniors like this one.
I think many of the things have been said by Professor Shittal Singh, but I have my own memories, because I worked with him more than 9 years in the department. I joined the department in 1994 when he was an associate professor. A man who was really having qualities of head, heart, and hand. And he was such a person who had big wisdom, and he will tell you how to come out of a situation, a bad situation. I remember we were in a seminar, somebody was telling about complications of appendicitis, difficult appendicitis. Then he gave a comment. Appendix and the gallbladder can give you a shock even on your day of retirement. See how much wisdom he was providing in that. Then he was the one who brought private practice to Jammu. People in Jammu were not private practice, doing surgery in private. He was the man who introduced private surgery in Jammu. And then, of course, as Professor Parekh said, he was the first person who brought laparoscopic surgery to Jammu. And I think not Jammu only, whole of J&K. And he was a great host. Whenever we were going to a conference with him, if food was not good in the conference, he said, come to my room in the hotel, I will provide you all the refreshments. And he did it with a great, I think, great concern for all of us. And he was a great, eager to learn. Whenever there was a new thing, we as universities may be missing something, but this man has such a eagerness to learn that he will be there. And then, of course, one day we were talking about something, surgeons, what they are doing, what he said, as people say, the last refuge for a politician or for a scoundrel, as it is that, but for a patient, the last refuge of the surgeons or a surgeon. This was a great thing. Then, of course, surgery as a craft. I think we have to learn from it. And his oratory, I think I have learned from many speakers in international conferences, in national conferences, state conferences. You cannot match his oratory. And he will give you such a confidence, even as a small colleague. If there is somebody he is talking to, you will introduce not as your student, not as your unit, he will tell he is my colleague, he does beautiful pediatric surgery, he is the great man. He used to give a lot of confidence to his
students and my fond memories for him. I feel that he has been given a this right movement of appreciation by offering a oration is named by Jagasi, and all the credit goes to the Kanchan, who has been my student. Even if she was a student in the same department as an undergraduate and postgraduate, sir has never said, teach my daughter. He said, she is your student, you have to take care of her. Never recommended anything. I think that was great for her. Yeah, that's great.
Thank you.
Thank you very much.
We appreciate all that.
Thank you, sir. Thank you very much. Any person here in the audience who knows Professor Shittal Singh and would like to throw a comment regarding this oration? It's most welcome. All right, thank you very much. So we close the session of oration. Thank you, Professor Fazil. Thank you.
Thank you very much, sir. Now, I request our esteemed chairpersons to kindly felicitate our speaker, Professor Dr. Fazil Q. Pare, sir.
Can we have Kanchan here, please? We want you to honor the speaker and your father. Okay? This is from Jakasi, because we just requested you and you did not even take 5 minutes. A big round of applause for her.
Thank you. Now, I would like to call upon stage Professor Dr. Sanjay Kumar Bhasin, sir, to kindly felicitate our chairpersons. Professor Dr. N.C. Digra, Professor Dr. Iqbal Salim Mir, Professor Dr. Ejaz Ahmad Malik, thank you, sir.
Moving further, for the Chairman Jakasi oration, I would like to invite on stage our chairpersons. Professor Dr. Nazir Ahmed Salru, former Professor, Department of General and Minimal Access Surgery, GMC Srinagar. Professor Dr. Roof A. Vani, Professor from the Department of General and Minimal Access Surgery, SKIMS. Dr. Nazir Ahmed Vani, Associate Professor and Head of the Department of General and Minimal Access Surgery, Government Medical College, Anantnag. And Dr. Harbinder Singh Bali, Associate Professor from the Department of General and Minimal Access Surgery, ASCOMS, and the Honorary Secretary, Jakasi. I request Dr. Fazil Q. Pare to please and come as the chairperson for this session. I request the esteemed chairpersons to kindly introduce the speaker for this session.
It's been always customary to present the presidential oration, our chairman Jakasi oration, and this year we have a very dynamic friend who is heading one of the biggest surgical departments in the country, Professor Iqbal Salim. He needs no introduction, always smiling, always with a very wonderful gestures, and takes keen interest in taking his team forward, encouraging his team. He has done contributed a lot in a big way as professor and head of general surgery at SMHS. There have been a lot many innovations. There have been addition of pancreatic surgeries in a good bit of volume, apart from laparoscopy and everything, metabolic, everything. I think that has been a great and I would say a wonderful time for SMHS hospital. Professor Iqbal himself is a wonderful laparoscopic surgeon, and we love him because of his wonderful mannerism and I would say the wonderful cheeks as well, and beautiful dimples. Please, sir.
Good afternoon. Thank you, Professor Fazil. Ever since I have grown up, he has been after my cheeks and the dimples also. Well, two doyens have spoken before me, and I really don't know how to match the standard they have set. Professor Sanjay Bhasin, with his eloquence and the way he really makes things look so simple, which are very complex. Then, well, Fazil sir, I have talked about him. He's my senior. I talk to him regularly once I have problems. So all the chairpersons there, which includes one of the persons who has taught me surgery, that is Professor Salru, and my colleagues, Dr. Nazir and Dr. Harbinder. It's again a warm welcome from Jakasi to all of you, and thanks Dr. Kanchan for staying. The sentence that I have used as topic, shrinking waistlines, growing needs, J&K's bariatric surge. It's rather a strange line, but I'll try to justify it. So, obesity is the modern epidemic. We talk of malnutrition, but we have to look at things beyond that. We are overfeeding also, and majority of the world is facing it. I would like to skip this, but India is also reeling under this obesity epidemic. And you can see how many patients, how many youngsters are now developing obesity. Then this is a map that is showing you how much trouble the world is facing. On one side, we have malnutrition at all phases, and on the other side, there is too much to eat. So this is the map that I was talking to you about. Then India is now currently the 10th country to have one of the highest incidences of obesity. And it's growing on daily rates. So this was about India. Now, as you can see, there is no distinction now of the rural or the urban areas. Even the rural areas, we are starting to have problems with obesity. So what's our scenario? We who live in the hills, who were very hardworking, have now left everything. We import even the labor for cutting the paddy, sowing the paddy, and we are just becoming stuck to our chairs because of the invasion of the mobile, which has in fact
made us into redundant entities. So the obesity in children in our areas is also increasing, and we are witnessing quite a surge of it. So this is the trends in overweight, obesity, NCD guidelines that we see. This is 2019 and 2020. This is the latest we could find. After that, we can see that the arrow is going uphill. And what's the treatment? Lifestyle modifications. I have been doing it for the last 6 months. I have lost 8 kgs, not beyond that. It stops. Then pharmacotherapy. One of our colleagues started using the new drug, and what he reported that I could not walk properly for 2 days. It's costing 11,000 rupees per month. So how are our patients going to do that? Then endoscopic procedures, certainly a very good method, but the results are not favorable. And finally, as we are surgeons here, it's what we do, metabolic bariatric surgeries. And the number of MBS, that's metabolic bariatric surgeries, is increasing as more and more surgeons find it imperative to start these procedures in their day-to-day practice. Should we operate patients, and at what BMI should we operate? We're talking of Asia, we're talking of the world. The Asian population is different. There is central obesity. Okay, glitches happen, so please bear with me. And it seems most of us are hungry or have left for lunch. But I'll detain you, I'll try to be fast. यार अभी तक तो चल रहा था. Okay, so we are done with this. I hope the mic is not giving trouble. Okay. Okay. It's not coming there. It was going on well. Hello? It's not coming there, the slide. Fortunately, Dr. Basin told me that I am a patient man, I can bear these glitches. Okay? And Dr. Fazal talked about hubris. I wish that was something that we would understand what it is and how we ruin the life of some of our patients by having that hubris in our mindset. No, they are changing something else, not the pen drive. Okay, I'll keep on telling you about that. So I am not only talking about SMHS or GMC Srinagar. I am trying to talk about the scenario in the whole of J&K. In this regard, I must give credit to two people. That is Professor Samir Nakash and Professor his portage then. Okay, I want to show their picture in display. Okay, it's fine now. They were the people who understood that no, obesity is causing issues, and they were the people who came up with the idea of starting bariatric surgeries, and it was as early as 2012. So these, I don't need to go into that, you are all well-versed, learned people. So this was kick-started in 2011 with a workshop by Dr. Mohit Bhandari, then Dr. Mufazzal, or Mufi as he is lovingly called. He delivered a guest lecture. Then first sleeve gastrectomy was done by Professor Sameer Nakash, Dr. Roof and Dr. Mubashir. Then Dr. Roof was stolen by Professor Sazal and Dr. Nisar to colorectal side, and he was instrumental, believe me. He has got all the equipment in skims for bariatric surgeries. 95% of the work done in skims is sleeve gastrectomy, and they have done an amazing number of 200 cases. That's quite encouraging. So these are their pictures, and ECMOMs they had in 2015, and 35 countries participants were in that, and this was the inauguration. So these two guys, Professor Sameer Nakash, who has retired from active service now, and Professor Mubashir. Can we have claps for them? So this is my small department, as I was just being told by Professor Ejaz that you have got 35 people. I told him no, I have only 21. Very small department, just 21 people, and we do have a good amount of workload. And this is what we tried. We have had 3 bariatric surgery updates till now, and sometimes I do get time to write about obesity. Then we try to talk to people. We try to involve our patients in delivering a message to the common masses, what are the bad effects of obesity. So this is one of our lectures, and so this is the patient talking to the future patients, what was her journey pre-op, intra-op and post-op. And believe me, there is no better ambassador than a good patient who has had a good outcome. So remember that. Where do we stand? Not much. We didn't start basically till 2017. Then unfortunately we could not complete it, or we could not go along nicely. We had issues, and we started then in a serious manner in just 2021. And we have done just 153 cases who have completed a minimum follow-up of 1 year. Please remember what I am saying. This does not include those patients who have been operated within the last 1 year. We started with lap sleeve. That is what everybody does, and it's a good thing. But within a very short span of time, we came to understand that this is not the procedure that patients are desirous of. There were issues about the weight regain and herniation in some patients. That's why we shifted to lap OAGB, and it's the standard procedure in our institution as of now. We have done 1 lap OAGBs. We do RYGBs also in selected patients, and we have also done 1 case of SARDS. I have not done it. My other colleague has done it. So if we go, Dr. Jasmeet showed it in the morning. I'll just try to take you through the steps. Crow's foot, then dissect and go into the lesser sac and look into the lesser sac. The moment you start looking into the lesser sac, your job is done. Then this first stapler is a 45 mm stapler. This is more than enough to give you 4 centimeters width, and serial staplers are used which are blue in color. We are mostly using Ethicon staplers. Of course, we have to take down the posterior adhesions and go on firing the staplers. And here is what I want to stress. It's the most important area is the fundus. If you do not disconnect the fundus, you will have issues, as I'll be showing you later on. So after that, as Professor Jasmeet said, make the patient flat and take the bowel and walk the bowel. Your cruciate forceps, once it's opened, it's up to 5 centimeters in length. And with that you get, and you can see that incision was made on the posterior aspect of the gastric tube that we had created. We stopped doing that. We had one complication. we understood that we have to dissect it there, we have to dissect the lesser omentum there, and that led to one of our complications, and we have stopped doing it. We are only doing anterior gastrojejunostomy, and believe me, the results are really great. So I have to come out of this. Okay, and one of our patients has lost 81 kgs. That is astonishing. She was 23 years old. What is the maximum weight loss? That is pointed here, and minimum is sometimes around 20 to 30 kgs. That is the usual weight loss that we see. Of course, the other things that we see, the resolution of OSA, that's what keeps the spouses awake. Once they are snoring, this is the first thing that goes in the first 2 weeks. Diabetes, 70% remission. Hypertension, from 3 drugs to 1 drug to no drug at all. Imagine what the patients are saving, what their families are saving. Professor Fazal rightly said, never hide your complications. And we as a department believe in telling people that we have created complications, of course, unwittingly. I talked about the patient. Unfortunately, we have lost 2. In our 153 patients, we have lost 2. It's in 5 years. We accept there were mistakes on our side, but we found out where we are going wrong and we corrected them. That is the first thing. Then leak was in 3 out of them. We managed to save 1. We have had bleeding, and I must thank my department of gastroenterology. They did a wonderful job. They go in, do an endoscopy. Of course, as a unit, we are doing endoscopies and colonoscopies on table, but we wanted somebody who had clips. We don't have the things with us. Then sleeve, one of the problems was incisional hernia, because you have to take the part of stomach out, while as in MGB, you leave it there. So we have repaired those also. Weight regain is what changed our attitude towards sleeve. Then in some patients, we have even had severe hypoglycemia. We tell them that you have to be in touch with your endocrinologist, nothing like that. Then a gastric fistula. I hope the video is there. Okay, can you see the CT scan? You can see the pouch, and you can see a large part of stomach, and it's joined. This is one of the important things that I wanted to show. So this we found recently, that a patient is regaining weight. So what is the reason? Then we investigated and we found that certainly there is a gastric fistula. What I emphasized is that the fundus has to be completely detached from your pouch. If you don't do it, the patient over a short period of or a long period of time is going to develop this. This is not playing. So we went in. Unfortunately, my postgraduates lost that video. I was fuming, but I did not show any evidence on my face. And we found out there was a large fistula near the fundus and the pouch. But as we found out that it's important to detach it, there were adhesions, lot of adhesions. This was our first case, and I hope we don't see anything like this before. These are some of our stories. This is the patient I was talking to you about, that she was 163 kgs. Can I have a round of applause for Professor Ruxana? She has been instrumental in us starting and converting the bariatric program into an everyday procedure. Under her guidance, this patient was done, and in one day we have done 3 cases. This is another, And I think you can, the evidence of weight loss is there from 136 to 77 kgs. And this is one of our most important patients. She is teacher of one of my colleagues, and from 143, she has reached 87 kgs. Our journey is transcending borders. This is a patient who has come all the way from Telangana to get operated in SMHS hospital. We have operated him. He is up and about just 4 days back. Because how that has happened, we don't know, but it's certainly being beneficial to that. And all of this is being done free of charge. So come on, people, let's be active. I have lost 8 kgs. Some of you also need to lose. Don't mind it, please. So this is my colleagues and me being active in sports. And thank you, everybody, for a patient hearing. And as you start to walk out on the way appears. Thank you very much. I hope I didn't keep you from lunch for too much time. I am also feeling hungry. Thank you.
I think there were some technical glitches, but thank God it happened with President only, not any of us.
Yeah, I was thinking about the sabotage being there.
So I was telling Nazir Sahab that you will be blamed for sabotage.
I have used the term, but I don't mind.
Honestly,
let's take things in a positive manner.
It's a big journey. I would say you have started the journey of obesity in Kashmir. These surgeries are very demanding. You need a very good team support from anesthesia, from critical care specialists, from your team, from endocrinologists. So many people are involved, diabetes and the dietitians. So I think still the drugs are not safe. What Iqbal sir said very rightly. There have been other complained by people, not only giddiness, many other complaints. And still this surgery is going to stand. And he has been always astonishing us with his wonderful videos, slides. लेकिन आज नज़ीर साहब ने थोड़ा मज़ा ख़राब कर दिया है, तो उसके लिए हम माफ़ी चाहेंगे.
I'm not saying, he's saying. Thank you, sir.
For us, he's a smiling assassin.
Okay.
We feel happy that the department has grown now. I remember the time I left. We were not doing more than cholecystectomies and lab coolies only were then, and that too in some hands only, not all hands. But now we are gone and you are going for bariatric surgeries. Congratulations.
Thank you, sir.
Can I give just a small comment? I think Professor Walslim is a very avid lover of sports. But I suggest him that he should keep sports beats for these patients who have been treated by him.
Thank you, sir. Certainly, this is a good suggestion. We will take it.
But I will advise you something. In PGH Chandigarh, long time back, Professor K.H. Chugh was the head of department of nephrology, and Professor R.B.S. Jadhav, he was the head of department of general surgery, and he was looking after transplant unit. Long time back. So, Dr. Jadhav did a marathon for these patients who have been treated by transplantation. Okay. Somehow, he forgot to call Professor Chugh. So there was a lot of problem, and after that, it was very difficult for Dr. Jadhav to do a transplant. I advise you keep the anesthetists, these endocrinologists, other people who are part of your team in the loop, so that you don't have problems like that.
Sir, I would like to hear something from Madam.
Well, it's an honor to work with all the surgeons. Being an anesthesiologist and an intensive care, I have worked with all of you from SKIMS to JVC to SMHS and now here. So I think an anesthesiologist should always help the surgeons. So the trend we have—
These are golden words. I think all of us should remember and tell all the anesthesia people that she has said it.
There was a trend.
Edge somewhere. Yes.
There was a trend that after 2 don't start the case, and BP is high and something like that, and they would start the cases at late. So I would tell them start before 10 so that their last round does not get postpone. And everybody is doing that. I think they are continuing to do that. Why? Because I have got my training from SKIMS. There was no concept of postponing any case. So during night duties also, I told Dr. Iqbal Salim also that some of the surgeons who are here, they would get a patient saying that it is appendicitis. So after going for rebound tenderness, I would tell them, no, I don't think it is an appendix. But we would not as anesthesiologists say no, because maybe there was 1% chance of a perforated appendix. So after that, there was a normal appendix and they could say it can be catarrh also.
Yes.
So that is how we learn not to say no to any surgery if the surgeon wants to do the case. And I have made another concept that if there are no beds available, give them imaginary beds for the patients in OTs. Because hardly 1% of the patients posted for surgery, they come back to ICU on ventilator. So hardly any patient will land on ventilator, except we know, like Whipples. Even Whipples we didn't put them on a ventilator. None of the patient of Bariatric was put on ventilator. Even triple Rhinoplasty, we did it first time. We didn't put that patient on ventilator at all. But we had some complication after 4 hours. We ventilated, intubated, extubated 3-4 hours. So hardly any patient should be postponed for water ventilator. This is for my anesthesia team here, and they have done the same here also.
Thank you very much, ma'am. Thank you very much.
Sir, always charismatic lecture and mesmerizing videos. Thank you, sir. I'm honored. But believe me that I have not sabotaged anything. It's a conspiracy.
I accept.
On my
I
left
accept.
side.
I accept. We should not keep people from the lunch.
See, ultimately, being the patron, this blame will come on me, so there is no sabotage.
Okay.
Yes. We are here to help you out.
I think there are some external forces acting for this.
No, there is no politics here.
But madam, history of Jakasi is a strong witness that whatever happens in Jakasi or Jakasigan, every blame is being put on Sanjay Bhasin. Yesterday also it was put on me.
So the blame has shifted now.
I think your conference has been a true,
Great.
successful, very successful.
I would request the organizers to go ahead with the felicitation before then we can proceed. First, let us felicitate the orator.
Thank you, sir. Now, I request our chairpersons to kindly felicitate our speaker, Professor Dr. Iqbal Salim Mir. Now, I would like to call upon stage Professor Dr. Ejaz Ahmed Rathar to felicitate our respected chairpersons. Professor Dr. Nazir Ahmed Salru, Professor Dr. Fazil Q. Pare, Dr. Nazir Ahmed Wani, and Dr. Harbinder Singh Bali.
Thank you. This national conference held at Government Medical College Anantnag is aimed at being a platform for the spread and exchange of ideas gained of years of experience and practice. There's much more to look forward to in this conference, but before that, we shall be having a lunch break, which will be followed by Professor K.L. Kapoor PG quiz competition in Hall C at 3:30 p.m. Kindly rejoin at 3:30 p.m.
General and Minimal Access Surgery, Government Medical College, Jammu. Dr. Nisar Hussain Hamdani, Associate Professor and Head, Department of Surgical Gastroenterology, Super Speciality Hospital, Srinagar. Dr. Rajandeep Singh Bali, Associate Professor, Department of General and Minimal Access Surgery, Government Medical College, Srinagar. And Dr. Mashkoor Ahmed Beg, Associate Professor and Head, Department of Internal Medicine, Government Medical College, Anantnag.
Sure. Welcome everyone to this post-launch session. I welcome Dr. Arshid Kema, Associate Professor, Department of General Surgery. He'll be speaking on standardizing laparoscopic distance fundoplication, a step-by-step approach. Dr. Arshid.
Where is the presentation, please? Presentation kahan pe? Thank you, Chairperson. Thank you so much, Dr. Nisar, Dr. Mashkoor. I know the most difficult lecture of the day is the one immediately after the lunch, because after such a tasty lunch, no one will be interested in academics. I'll try to minimize your torture by being very brief. हाँ ये वाला है बेटा ये हाँ हो गया वहाँ नहीं आ रहा है अभी आ गया Yeah, thank you. So, standardizing laparoscopic Nissen's fundoplication, a step-by-step approach. I have tried to break down Nissen's into basic steps so that it's very easy for, because there are many residents here who can easily understand how to perform a Nissen's fundo. Well, Nissen's fundoplication was first described as early as 1956 by Rudolf Nissen, but obviously at that point of time he used to do an open surgery. In the early 1990s, Dale Magny et al., they performed and reported the first laparoscopic Nissen's, and it is the gold standard for treatment of GERD, but it requires a systematic preoperative evaluation, precise surgical technique, and careful post-op management to achieve optimum results. With a preoperative evaluation, the job is mostly done by a gastroenterologist, and I am happy that Mashkoor is there. He knows how to evaluate these patients. A baseline investigations, contrast esophagogram, upper GI is mandatory. Esophageal manometry is very, very, very important. We cannot deny the fact that most of these patients do have motility disorders associated, so manometry has to be done and the diagnosis can only be done by a pH metry, 24-hour pH metry. Nowadays, we have wireless capsules like Bravo to guide us in the management. So, if you see the literature, definitely there was a meta-analysis and they found out that fundoplication definitely and significantly improves objective and subjective reflux outcomes, and definitely Nissen's is the gold standard, though we have partial fundoplications like Tope, DOR, and we could have transthoracic also, but Nissen's definitely has no match. So what are the basic steps? I have divided into 7 steps. First is the right crust identification. Second is to identify the retroesophageal tunnel. Third is to restore basically the intra-abdominal length of esophagus, because that is one of the very important anti-reflux mechanisms. Then we have to mobilize the fundus. Then obviously crurorrhaphy has to be done. A fundic wrap has to be placed around the esophagus, lower end of esophagus, and the wrap needs to be fixed. So, the first step, right crus. How do we identify the right crus? We start at the pars flaccida. Yeah, the video is running. So the pars flaccida is the flimsy layer of the lesser omentum. We cut it open and you will see the right crus appears. Here is the right crus that you can see. My recommendation, and I usually, what I follow, I do an inverted U incision over the right crus and go towards the left crus, cutting the Limberg membrane, that's the pleuroperitoneal membranes, and going towards the left side, trying to expose the left crus. You have to be very, very vigilant here sometimes, because most of the times, very, very minimal of times, you could have a left gastric that can give an accessory left hepatic, and that can get injured if we are not careful during this dissection. The second step is to create a retroesophageal tunnel. And how do we do it? We just have to identify the esophagus, go behind the vagus, and pass our instrument. And I usually like cruciolmy there, and I try to pass it under the esophagus, then get an umbilical tape to sling it around the esophagus, so that that helps us with further dissection. We usually use an umbilical tape. I do not recommend the Cialistic slings, because they are elastic and they do not get the same amount of tonicity as this umbilical tape does. We usually tie it, but not too tight, so that it holds the GE junction, and then pull it down. An assistant is there to pull it down. So the third thing, a very important thing, is to restore the intra-abdominal length of esophagus. How do we do it? We have to do a circumferential mobilization of the esophagus in the mediastinum. Here you see, we usually start on the right side because that is the easiest to approach. Then go anterior, then to the left side, and finally to the posterior. The sling helps us here because the assistant is pulling the sling in the opposite direction. Once we put it in the opposite direction, a counter traction is created so that we can easily go and dissect it here. I learned one thing from Dr. Ganesh Shenoy. He works in Fortis, Bangalore. He uses a gauze. I'll be showing you that thing here in this video. After the dissection is complete, we believe it's complete, we put in a gauze to push again into the posterior mediastinum to again achieve a minimal length, and the length of esophagus that you need to achieve is minimum 3 centimeter, ideal 5 centimeter. That should be the intra-abdominal length of esophagus. This is what I was describing, pushing in the gauze to dissect more, and it is very, very quick and very easy. So after that, you have to mobilize the fundus to create a wrap, because if we do not mobilize the fundus, there are some posterior fundic adhesions, and the wrap remains under tension and it can give way. So this is, we start at the greater curve close to the stomach, and we mobilize the short gastrics. Very shortly you will see spleen coming in the view. You have to try to enter the lesser sac. Sometimes it gives you trouble, especially in obese patients, but definitely you have to be a bit patient here, a bit cautious here, because spleen is there, there are vital structures near, and you can damage them. Again, an important point that you have to notice here is that sometimes there are posterior short gastrics that you need to take care of. After that, we do a crurorrhaphy. Crurorrhaphy is simply closure of the crura, opposing them together, but they do not have to be too tight. Again, a small recommendation here, we use a horizontal mattress suture here, passing it on, then with a backhand throw, you will see it. I will use a backhand throw of my right hand, the needle. I put a backhand throw and tie it. And you will see I am taking a good amount of belly of the crus. Some people do not recommend it, but I do not tie it too tight, because if you tie it too tight, there is chances of necrosis of the muscle, and that can lead to recurrences. Usually 2 or 3 sutures are required before we can achieve an adequate crurorrhaphy. One thing to note here is that once you feel your crurorrhaphy is adequate, you do not have to go too tight, too snug with the esophagus. There has to be some distance, and you have to believe that it should admit one laparoscopic instrument through it. You can see the apex there. It will admit a bit of here. Yeah, it admits a bit of laparoscopic instrument. That is what you should do, because if we do too tight, there will be post-operative dysphagia. Then these two I've clubbed together, the fundic wrap and the wrap fixation. Very important, the wrap, usually we use 3 sutures. At the distal end of the esophagus, we put in a wrap. And again, the first suture is between the fundus and fundus. Second suture here, you need to understand that we go through fundus, then esophagus, and then fundus on the other side, so that it remains there and it does not herniate. The wrap does not herniate. Again, the third suture would be between fundus and fundus. Important thing here to note is that sometimes what happens, the wrap along with the esophagus migrates into the thorax. To prevent that, we need to hitch the wrap with the right crus. That is also known as the Hill's stitch. So I'll be demonstrating that shortly. That will come in the view. The only thing that I would like to tell you here, most of the people recommend polyester sutures, but I do not use them. I have found it very difficult to tie them. Knotting is not that great. I use simple silk sutures and they are giving good results. And there was a literature review wherein they said that silk or vicryl can be equally as effective as polyester sutures. You have to remember one thing, the sling that I used initially, I do not cut that. I always pull on the esophagus so that I get my wrap absolutely at the right spot. If you are concentrating here, you can still see there is an intra-abdominal length of esophagus without the wrap. That's around 2 centimeters and the wrap is around 2 centimeters. So we have restored the adequate length of esophagus. One more thing to know, remember here is that before we do a wrap, we have to do what is known as a shoe shine maneuver to ascertain whether the wrap has been mobilized adequately or not. This is a short video. The chairpersons permit me. Is there time, sir? A short video. I'll just show the mobilization part. This patient was operated outside in Delhi, and here you see the anatomy is distorted. We try to identify the anatomy, and just in the similar manner we have to demonstrate the right crus again, but it was not easy here because there were a lot of adhesions, and the normal anatomy that you can achieve in 2 or 3 minutes in a normal fundoplication, it took around an hour to demonstrate the normal anatomy. You can see this is a huge defect here. Almost whole of the fundus has migrated into the thorax. We had a difficult time mobilizing it, and finally, but we managed to do it. We managed a good retroesophageal tunnel, and finally it was an easy job. Lastly, post-op, just one slide now. We have to avoid increased intra-abdominal pressure. Orals we start on post-op day 1. The patient usually goes home on the second post-op day. We usually give prokinetic laceride for 15 days first, and soft diet has to be used for 2 to 6 weeks, and the patient should be on low residue carbohydrate diet. There should not be too much of bloating because these patients do have a problem initially egressing the gas out. Thank you for your patient hearing. Thank you.
Very good, nice presentation. We can say that this gastrointestinal reflux disease is an area where now gastroenterologists also try to give a competition to the surgeons in that area. We have in many centers they are doing endoscopy procedures for the same. We can say that we don't see much of the reflux problems here. Not much of the what we call as esophagitis ulcers are there. In our setup, it is not much a problem, but yes. You can say the good. We have maybe the good competition between gastroenterologists and surgeons in this area.
No, sir, there is no competition. We only get the patient once the gastroenterologist refers it to us. There is no competition. You are the people who actually treat them and refer them once they are actually burdened with PPIs. They take a long standing PPIs. Patients are already on PPIs for quite some time, and it becomes bothersome for some patients. And what I want to apprise the crowd of is that it's very important to understand that GERD is a risk factor for Barrett's esophagus, and Barrett's is a risk factor for lower end of esophageal cancer. So we have to take GERD seriously. That's the only message I would like to give the audience.
My point was that there are some endoscopy procedures being done.
Absolutely, sir. But unfortunately, I don't think we have them in Srinagar.
My trials for that, but they are.
Yeah, definitely they are there.
Dr. Rajandeep Singh Bali is requested to come to the podium to join the chairpersons of this session.
Now we welcome Professor Dr. Tarun Mittal. He is Vice Chairman and Head of the Unit, Senior Consultant, and Professor Gripmer. He will be speaking on redo fundoplication. Possibly this session will be aired online.
Yeah, I am there online.
Welcome, sir.
Yeah, hi. Can you see my slide?
Yes, sir.
Is it visible?
Yes, it is visible, clearly visible.
Thank you. So I bring greetings from Sir Gangaram Hospital, and at the onset I would like to thank Zahid and whole of the team from who is organizing the Kasicon, and would have loved to be there, but we know all the circumstances that happened, and would definitely like to come at Pelgaon sometime and be there with all of you at some maybe months.
Dr. Tarun, we had a doctor here from Calcutta. You would have come here. Dr.
Yeah. I was also on a holiday. I just joined yesterday.
So I want to
Yeah.
Dr. Tarun, हालात को blame मत करो. आप नहीं आ सकेंगे आराम से.
Yeah. Yes.
Carry on.
Yes. I was talking about जब पिछली बार मई में होना था जब के लिए, that I could not come.
Okay.
That it was cancelled. It was cancelled, na, that way.
So you can carry on. No problem.
Yeah. So we now, as the fundoplication has become very common surgical procedure which is being done by almost all the laparoscopic and general surgeon. So the more patients are coming up with failures also because of the fundoplication which has happened. And from the patient's perspective, it is failure to provide the durable symptom control. Whatever the symptoms patient had, it has come back again, or undesirable symptoms which was not there and it has again new symptoms have come. So approximately 3 to 6% of the patients would be complaining of severe symptoms or mechanical wrap complication which might require revisional surgery from the total number of patients. But the radiographic recurrence can be seen in 50% of the patients. So you do not require most of these patients to be operated again if they just have a radiographic recurrence. Just if the symptoms are severe or there are other complications, then only they should undergo a redo surgery. So there are a lot of factors. One is a patient factor which can cause the recurrence. The other is a tension. And the third is the technical factors because of which it causes the recurrence. So there are two types of tensions which can happen. Either it can be axial tension, which is parallel to the esophagus, and which because of which there is cephalad migration which happens. Physiologically, approximately 2.5 centimeter movements is always there, and it is because of the elastic recoil of the phrenoesophageal membrane, which is acting as a counteracting force. It diminishes over a period of time its thickness and its strength. And if the patient has shortened esophagus, then this concept of axial tension arises and which can cause the recurrence. The other is a radial tension which is between the two hiatus. It is, as we all know, dynamic nature of diaphragm is there. It's a constant motion is there, which causes breakdown of the sutured crural repair over a period of time. And this manifests as difficulty in intraoperatively. We can recognize this if there is difficulty in reapproximating the cruras when we are operating these patients. And if we recognize that and do correct these things at that time, then this recurrence might not, we might not have to operate these patients again. The other factor which can be there is if patients do nausea, if they have nausea, vomiting, or do retching post-operatively. So they should be told post-operatively to avoid, not like other laparoscopic procedures as lap chole or hernia. They should strictly avoid heavy lifting, straining, strenuous exercises. We do not use nasogastric tubes. One should avoid opioids, tramadol, and one can preemptively use these dexamethasone and metoclopramide to reduce the incidence of nausea and vomiting post-operatively. The other factor which can cause recurrence is BMI more than 35, and if they are very obese, then they should be given a dietary counseling and might have to consider a bariatric surgery along with the hiatal hernia surgery rather than just doing a hiatal hernia surgery. So there are other factors like the technical factors, misplaced wrap, incomplete hiatal dissection, you did not identify the G junction well, division of short gastric was not there, then they get more tight fundoplication can be there, crura can be tight, or you have loose sutures are there, and proper training of the surgeon experience is also very important when we are doing these surgeries, and which can cause recurrence if they have not been properly trained. So the symptoms are almost same as the preoperatively for the primary surgery, the heartburn, regurgitation, dysphagia or the chest discomfort. And most of these patients should be managed initially with conservative management, and if they do not resolve or there is complete dysphagia to solid also, then you might require investigation. Otherwise, one should try to give them conservative treatment, and if they do not improve over a period of time, you might have to investigate and then plan a surgery. Initially, in preoperatively, counseling is very important because most of these patients are taking the food in gulp preoperatively. So some amount of dysphagia is a part and parcel of a fundoplication, which will slowly resolve. So that these patients should know, and they should be counseled preoperatively. Then these patients do well postoperatively also. So after, if we have decided that patient might require investigation, so this is a test which used to be done very commonly, now is being done, but now being done less commonly. We now more going for CT volumetry and CT three-dimensional imaging, which we will be showing you in our CT scans which we do. But this is a very good investigation, and it tells you the status of the benign esophageal pathologies, esophagus, stomach, lateral view, how much is the hiatus, and what type of hernia it is there, sliding, paraesophageal, mixed, where is the G junction, where is the fundoplication. These all things can be done. A very good radiologist can tell all these things, and these are the types of failure which all should know, which have been studied on barium esophageogram only, and but now this can be seen by CT scan also. So this is a type 1A failure in which both the G junction and the fundoplication as herniated above the hiatus. There is increased radial and axial tension. It is because of that, because of it both G junction and fundoplication is one. This is the most common type of recurrence which is there, which I will be showing a video soon. Then the other is a slip fundoplication, which is type 1B. This is in which the G junction is above the hiatus and the fundoplication is below the hiatus. It is misjudging the location of the 2G junction. That is one of the reasons which can be there, or placing the wrap around the cardia instead of fundus. Increased radial tension can result in this type of pathology or this type of failure. Then there is type 2 failure in which the herniated stomach or greater curvature is above the G junction or fundoplication is below the hiatus. So the greater curvature is above, but the G junction and the fundoplication is below. This is because of breakdown of pleural repairs. And type 3 is in which if you utilize the mid body of the stomach to construct the wrap, this patient will have a dysphagia, that is type 3 wrap failure. So endoscopy is very important. You can see the anatomy descriptive. Every type of failure has its distinct anatomy and experience. Endoscopist can see that. You can see the esophagitis, what is the level of esophagitis, if there is Barrett's or not. And sometimes you can see if there is a reduce, you can see a mesh or a foreign body erosion or a sutures, which can be seen with the help of the endoscopy. So these are the various types of anatomy which can be seen, properly positioned, intrathoracic, disrupted fundoplication, twisted. All these can be seen by an experienced endoscopist. So the other very important thing, if one has decided that one will be undergoing surgery, or some diagnosis might have been missed, or for example, ecclesia manometry was not done preoperatively, which should always be done in all the GRD patients to assess the motility of the esophagus and the sphincter also what is there. So it might be a missed ecclesia, so you have to do the manometry for these post-operative dysphagia. They can assess the esophageal motility, they can assess the G junction, fundoplication configuration. Their distinct patterns are there based on the esophageal sphincter area. What is the IRP, integrated relaxation pressure? Where is the high pressure zone? What is the integrity of the distal contractile? Or how is the esophageal motility? Based on these 5-6 things, the expert endoscopist can tell us what type of wrap failure it is. And post for us during surgery it is important. If patient has low motility or absent motility, then you might have to do a two-pay fundoplication instead of a Nissen fundoplication, because there the dysphagia chances is higher. If the patient have post-operative bloating, then you might have to do a gastric motility study to see what is the gastric emptying, and this if there is delay, then you can put a Botox or in the pylorus also if it is required. So ultimately, if patient symptoms are refractory or dysphagia is there, which is not getting managed with conservative treatment, you might have to operate these patients and plan a surgery. The planning surgery, you will have to see what is the reason for the first operation failure, what is the esophageal length, how much is the motility of the esophagus, whether there is presence of Barrett's esophagus or not. So it might change the surgery if it is required. The Barrett's should be stable, where there is dysplasia or not, no dysplasia, or just the metaplasia. Based on that, you might have to manage the Barrett's, or concomitant gastric pathology, like if there is gastric motility or if there is another pathology there, you might have to tailor the approach to the patient. So many things have compared, like open transabdominal, transthoracic and laparoscopic. Overall, it is laparoscopy is shown to have reduced hospital stay, decreased pain and lower complication rate. So most of the one will prefer a laparoscopic approach over a laparotomy or a thoracotomy or a thoracoscopic approach. So these are the steps which I will be discussing when we will be showing the video. So most important is adhesiolysis, which adhesions might be there, and the hiatal dissection. And overall then we have to take down the previous fundoplication, convert it into a same anatomy which was before the surgery, and then plan the procedure. If we do not take down the previous fundoplication, then the results might not be the right, and you might be missing something. So I'll just show you two videos. So this is one video in which patient was operated in some center, and after 4 to 6 weeks, patient had dysphagia and pain, and somehow that surgeon was out of country at that time. So the patient came to us. So we got the CT scan done. In this you can see pleural effusion also there, and the wrap has migrated into this thorax, with G junction also migrated into the thorax. So here this momentum was into the thorax, into the mediastinal cavity, and by slowly by pushing and pulling, we could remove the stomach. Stomach is a very thick structure, so it generally does, and it does not get injured. And now we are using the ligashore and started dissecting the hiatus. You would see that whole of the wrap is migrated inside, and we are still at the level of the stomach and the fundus level. So slowly, first the left pleura was dissected, now we are dissecting the right pleura. Now the lips of the fundoplication which are there, right and left, and then they have to be dissected. They were very much adhered to the pleura. You can see that one side pleura has got opened, and because they were very much adhered, so one should not be very worried about this. You can place a chest tube if it is very large hole. Small holes can be managed, just does not require any management. They will close on its own because we have not injured the lung. So here you would see that we are undoing the fundoplication. Ethibond suture is seen. One should not use an energy source to undo this, and one should always use a sharp dissection and a sharp scissor to divide this. Sometimes one uses a stapler also to divide this if one is not confident where the plane is. Here now we are dissecting from the left side the lips which are of the wrap which is there, and which was also adhered, and in this you can see the pleural effusion which we were seeing. So in both we placed a bilateral chest tube because it was very large, pleural hole was there. And here after dissection, whole of the wrap has been dissected, and we can see G junction is down, and because it was a large hiatus hernia, there is controversy what to do for place a mesh or not, but we generally are placing a mesh, and one should place a mesh which we are using it in IPOM. Initially Crurasoft mesh used to come, which is not available now, which used to be a butterfly shaped mesh, PTFE. Here we used the Bariatric mesh and stitch. One should not use tackers here to fix it. It is better to use sutures because tackers. Yeah.
I'm sorry to say your time is over. You already exceeded it by 3 minutes.
So I can stop, no problem. Thank you.
Thank you, dear. Thank you, Dr. Tarun. We'll be proceeding to the next speaker. That is Dr. Jasmeet Singh Ahluwalia. God bless you, Tarun.
Okay, thanks again to the organizers and many congratulations to you, sir, and all the whole organizing team. It's been a wonderful day here at Anantnag, and I really am enjoying the content here and the participation and the zeal of the all the participants. I'm Dr. Jasmeet Ahluwalia from Star Hospital, Jalandhar, and I'll be dealing with some newer concepts in weight loss. And Dr. Iqbal has already told about mini gastric bypass, which is being done, sleeve gastrectomy and all. So I'll try to skip that part and I'll try to focus on something which is a little newer in the kit on the block and which is a little more simpler. So the things which have been already discussed, I'll try to skip. Can I have the slides, please? So you already know the epidemiology, the rising incidence of obesity and the importance that's now even in a state of J&K, which is a hilly state. This is probably the only disease which has so many comorbidities associated with it, starting from as simple as diabetes to heart failures to almost all the systems of the body. And this is one disease where doing one procedure we can take care of so many comorbidities. So it is actually defined as the condition where the excessive fat accumulation starts to harm the body, and there are many definitions, but we'll rather not go into that. So the epidemic is rising because of the urban city designs and the availability of high calorie food. The discrimination also remains high against the obese people, and even in our own setup of medical distribution, we see a lot of discrimination being done against obese patients, and it's being on record, and there are no laws against any discrimination being done against any kind of obesity. So the simplest of all is the BMI on which we actually base it, even though it's not the best way of defining obesity, but still it's the simplest, so keep on doing it. And how do we deal with that? Where for simpler patients, our normal BMI is around 23 in Indians, and up to 27.5 we can simply do lifestyle modifications. And from 27.5 onwards we can start adding either medicines or balloons or other some simpler forms of modalities. And from BMI 30 onwards now, even though usually we started at 32.5, we can start adding bariatric surgeries of different kinds. So why the other things do not actually help? Because once the BMI is more, it's more than 32.5, then it has been shown that usually up to 95% of the people, they are unable to lose enough weight, and then even those who 5% who lose, they again 95% of them they regain the weight. So that is why some kind of intervention is usually required once the BMI exceeds 32.5. So these are certain indications by OSCE, and there are certain contraindications for doing a bariatric surgery. And I'll just show you some of the things which are less discussed, like intragastric balloons. There are different kinds. The basic idea is that they fill a part of the stomach and it slows down the passage of food, and it can take out almost 15% of the excess weight. So it's not indicated for those who are morbidly obese as a definitive procedure, but for those who are less morbidly obese, we usually do it up to BMI around 32. And for anyone who is too high risk as a patient for bariatric surgery as a stepping down procedure. So the main advantages being they're minimally invasive, they have a good safety profile, they are reversible, and the risk of malnutrition is almost negligible. But again, the disadvantages are that the initial tolerance can be poor. Patient may have a lot of retching and vomiting for the first few days. These are temporary procedures. They have to be taken out by the end of anywhere between 5 months to 1 year. The weight loss is limited and the weight regain is a problem. This is the simplest of all the Illusion swallow pill. So you need not. So we need not give any anesthesia. It's just like swallowing a pill. So this is a small capsule which we just ask the patient to swallow. The patient has been taught how to swallow this big capsule already. So the patient takes feed the CM shot, and then we'll simply pull this catheter. It gets detached. Patient has a mild cough thereafter, and we make sure that everything is out, and then the patient will be out. So this takes care of around anywhere between 10 to 15%. Patient does have to follow a low calories diet as with any other procedure. And the other balloon that we usually use is PATS 3 balloon. This is an adjustable balloon. Since it's little bigger, so it cannot be placed, it cannot be just swallowed. It has to be attached to a tape or endoscope and then to be placed under anesthesia. So we do a preoperative check endoscopy to make sure patient doesn't have a severe gastritis or esophagitis or a hiatus hernia. Once it's a normal stomach, then we open up the packaging of the balloon. These are certain things that come with the balloon. Once we clean the tip of the endoscope, we'll fix this balloon to the tip of the endoscope, usually on the left side. And this is the balloon with the attached catheter. So before we introduce, we need to fix it with the catheter, which will be filling the balloon. So once it's properly attached, the extension tube will fix the balloon with the endoscope. This is the balloon being fixed with the endoscope. This is all synthetic condom shape of thing which can be used to fix it and to implant it on the tip of the scope. So then you just apply a lot of jelly and push it through the throat into the stomach. Once we retroflex the scope and see the whole of the balloon is inside, then we start to fill it. So we can fill anywhere between 250 to 400 ml of fluid in the first go, and since it is adjustable, thereafter if the patient doesn't have enough weight loss, we can readjust it at the intervals of 2 months, once or twice. And if the patient feels too much of discomfort, we can reduce some fluid also. So this balloon can be there for up to 1 year. That's the maximum life. And again, the weight loss same quantity is anywhere around 10 to 15%. So then is the bariatric surgery. I think most of this has been discussed, but still I'll discuss the basis. So what happens as the patient gains weight, the stomach also becomes bigger. So it is thought that the fundus is bigger, so the ghrelin is more, the hunger is more, the quantity of food now required to fill the stomach is more, the transit time is more, so the food travels less quickly through the intestines and gets more absorbed. So the simplest of all is sleeve gastrectomy, as sir already told. We just resect the excess part of the stomach, including the fundus, and just leave a small sleeve of the stomach so that the ghrelin hormones go down, the quantity of food now required is much less, the transit time is decreased, so the food passes very quickly, and the incretin hormones, they increase, so the patient gets relief from diabetes and other associated comorbidities. So very quick video. We just divide the stomach on its greater curvature, remove whole of the greater omentum, starting from around 2 centimeters from the pylorus and going right up to the OG junction. So I've suspended the stomach with a suspension suture, actually by attaching a suture onto a JP drain, and this is the top end of the fundus, and we're just exposing the left crust so as we take the whole of the fundus, just divide any posterior adhesions. Then we place a bougie, which is a standard gastric bile calibration tube of around 38 French, and we resect whatever is the excess stomach on the greater curvature side and just leave as much of the stomach on the lesser curvature of side as much is the size of the bougie of around 38 French. So again, a very simple procedure. I think more and more youngsters should take up, because the basic fear among the minds of the people is that these are very big surgeries and very challenging patients. Yes, patients can be challenging, but usually these procedures are quite straightforward and simple. And once this sleeve is done, we just take it out through this 15 mm port. Similarly, now what is the most common bypass is the mini-gastric bypass. Already it has been told twice. Again, the same principles, the hormones go down because the fundus has been dissected, and the absorption of the food becomes much less because part of the intestine has been dissected free. This I've already shown in the morning. I'll just go through very quickly. So you start dividing the stomach, and you start to make two different parts of the stomach. So one which remains on the medial side is being in connection with the esophagus, and one on the lateral side is disconnected. And then this medial stomach is being anastomosed to the jejunum. The bypass length can vary depending on the patient profile, and you eventually what I'm trying to convey is that being fat to fit is not just a cosmetic procedure. It takes care of so many things. The diabetes gets resolved in more than 80% of the people. The BP gets resolved in 92. Heart disease risk reduction, GRD reduction, asthma, polycystic ovarian disease, migraine, depression. Patients' quality of life improves in over 95%, and they can add up to 10 to 15 years of age in their life if bariatric surgery is done at an appropriate time. This is our first patient operated more than 10 years ago now. She had diabetes, obesity, NASH, a lot of diseases. One of my relatives, now she has lived for 12 years. Thereafter, we operated her sister, her daughter, all received pediatric surgeries. And with one surgery, all the diseases are gone. Thank you. Thank you.
Thank you, Dr. Jasmeet.
It's a pleasure to invite Dr. Mohammad Yunus, our dear colleague, consultant surgical gastroenterologist at Sher Kashmir Institute of Medical Sciences. He'll be speaking on principles of liver resection. Welcome, Dr. Yunus.
Thank you, organizers. Respected teachers, dear colleagues, friends, and students, I'm here to present a talk on the principles of liver resection. So this is a painting. There's a myth of Prometheus who was chained by Zeus. The eagle would feed daily on the liver, and the liver would regenerate the next day. At present, liver resections are based upon the precise knowledge of natural lines of division of the liver, which define the anatomical surgery of the liver. Nomenclature: the Cuino was the first. He gave the segmental anatomy of the liver. In his description, he divided the liver in the functional right and the left liver by the main portal caesurae in which the middle hepatic vein runs, which there is the liver in the right and left liver. Likewise, the right liver is further divided in the anterior sector and the posterior sector, and the left liver is divided into the left lateral and the left medial sector. The liver is a dual blood supply. The CT anatomy, the red line divides the liver into the right liver and the left liver, and the green line divides the right liver into the anterior sector and the posterior sector. The first order of the division of the portal vein, accordingly, the liver resection is defined by the anatomical term. The resection of the segment 5, 6, 7, and 8 is the right hepatectomy, and the resection of the left hemiliver, segment 2, 3, and 4 is the left hepatectomy. The second order division, the resection of segment 5 and 8 is the anterior sectionectomy, and resection of the segment 6 and 7 is the posterior sectionectomy. Likewise, the resection at the third order division, the resection of individual segments is called a segmentectomy. So there are the goals of the functional assessment of the liver. There should be proper patient selection and the prediction of the safety limits of to what extent the liver we can resect the liver. So we need to know the liver functions, the coagulation profile. We need to know the child score, MELD score, and these tests like galactoside elimination test is done frequently. The normal liver, the 60% comprises of the right lobe and the 35% is the left lobe. Before going for the liver resection, we need to know the detailed anatomy of the liver, the hepatic arterial supply, and because in this picture there shows the accessory right hepatic artery, and in the lower picture, CT picture shows the hepatic artery arising from the superior mesenteric artery. There are certain bile duct anomalies, like the first picture, the right posterior sectoral duct, then the left duct. So before going for the liver resection, the detailed anatomy of the bile duct anatomy we should know. the estimation of volumetry should be done so that the future liver remnant is adequate for the patient. The CT volumetry is done by the CT volumetry, and there are softwares. We need to prepare the patient for liver resection, like we need to optimize the patient, decrease the jaundice, anemia, and child scoring is done, and see the site, size, and vascularity of the lesion and resectability. The operative procedure, there's a proper positioning, bilateral subcostal incision or Makuchi incision used. The anesthetic condition, CVP is, we need to maintain the CVP below 2 to 5, and the patient is pushed in 15% tender blood position. But these are the operative basics in liver resection, like inflow control, outflow control, and parenchymal transaction. First, we need to mobilize the liver. Then we need to take control of the inflow. Like it was first described by Laro Jacob. It involves a ligation of the right portal pedicle, and it is transected and then portal. And sometimes we need a Pringle maneuver. Inflow control is done first, then parenchymal transaction is done, then we need to do the outflow control. In fact, we need to know the I am showing a video of the posterior sectionectomy being done. Mute volume. So this was the lesion in the segment 6 and 7. We did a posterior sectionectomy, and after proper CT and we detailed anatomical knowledge, then we did the Makuchi incision is given. The liver is mobilized. This is a lesion in the segment 6 and 7 of the lesion. We had planned the posterior sectionectomy, and after proper mobilization, we need to go for inflow control. So this is the outflow. We are dissecting the right hepatic vein. We need to lift the liver from the IVC. Then we go for this is the inflow control. We take the gallbladder down by the fundus first method. Identify the right hepatic artery. This is the Rovier sulcus. We are taking the posterior sectoral branch of the right portal pedicle, taking the control of the inflow of the segment 6 and 7. Then we ligate the posterior sectoral pedicle. After this is the posterior sectoral branch of portal vein. This is we are taking control of the artery, hepatic artery, right hepatic artery. Then we mark the transaction line. The ischemic, there is a ischemia here in this posterior sector. There is a ischemic line, so we may mark the transaction line. Then we start the parenchymal transaction with a water jet, and we ligate the small vessels with multiple clips, and we proceed to the ischemic line. Then we go deep in the ligate the small bile ducts. Then deeper parenchymal dissection. This is then we apply the stapler at the end of it, and we conclude the posterior sectionectomy. I will show another video of the left lateral sectionectomy. This has been done by the falciform, and the control is by the ligamentum teres approach. This is the inflow control. We are taking the inflow control of the segment 2 and 3. This is the portal pedicle in the ligamentum teres, ligamentum teres approach. We take the control of the segment 2 and 3 pedicle, intrafascicular glycine and pedicle, intrafascicular glycine approach we are using. There are two methods of the Glissonen, extrafascicular and intrafascicular. I am using the intrafascicular approach. Then I am looking for the segment 3 portal pedicle to the segment 3 of the liver. I will take control of it, ligate the pedicle. This is the segment 3 portal pedicle being dissected. Then this is, I will take control of the segment, then I will ligate it and cut. So inflow control of the segment 3 is done, then we go for the inflow control of the segment 3. Likewise, this is the portal pedicle of segment 3. Then we have started the parenchymal transaction after demarcating the ischemic line of the segment 2 and 3. This is the parenchymal transaction. This is a complete avascular liver, or rather segment 2 and 3. Then at the last bit of it, we applied a stapler, then do a left lateral sectionectomy. So main steps are inflow control, parenchymal transaction, and the outflow control. Thank you.
Thank you, Dr. Yunus. Nice video presentation. One particular thing I noticed it as compared to rest of the centers, most of our liver resections are for benign diseases. Is it same at your place?
No.
Or do you more hepatocellular carcinomas than benign?
No, we have a mixed population of the patients. Like nowadays, for benign, we are doing alveolar hydrated or more of our cases. We do a good number of HCC. We do hyalurocholangio right hepatectomies and good chunk of hepatic resections for oriental cholangiohepatitis, right? Left lateral sectionectomies, and of course radical cholecystectomy for say gallbladder, and we do resections for HCC.
Fine, thank you. Thank you.
See, Yunus is one of our students, honestly speaking, who has made us feel proud.
Thank you, sir.
And I think this is without anything. Number one is his humility, and technically he has grown very much. He does a very flawless surgery. And even I have involved him 2-3 times in our cases. Once it was a metastatic colorectal disease. And this is what I want to convey. Never feel small in collaborating. He is my student and I am proud to collaborate with him.
Thank you, sir. Thank you,
for the betterment of patients. Excellent job.
Sir, that is so nice of you that you acknowledge your juniors and feel like collaborating with your juniors. You don't feel less with that. Great of you. Nice of you. Thank you, sir.
Thank you.
Thank you, Dr. Yunus. Now I will like Dr. Mahmuda. He is a professor and head, Department of Surgery, Skims Medical College. He will talk on laparoscopic management of large renal calculi, a case series from Skims Medical College.
Assalamu alaikum and very good afternoon to all of you. I am talking about the work from a general surgery unit, from the perspective of a general surgeon. So sharing our experience of laparoscopic pyelolithotomy for large renal calculi. So he's the person, Thomas E. Starls, who is the pioneer in liver resection from USA, a surgeon from USA. He's also the first person to start with the liver transplantation, and I quote his saying that what was inconceivable yesterday is barely achievable today, and open becomes a routine of tomorrow. So we know various options for large renal calculi. There have been the traditional open surgeries like pyelolithotomy, extended pyelolithotomy, anatrophic nephrolithotomy, and many more nephropyelolithotomy together. Then came the era ESWL. It had many contraindications, relative and absolute contraindications. Then in the logical setup, we have the PCNL procedures being performed, RIRS. Now for a general surgeon, he will be obsolete if he will not be doing the urological procedures which he can manage very easily at his department. So the work has already been published in the international journals. Our experience, what we call a large calculus is more than 2.5 centimeters. So all the 10 patients were in that group in 1 year, 1.5 years between July 2021 and 2022. We did standard laparoscopic retroperitoneal approach in all the cases using a 10 mm 3 ports, one 10 mm in the renal angle and two, I have shown the picture, one at the 12th lip and second at the highest point of the iliac crest. So we'd use it indigenous balloon, a glove finger, we'd cut double and put it on the suction cannula and inflate it with a normal saline about 1000 ml and wait for 5 minutes to create a space in the retroperitoneum and use it per op stent in all the patients. So inclusion criteria were that a solitary calculus with a large stone more than 2.5 centimeter size. So contraindications, multiple stones or patients with bilateral stones or who had already been operated for open surgery, and patients who had congenital anomalies were excluded from the study. Now the results were we operated 10 patients of these large calculi, and a retroperitoneal approach was attempted in all the cases. Female-male ratio was 4:1. We had 2 females and 8 males. Mean operative time was 107 minutes. And average blood loss was 98 ml. Hospitalization was between 3 to 5 days, and stone clearance was in all the patients except one patient who had extended Stag-Harden calculus in the minor calces. So one patient who had pyelonephritis, severe pyelonephritis, I will show the picture, got the UTI but got corrected, he got well after antibiotics after 2 days, and we discharged him. This is the patient who got converted into open. You can see the stone migrated in the minor calyces. So there was a technical difficulty in retrieving the stone because we had to do an extended pyelolithotomy where we need to have a gallbladder retractor and in taking out the stone. So this is a short video of my presentation. This is a large calculus. You can see on the right side. So this is the first port we made about 1 centimeter in the renal angle. Then this is the picture after inflating with the balloon, and this is the guide we use as a needle. And then use 2 more 5 ml trocar, 5 ml position trocars we use. This is the dissection now we are performing. Mind you, retroperitoneal surgery is very less being performed because number one, the surgeon is not familiar with the structures and normal anatomical structures. And number two, there is a potential space. Retroperitoneum is a space which we have to create. It is not a transperitoneal space, abdominal cavity where we have a big space. And so it's a very less space. You have to create the space. And one more difficult problem with retroperitoneum is that it absorbs light, whereas peritoneal, transperitoneal, it reflects light peritoneum, and so you get visibility problems also, and you are not well versed with the anatomical landmarks. So this is the renal pelvis we have approached after identifying the ureter and identify the psoas muscle. So I had to make a Y-shaped incision on the pelvis, you can see, because the stone is extensively large. It was about 9 centimeters. You will see yourselves how difficult it was to retrieve it. So this is the incision we made on the renal pelvis. This is a Y-shaped incision. So the problem was in retrieving this stone because one of the horns was in the calyx, so it was this, you can see on the right side, so it was difficult, very difficult, and I broke one hook because the stone weighed about 92 grams, and we can see the normal egg weighs 60 grams, so it is more than 1.5 size of an egg. So taking out a 92 gram stone from this pelvis is very difficult. As Dr. Iqbal Sahab said, our jaws of the forceps open only by 5 centimeters. Since it was a 9 centimeter, I had a technical difficulty in holding the stone. So this is the stent we are using, and this is the pelvis. We are closing back over the stent. I use intraoperative stent, not pre-op. So the problem, yes, was the retrieval of the stone, and the weight of the stone, because it will go down, and I had to tilt the patient on the opposite side and with the long this sponge holder and guiding it with my finger slowly with moved, and it took me more time to retrieve the stone than to take out the stone and do whole the procedure. So this is the pelvis we are closing back. So I'll be a bit faster. Oh, sorry. So this is the last. Why can't it move forward quickly? ये अच्छा ना ये पका ये कर्सर इसका कर्सर नहीं चल रहा है ये कर्सर कैसे फॉरवर्ड जल्दी करना है ना इसमें हाँ आगे करना है हाँ आप वहीं पे चलाओ आप लास्ट मिनट इसका दिखाओ लास्ट मिनट इसका कर्सर पे लास्ट मिनट लास्ट ना चलो लीव इट अगर नहीं हो रहा है नहीं अगर देखो ये क्यों नहीं आ रहा है इसमें अब ये करो आउट पे इस पे आएगा Yes, just yeah. Just so this is the last steps here. So this is the stent and pelvis being closed. So finally we put a drain in the retroperitoneum. So this is the incision last, you can see the size of the stone, this is the big, and this is the weight, 92 grams, we have made the stone. So this is the stent, the post-op picture of this patient. Now there's one more patient whom I talked about that this patient had pyelonephritis, severe pyelonephritis. Why is not moving? Just I will. So this is the second video. This is a patient again with the large stone, and we have created the retroperitoneal space. So you can see the dissection being carried out, the renal pelvis here. There are definite advantages of this retroperitoneal approach. That number one, you are not violating the peritoneal cavity if there's any infected urine or if there is any post of sepsis. So you take it care of, and it is just restricted to the retroperitoneum only. So there's no peritonitis. Number one. Number two is that the injury to the viscera are avoided because you avoid the entry to the peritoneum. So there are the advantages, but it's very technically difficult. You can see the renal pelvis here. We are dissecting over the renal pelvis. So this is the Gerota's fascia. We are dissecting. We had to mobilize the kidney. So this is we are opening the renal pelvis. And this patient had a lot of pus, infected pyelonephritis. He had pyelonephritis. It was infected. See the pus coming out where we opened the renal pelvis. He had many more small stones which we did not pick up preoperatively. So they were intraoperatively. We found them 2-3 stones, small stones. So this is the renal pelvis. We are dissecting to make it wider and take out the stone. You can see the pus coming out. So we had to enlarge the pylotomy incision. So this is the maximum jaw opening. We could take it out. So it was around 3-4 centimeters. Again, it had a horn which was stuck up. So it took us time to retrieve it back. So this is one more fragment. So we had 4 small associated stones, and this is the stent. And we closed all these above the stent. This was a very small pilotomy compared to the first patient. So this is the final picture. Now, the advantage of retroperitoneal I have already discussed. The disadvantages, we have the anatomical landmarks are not there. Then strategic post-placement is critical, very less space. Then large specimen retrieval, and this is the conversion. One patient. We had just 1 minute, please. So this is a post-op KUB. The strengths of our study are that it's a viable alternative where endourological facilities are not available, and it has a promising results. And limitations are the single center study and a very small group we have studies. So conclusion derived is that inference can be derived that retroperitoneal laparoscopic approach is a promising alternative to with encouraging results despite this technical difficulty. It yields high stone-free rates and low post-operative morbidity. It is safe and feasible option that can be recommended for the management of large renal calculi if proper logistics and expertise is available in the general surgical units. Since the number of patients is too less, so cannot come to the conclusion. However, we'll adapt the more cases to come up with the large series. Thank you very much.
Thank you, sir, for a very good talk on this.
Yes,
How much was the incision there from moved and long stone?
First stone, yes, sir. The stone size was 9 centimeters. It was 10 centimeters incision, 1 centimeter larger than that. Because I had to struggle a lot. I tried to take it out through a smaller incision. I thought skin will get stretched. But because of the weight, heavy weight, I could not hold it in any forceps. I tried my sponge holding, but because of fulcrum effect, so it would not open. So I used closed sponge and my 2 fingers inside and then tried to retrieve it.
I think there is a very space where we don't have muscles.
Yeah.
That is a lumbotomy.
Yeah.
You just make a linear lumbotomy and you can take out the stone. It's a very
One thing I did, because the weight of the students was 92 grams, so it would go posteriorly. So I shifted the position of the patient so that it could fall down, and then we managed to get it through 9-10 centimeters.
I think that's what I'm saying. Lumbotomy, small incision, without cutting any muscles. You have just cut fascias.
No, we have not cut muscle. It's only skin we have cut. Muscle is okay. That for it was because retroperitoneal space we have already created. It was only just in the skin we had a problem taking out.
Okay.
Rest that was okay.
Fine.
Okay.
Thank you, sir. Now I would like to invite Dr. Zahid Mohammed Ratan. He is Associate Professor, Department of General Surgery, GMC Anantnag. He will be talking on laparoscopic management of pelvic urinary obstruction. Sorry.
Respected chairperson, faculty members, delegates, good afternoon. Today I am presenting laparoscopic management of pelvic uterine junction obstruction will ensure experience of 12 cases. Principles of pyeloplasty: excision of atretic segment, reposition of the crossing vessel, if there is a cause as a crossing vessel for PUG obstruction. And the pelvis should be dependent and funnel shaped, preserve the vascularity, and the anastomosis should be tension free, and anastomosis should be watertight. Few words about the PUG obstruction. Untreated pelvic PUG obstruction will lead to infection and many other complications. The gold standard to treat this condition is pyeloplasty. With the increasing popularity of minimally invasive surgery, laparoscopic pyeloplasty emerged as a potential modality better than open pyeloplasty. Multiple surgical options exist to manage the disease, including open pyeloplasty, laparoscopic pyeloplasty, robotic assisted pyeloplasty, and the endopyeloplasty, that is the endoscopic procedure. Open pyeloplasty was first described by Limberg in 1986 and later on was modified and popularized by Anderson and Heine, and since then open pyeloplasty has become the gold standard treatment for PUG obstruction with long-term success rate of greater than 90%. The first laparoscopic pyeloplasty was performed by Cauchy in 1993. This technique was Anderson-Heine's dismembered pyeloplasty. Schotler et al. Also introduced a laparoscopy in the same year. Although laparoscopy has become the popular in management of PUG obstruction, some surgeons still debate about the increased risk of complication with it. We present you our initial experience with laparoscopic management of PUG obstruction. This was the observation study for 12 patients who was diagnosed for PUG obstruction May 2024 to May 2005. Diagnosis was based on the history, clinical examination, ultrasonography of abdomen, CT scan, and DTP scan. After confirming the diagnosis, both options were given to the patient. Factors that were evaluated: the operative time, blood loss, post-operative complication, conversion to open, hospital stay, and the recurrence rate. And the inclusion criteria was patient is greater than 18 years with a primary PUG obstruction, and patient with secondary PUG obstruction that was excluded from the study. Patient is not fit for laparoscopy, and the patient is have bleeding disorders. And the data of the patient: total number of patients known, in which the males were 8 and the females were 4. Mean age was 28.3. Intrarenal pelvis was present in 2 and crossing vessels in 2. Associated calculus in 1. And laterality, that is more on left side as compared to the right side, and the conversion was into 2. One has the intraabdominal pelvis with a large supine that gets a difficulty in suturing. And the operative time was 150 minutes, blood loss was 100 ml, and we need no blood transfusion in any patients, and the hospital stay average was 4 to 5 days, and return to their normal activity about the 9 days. Mean follow recurrent. This is a port position, and the port position is very important in case of laparoscopy because we need the intracorporeal suturing, and usually the port position changes with the change of the patient. If the patient is obese, the port position will be more towards the lateral side. If patient is thin, it will be more towards the middle side, and usually the one port that is fixed is only the subcostal port. The rest camera port and the working port will be varied. This is a short video about the pyeloplasty. We are now opening the gyratoid fascia after removing the left colon and the mesocolon from the gyratoid fascia. After reflecting the gyratoid fascia, now we are mobilizing the gonadal vessel toward the medial side, and also after identifying the PUG, now we are removing the fascia from the PUG. The fascia should be removed all sides of the pelvic junction so that the suturing will be easily. And usually the mobilization should be minimal so that there will be no necrosis, there will be no decrease of blood supply. After mobilization should be done from all sides. Now we are mobilizing the pelvis from below and also from the spirally. After mobilization, we can check whether we are taken the complete model so that the anastomosis will be tension free. Now we are checking that we are get the advocate mobilization. Now we are opening the pelvis. Now in order to remove the constructed part, we can now after opening the pelvis we can keep the part of it as such so that the orientation will not change, or sometimes we can cut it if you are difficult. Now we are in this patient we have cut the whole of the pelvis. Now after that the patient this needs the speculation of the part. Now it should be usually done in the single go. After speculation of the ureter, it should be done up the rugosity until know that the atretic segment have crossed. Now after that we can take the first suture, which should be taken at the para-axial position, and the first suture is a very important suture, and it makes and breaks the anastomosis. And the first suture should be taken from out to inside and from in the pelvis from inside to outside, so that the knot should be the outside. So this is a post suture. After then second suture again from the pelvis from outside to inside, and the ureter from inside to outside, so that again the knot will be the outside. Usually the atretic segment, that is the dismembered part, should be removed at the last, so that it will help us in holding during the suturing, so that there will be less trauma to the ureter. Now the posterior layer, we are closing the posterior layer of the anastomosis. It can be done continuous or by intermittent, by sutures, interrupt sutures. And the needle that should be used should be a tapered needle. And the suture that is used usually is a 4-0 suture. Now we are removing the dismembered part from the pelvis, and now again this is the last suture. Again the knot should be usually outside. Now we are keeping the last suture in the posterior layer. It is the knot is now outside. This is a posterior layer. The suture should be about 1 to 1.5 centimeter away, and usually there should be only the mucosa portion. Now we are placing the stent using the subcostal port or using the suction cannula, helping us in putting the stent. That it is the intrarenal pelvis, then first we should put a stent, and after that we should close. After placing the stent, again the anterior layer is closed, which is more easy as compared to the posterior layer. Now we have completed the anastomosis both anterior and posteriorly. After completing the anastomosis, we should see any bleed. And the anastomosis should be again funnel shaped and dependent. One minute. Now washes is given to see any bleeding.
Dr. Zahid, don't worry, we'll give you extra time. You're the organizer.
1 minute.
You deserve it.
And this is a port position in this patient. And the conclusion is in the hand is of an experimental laparoscopic surgeon. Laparoscopic pyeloplasty is a safe and effective, minimally invasive and a viable alternative to open pyeloplasty for the management of huge obstruction. It offers several advantages over the open surgery, including the less pain, shorter hospital stay, and faster recovery. The success of LAPL almost similar to that of open pyelo, but longer term outcome must be assessed. Thank you.
You can ask.
No, I am not going to ask.
We still have a dinner left, huh? Keep that in mind.
We are not going to attend that. Can I have the mic?
Dr. Nazir sir has headed. He has headed, you still have to leave unarmed, na?
Well, basically, I don't ask questions, he's a consultant. So the idea was just to tell the audience about the placement of stent. This has been designed and proposed by Professor Munir Khan, but unfortunately we forget to mention that some senior has done something good. So this was the way, because as I also have experienced, once you're using this double GIST stent, it's very difficult to put the upper part in. So he came up with this brilliant idea of using the suction irrigation cannula, passing it through that, and that makes the job easy. Rest, wonderful work. Please minimize the suturing, that's all.
Thank you, Dr. Zahid. With this, we conclude the session. और कुछ बोलना है आप ही की conference है. You can.
No, thank you, sir. Thank you, sir.
I love.
Okay, thank you.
Thank you, everyone. We deeply appreciate the insights shared during these engaging sessions. To honor the contributions of this session, may I now invite Dr. Shamsul Bari to kindly come forward and felicitate the chairpersons of this session. Dr. Nisar Hussain Hamdani. Dr. Nisar Hussain Hamdani. Thank you, sir. Dr. Rajandeep Singh Bali. Thank you, sir. Dr. Mashkoor Ahmed Beg. Thank you, sir. Kindly have a seat, sir. I further request Dr. Akhtar Ahmed Ganai to join us on the dais to felicitate the speakers. Professor Dr. Ejaz Ahmed Rathar. Professor Dr. Ejaz Ahmed Rathar. Thank you, sir. Dr. Arshid Rashid Kema. Thank you, sir. Dr. Muhammad Yunus Bhatt. Dr. Muhammad. Thank you, sir. Dr. Zahid Muhammad Rathar. Thank you, sir. Dr. Jasmeet Singh. Sir, one more is left. Yes, sir. Dr. Jasmeet Singh Ahluwalia. Kindly somebody please collect the award on felicitation on his behalf. Thank you, sir. To lead us through the forthcoming panel discussion, we are honored to invite our esteemed moderator, Dr. Manmohan Singh, Associate Professor of General and Minimal Access Surgery, Government Medical College, Anantnag, on this stage to moderate the session on the topic carcinoma.
ये कहाँ लगानी है पेन ड्राइव? नहीं इसको हटा दे। Welcome all. Good afternoon. We were discussing, we have a panel discussion here. The discussion is about the carcinoma GB, presentations and management. I would like to invite the panelists. Unfortunately, Dr. Umar Javed Shah, he had to leave, so he is not available. So I invite Dr. Nisar Ahmad Hamdani, Associate Professor, Super Specialty Hospital, SMHS, to kindly come on the dais. Dr. Muhammad Yunus Bhatt, Associate Professor, Surgical Gastroenterology Schemes. Dr. Mir Saika Shafi, Associate Professor, Radiology, GMC Anantnag. Sir, we are already behind the time. Can we start it, sir?
Yes, please start.
So the first thing and foremost thing we want to discuss is about the risks and substantial difference in the incidence of carcinoma GB. As we are well aware of this, carcinoma GB is very much rampant, as we will see excessive mostly in the northern parts of the India. Most commonly, if you will see the southern parts, it's not like that. So can you give us an idea why it is so? Why there are such a high incidence of carcinoma GB in particular our part of the valley and towards the Gangetic belt as such?
As far as Kashmir is concerned, there is no great, I can say it is not alarming, or it is not greater than the national average. Of course, in northern India, in Gangetic belt, they have a high incidence of carcinoma gallbladder. There are certain reasons for that. But as far as overall the etiology behind the carcinoma gallbladder is concerned, as you know, the cholelithiasis is one of the most important factors related to the etiology and chronic inflammation associated with the cholelithiasis. Is a risk factor of carcinoma gallbladder, more so in females. It is more in female population. And they say that in Gangetic belt they have some carcinogens in that area. There are certain papers from HPGI group. Dr. Nisar would like to be more.
So actually, one point here, there was a study from this Dr. Ashok
from SGPGI. He was specifically centered about this, the gallbladder, carcinoma of the Indian perspective. And he has told the incidence rates, according to the National Registry, Indian Registry, the northern part of India, the incidence of the GBCA, it is almost double than the southern part.
Yes, that is true. In fact, Delhi and this northern plains, they are considered to be the gallbladder cancer of the world. There have been multiple studies. Gallstones have been historically associated with gallbladder cancers, and gallstone incidence is by and large more in North Indian population as compared to South. Though it is quite common there also, but it is more common here. Number two, there have been a few significant studies from SGPJ and Banaras Hindu University group, because this area being basically a farming belt, it is considered that a lot of pesticides and chemicals get leached into the Yamuna and Ganga water, which is ultimately adds to the water table and is consumed through different routes. Number one. Number two is presence of some heavy metals and arsenic. That has also been associated with this gallbladder cancer, but particularly in West Bengal studies. In fact, arsenic was one of the very important thing found in besides gallbladder cancer in NCPF in study by Basu et al.
So, have we done some specific studies in why in the Kashmir region has been some studies from this area also, specifically directing on some gene abnormalities or gene polymorphisms from this, as had been some areas from schemes, they have studied the monogenetic changes, but not so confirmatory, so as to point out a one singular factor, which is, that's why the incidence is high.
Till now, not much studies have been done, although a lot of work has been done. We do a lot of radical cholecystectomies. Not much work as a lot of etiology has been done till now. My student had a thesis on, say, gallbladder recently. She concluded in this year. We did a study on that. We did a study on gene. We find that some mutations in the gene, they were more common in that area. But the sample size was less. So a large population-based study needs to be done to see. As far as genetic, there is no study, that prominent study from Kashmir, which mutation is there.
Okay, sir. Sir, now coming to the risk factors, can we say the earlier adage about the porcelain GB, is that so much ominous right now? Or as opposed to the incidence of anomalous pancreatobiliary junction, is that more common towards the GB carcinoma or the porcelain, sir, ma'am?
In fact, both are the predisposing risk factors for the carcinoma. They are known in the literature, but they are there, but we don't see much of those here. APBJ is difficult to diagnose perioperatively, but retrospectively we can see and see the association with the carcinoma. In fact, porcelain gallbladder is associated, there's a risk and it is association with the carcinoma gallbladder. There's already seen.
Dr. Nisar, sir, would you like to add?
See, basically these etiopathogenic studies, they have been written and documented, but to my understanding, we are not working in those setups where we can very effectively and objectively evaluate the etopathogenesis.
Yes.
Because our way of working, our coordination, our referral, it's all it's suboptimal. And number two, we have here and there these studies which have been done, but I don't think by those studies we can actually come to the conclusion that what is contributory and what is not. I mean, for an example, if we are operating a colorectal cyst planned for surgery, in a MRCP report, normally an APPD junction should be reported. But most of our MRCPs lack that. So I'm talking of a colorectal cyst, which we are actually planning for surgery. Not to talk of these etiopathogenic studies. It's too high to talk. Number two is your question regarding this porcelain gallbladder. Porcelain gallbladder, it has been said that in fact the association of porcelain gallbladder is overestimated.
Yes.
It is overstated. It's not that significant risk factor. In fact, there was one paper by Sandys et al. In British General Surgery, if I remember rightly.
Yes, sir.
And he has divided into diffuse and punctate calcification. In fact, diffuse calcification is possibly more related with this rather than, and that significant association is, I don't think it's more than 7%.
Yes, sir.
Something like that.
Should we educate then prophylactic cholecystectomy? Should we educate it in porcelain GB or it should be in ABBD? Or prophylactic cholecystectomy as such should not be done?
No, it is a bizarre statement. You cannot routinely do prophylactic cause to prevent or to for preventing the carcinoma. You see how many cholecystectomy policies are asymptomatic.
Sir, I am only talking about porcelain here and ABBD here. Not about the whole scenario, sir. Only these two. Should we educate prophylactic cholecystectomy in these type of patients, in these type of patients or not? Apart from the other things in which the cholecystectomy is adjuvant, usually in bariatric surgery as we see usually, or as a part of vehicles you can say, or in coldostomies and this.
Yeah, we can, but as told by Dr. Nissa, it is difficult to diagnose preoperatively APBJ and all those anomalies. So that it is not clear cut in which patients we should advocate the prophylactic cholecystectomy based on the APBJ and to prevent then carcinoma gallbladder. In our setting, it is not so much educated, but still we can, as an expert, we can recommend that in case a porcelain gallbladder is diagnosed preoperatively, we can recommend cholecystectomy.
Sir, it's okay. You would like to add something, ma'am? Okay, we will call for this GB polyps. We are coming to the diagnostic part also, ma'am. So, GB polyps, what should we do? How should we proceed, sir?
You see, it depends upon first is the size of the polyp, number of the polyps, and the symptoms.
Okay.
By and large, we advocate cholecystectomy if there is a single solitary polyp, it is greater than 1 centimeter in size. The small multiple polyps, we don't recommend prophylactic cholecystectomy. And
even if there is vascular scar, there is a vascular scar.
Basically, there have been recently consultant guidelines from the American Society of the Radiologists where they have 3 categories regarding the incidentally detected GB polyps, not of the symptomatic cases. So they have categorized it 3 groups. One is the extremely low risk polyps. Yes. You have typically a pedunculated polyp or you have a ball on a wall side. So, or a polyp with a thin pedicle. So, under such circumstances, if the size is less than 10, you let it be. If it's between 10 to 14 mm, you follow it after 6 monthly intervals. And if the size is more than 15 mm, then you go for the surgical consultation or cholecystectomy. Then another category is the low risk. First was the extremely low risk, and this one is the low risk category. The polyp here is pedunculated, but the peduncle is here wide or it's broad base. So again, the recommendations are when the size is less than 7 mm, you wait. When it is up to 10 mm, you do a follow-up at 6 months. When it is 10 to 14 mm, you do more frequent follow-ups, and more than 14 mm, you go for surgical. Then the intermediate polyps where you don't have a star, they are flat polyps, they have a vascular, yes. They have vascularity on CDI. Then under such circumstances, if the size is less than 7 mm, that's the cutoff. If the size is more than 7 mm, you go for the surgical consultation.
Thank you. Sir, you would like to add something?
Nothing. One important thing I would like to differ with my radiology colleague is that one thing is regarding these guidelines. Actually, American guidelines do not apply to Indian population. Since, as you already we discussed earlier that we have a different population set, we are more prone to gallbladder cancers, so our degree of suspicion and threshold has to be low. There has been actually studies which were then endorsed by meta-analysis that the risk of gallbladder cancer in a polyp is 0 only when it is less than 4.8 mm. Beyond 4.8, the risk of gallbladder increases. Though it's a statistical study, but it is quoted often, and in fact, a polyp which number one is symptomatic, which is associated with gallstones, Number 3 is associated with thick wall gallbladder. Even if it is a 7 millimeter polyp, I would definitely recommend surgery.
Okay. So, ma'am, what would be the investigation of choice in a patient who is suspected of carcinoma GB?
There is no single investigation. Usually what we see in our setup, we see most of the GB cases which I have seen.
It's a basket of...
Yes, we see middle-aged to elderly, predominant female population. They land up in emergency with acute abdomen or some vague symptoms, and then we see a mass in the GB fossa. That's the most common presentation, and most common presentation of GB as a mass in the GB fossa. With majority of the times we are not able to discern the interface with the liver. Then second presentation is the GB wall thickening. That needs a bit of further imaging. Then the third category is where we detect these incidental polyps. But the first investigation would be the GB, and nowadays there is a GB RAD score, where this is a system of standardizing the nomenclature.
Just like Bile.
Yes. Wherein GB, we give 5 categories, and it becomes easy to pick up all objective findings and to communicate the same to the surgeons. This way the subjectivity in the radiology reporting is minimized. We have the 5 categories. GB0, when you are not able to assess the GB on UHG, you have to do another investigation. Then you have GB1, it's entirely benign, you cut the case there only. Then GB2, you can consider a multiphase. But then the other 3 categories, GB3, 4 and 5, you have to consider you have to do a multiphase CT or MRI. So coming to the role of the CT, it's the best investigation for staging, be it T staging, N staging, or distant staging. So at present, CT would be the better investigation for staging of the CAGBs, which needs to be supplemented by MRI in certain scenarios. So CT has quite high sensitivity in even differentiating between the subtypes of the T1, depending upon the type of CT you really have got. So CT.
Ma'am, talking about gallbladder thickness, is there some variability, particularly in the subset of the patients who are post-coli, you can say cholecystitis patient, or chronic cholecystitis patient? Can we somehow differentiate the wall thickness?
Yes, there are not the thickness actually, but the pattern of the thickness. Yes, right. The mitotic thickening, you typically have a heterogeneous thickening. I am talking about CT now. You typically have a heterogeneous thickening. Even if you have a layered appearance, you have enhancement in both the inner layer as well as outer layer. Coming to the inflammatory thickening, if you have the preserved neural stratification, or what we say the layered appearance, but the outer layer typically it's not enhancing so far as the inflammatory conditions. But coming to the mitotic pathology, it is heterogeneous enhancement, or it is a layered appearance, but you have enhancement of varying degrees in both the inner layer as well as the outer layer. Then there is one more point when we have thickening which is associated with certain typical findings, like you have an echogenic foci, which in our terminology on UHG, or you have intramural nodules on CT, you have intramural nodules on UHG. They are in favor of a benign pathology, typically the adenoviruses.
So we can conclude.
One thing I would like to add. In usually malignant cases, there is a focal thickening as compared to acute inflammation or xantho. They have a global thickening, the diffuse thickening of the gallbladder wall. So that's more important.
So the most important thing is after a date of
asymmetric, or there's a focal wall thickening in the.
If we wait for some time in a patient with an acute cholecystitis, with the passage of time,
you have to wait. Basically, when you are suspected the cholecystitis, edema, pericholecystitis edema, and the wall thickness is there is a global thickening. Definitely, you will wait. You will not jump to the conclusion that is a gallbladder. But if there are some foci of enhanced thickening, or as the doctor said, enhancement, so that we can take a scope, we can then later add on the CT.
So anything additive, which we can help in distinguishing what is finally known as, or commonly known as, malignant masquerade, like xanthogranulomatous cholecystitis.
I think xanthogranulomatous
cholecystitis. Or IgG4 disorder.
Yes, this entity, it's a histopathological diagnosis. In fact, I may be right to say that even on histopathology, it's very difficult to diagnose. CT imaging and UHG imaging can help, but it's very difficult, and you should have a lot of experience in dealing with those cases. You typically have those hypoechoic nodules on ultrasound, and the corresponding correlates on CT are the hypodense cystis.
which favor xanthogram. Otherwise, if you see the local extension of the lesion, those xanthogranulomatous cholecystitis is the most important mimicker of a locally advanced CAGB infiltrating. And they were typical presentation. You see CAGB, mass forming CAGB, local infiltration, and xanthogranulomatous cholecystitis can also come in the similar circumstances, and further presence of often in CAGB, which we detect incidentally, cholelithiasis is almost present in all cases, which I have seen. Same is the case, xanthogranulomatous cholecystitis also occurs most frequently in the setting of chronic cholecystitis. So calculi again are similar, predisposing factors in both. So it's few of those factors like those intramural nodule cystis by which you can point your suspicion towards an alternative pathology.
Is there any, still from the management point of view, we have to take, assume it is if it is a thickness, wall thickness on the CT, it is not inflammatory, we need to proceed to the radical procedure. Because I have in our setting, in my surgical, we have done the colostomy, I have seen almost greater than 20% of the patients having xantho on final histopathology. And preoperatively, they were all the investigation done, the radiology discussion done, everything done. We planned, they are preliminary diagnosed carcinoma gallbladder, but ultimately the biopsy came with xantho. It's a very high percentage. In our setting, 20 to 30% patients.
Okay. So you advocate we should go for this, although it's an overkill, but it's a better overkill.
Yeah, we overtreat those patients. Yes. Because we cannot take a chance. We cannot take the chance. And in fact, we are helpless. We cannot make the diagnosis pre-operatively.
Ma'am, what's the role of FDG PET CT? If you can show us something. And
Yes.
what percentage of the patients do show METs on PET?
So far as the role of PET is concerned, it is the same as with most other malignancies. It has a role in staging, especially for when you have local peritoneal spread. You can pick up those peritoneal implants. CT is poor in demonstrating small implants. PET can come to the rescue. Similarly, there are cases of CAGB which metastasize to although it's rare, but there are METs to bones, there are METs to lungs and other distant organs. So PET definitely has a role in preoperative staging, especially when you have suspicion of a very high grade lesion on initial imaging.
Ma'am, what about...
And PET has more of a role, especially PET combined with CT, it has more role if you are suspecting now a recurrence or a residual lesion in the operative bed. So I think PET comes more into LALM at that site, at that point of time.
Ma'am, are GB as such avid, PET avid, GB malignancies as such?
Yes.
Pretty on this borderline issue, not so much.
No, GB malignancies, basically it again depends upon the histopathology. When the most common histopathology in the GB is adeno-CA, so obviously we expect that they will be avid.
One thing I would like to add in the clinical scenario which we are having in Kashmir. Usually when a clinician sees a gallbladder thickening or he suspects, the primary physician, he suspects a carcinoma gallbladder, he straightway writes FNAC of the gallbladder wall. So most of the patients, they go do FNAC. Then a medical oncologist, he also does FNAC. I need to mention because as far as the teaching goes, when you are diagnosing the patient on ultrasound or CT, you need to assume that it's a carcinoma gallbladder. There is no role of FNA when you are planning a radical procedure. So no need of FNA or FNAC or anything, biopsy before surgery. So there is no role because most of the physicians or many of the medical oncologists, they advise FNAC. It is not advisable. In most of the HPV malignancies which are resectable, there is no need of FNAC. And there are certain indications of PET. We don't need to do PET in every patient. So as the doctor has said, if you are suspecting there's a MET, there's some suspicious between the lung or some another, then you need to do the PET. Or there is the markers are very high, or there is a hepatoduodenal ligament infiltration, or if there's a locally advanced gallbladder cancer, some suspicious nodules in the liver. So we need not to do PET in every patient because we have seen that patient, especially in the clinical scenario, the patient diagnosed as a cause of FNA being done, PET being done, and nothing being done. So this is the real scenario in our setting.
Sir, would you like
to endorse for Dr. Unison?
Okay. Sir, is there any role of this PET CT in incidental? Although incidental is a broad subcategory, it's altogether another domain.
Yes.
Is there a role?
When we encounter an incidental gallbladder cancer, what is normally labeled as incidental, which many a times is actually not incidental, because there are evident signs in the preoperative ultrasound which maybe the surgeon or the sonologist has failed to pick many a times, and then
that
patients
you say
are operated.
That are suspicious
Yes,
signs.
yes, they are suspicious gallbladder cancer.
That is
They are not
incidental.
incidental. But then they unfortunately come into category of incidental post-operatively. But once we plan a redo radical cholecystectomy or a completion radical cholecystectomy, what we call, that time there is a role of PET. Not exactly for it doesn't change things much, but to a large extent it has a medical legal importance. It saves the surgeon.
Yes.
Definitely we select these patients for PET.
Sir, would you like to give us the avid audience a definition, simple definition, what classically constitutes an incidental GB carcinoma?
So, incidental gallbladder cancer by definition, true incidentals are those which are diagnosed only on histopathology.
Yes.
But there are no evidences or no suggestions preoperatively, intraoperatively and post-operatively when the gallbladder is opened up in the operating room. That is pure incidental gallbladder cancer, but unfortunately, many of them they get labeled as incidental gallbladder cancer, which actually they are not.
They are not. Their telltale signs already there.
Yes.
They are not gone.
One thing I would like to add in this scenario, many of the surgeons who do the diagnostic lab, they sometimes suspect this is a gallbladder malignancy or there are some adhesions and all that, and they suspect, but they proceed on doing cholecystectomy. One word as a surgeon I would recommend, they should
investigate it further.
They should close the patient, they should close the patient, they should not proceed. Actually that harms the patient.
They should not first keep the patient for surgery.
No. If somehow they put an echo, they have found that there are some lesions or he feels it's a malignancy.
Okay, there is some suspicious activity.
He should not proceed with the simple cholecystectomy, because what is that? It does the upstage the tumor.
Sir, is there a difference if an operating surgeon is an pancreatic surgeon or a surgeon is an as such not trained in?
Basically, what the difference makes, I will tell you, the surgery should fulfill the oncological goals. What are the oncological goals? The R0 clearance should be there. There should be hepatoduodenal node clearance after the celiac axis. The periportal nodes, station 12A, station 12B, they should be taken, periportal nodes. Even station 13 node should be taken. And the liver resection, minimum 2 centimeters, he should be able to do.
So
that means
if he is able to do, can he proceed further?
He can proceed.
Without any investigations, without any CT as such?
No, this is not the answer to our earlier question.
Yes.
I mean to say, if a surgeon is competent enough, on table he has found there is some GP mass or fundal mass, if he is confident enough, he can proceed. Maybe he will retrieve back into the CT, then he will further investigate. That is not a question. The question is, the main aim is to do the R0 resection. If we are suspecting on the diagnostic lab that the patient is having some GP mass or something suspicious, we should not proceed. Yes. We should take the code back, send the patient to CT, then review the CT, discuss with the radiologist, then again we can go in the plan.
As I would respectively say, many of our centers don't have the facility of frozen section as such.
No.
So
here you cannot do the frozen section.
Yes.
It is not a frozen section here.
No, not about that scenario. I am saying over the surgeon has opened he has posted the person for cholecystectomy. Yeah. There is some suspicious nodules. He is not sure whether I should go in or
most
not.
Most of the amount of thing he can take a biopsy. Laparoscopy he can biopsy and close.
Then close.
He can take the cope up, send the patient for CT and do the relevant investigations.
Okay.
He should not proceed with the cholecystectomy. Okay.
So, as we have already discussed about the incidental carcinoma, incidental GBs, which one it is, and it is detected on table, it is detected on histopathological examination, or there is some suspicious activity which we will label as an incidental GBC. So that Dr. Nisar has already illustrated, I think. We can. So how do we proceed in such patients? In patients who are detected as initial as incidental GBCA, how should we do it, rather?
First, when a patient comes to you with a biopsy, cholecystectomy being done with a biopsy of the adenocarcinoma, then we need to re-investigate the patient. We do the staging. At least minimum we need to do the CT scan, contrast analysis, abdominal pelvis, and then we need to do the proper workup of the patient. Maybe as Dr. Nisar Sahab has said, plus minus PET we can do. We need to rule out the distant meds and all that. Then proceed, if everything comes to be okay, then we proceed for the completion radical cholecystectomy. In completion radical, again, we need to do the hepatorenal clearance, lymph node clearance.
Surgery has to be done as per the procedure for radical cholecystectomy.
Yeah.
That I understand. Sir, what would be the optimal time interval between the indexed cholecystectomy and for the radical section? As you know, many of the patients, they are diagnosed or biopsy comes late, and when the biopsy comes, it's the time interval is, then again the time is spent on investigation when he finally reaches to a surgeon. So is time a dependent factor here?
Yes, definitely. If the patient comes late, the prognosis is worse. But as early as possible, if the patient comes early, we need to investigate and then subject the patient to again. So we can subject the patient as early as possible. There is no need to wait for anything. Not to wait for the information to settle. We need to go in again.
I fully agree. This topic has been actually worked out extensively. And by and large, the recommendation is that it should be done within 8 weeks.
Okay, the surgeon open. That's why there is a role. Many of this, there is a time. Many of our surgeons, they don't open up the gallbladder after doing a cholecystectomy.
Yes, that's what I actually wanted to stress upon. It should be made a ritual to open up the gallbladder once the surgeon operates. And just shift to the other side, then open up the gallbladder longitudinally and examine the surface. Wash the surface with normal and seat. Then document it in your notes. And one very important thing which unfortunately many surgeons do not mention in their operative notes is whether there was bile or stone spill and which port site was used to extract the gallbladder. These two things, port site definitely does not have as such a, we cannot translate into therapy, but definitely it has a prognostic value. Number one. Number two, whether this gallbladder was taken out, extracted in a polythene bag or like just like that. That should be mentioned. That should be a part of a routine surgical note.
So you would like to add
one thing I need to mention here. I have seen instances of incidentally detected CAGB in those patients whose the primary surgeon has done CT that has shown some suspicion lesion. He has again done simple cholecystectomy. He has done the planned cholecystectomy and the biopsy has been done.
Proceeded with the
That
should not be.
I can actually give a sort of solace to Dr. Yunus. In fact, I have seen patients getting operated where a gallbladder mass was operated, frozen was positive, then patient was closed back. Then patient was discharged. That way it's a very small thing for PSC.
We have seen several cases in CT. There is history of cholecystectomy, and then we scan the patient. There is a large lesion in segment 5B. So there are many scenarios where they don't go for the histopathology post-op, although that must be rare nowadays, but we have seen several cases where there is just a history of cholecystectomy, and now after several years they land up with a huge lesion in the segment 5 of liver.
So surgery, what type of surgery we are talking about here? Is there a classical surgery? What we do, it should be a wedge resection, a segment 4B, 5 resection. In these type of patients, what do you do?
In case of locally advanced lesion.
Now here we will as we have already discussed the incidental part,
Yeah.
we have again come to the GB as well.
Yeah. In case of the locally advanced, like the lesion is infiltrated the segment 4B or 5 of the liver, we need to do the good amount of liver resection, minimum 4B5 resection. But in case of if it is limited to the on staging, it is limited to the gallbladder, we can the segment 2 segment wedge is enough.
So, is there any definition of this wedge? How much this wedge should be?
Minimum 2 centimeter should be there.
So you would like to add something?
Yes, there have been studies for this the depth of the wedge. It is customary basically, but it was evaluated more than 5 up to 1.5 centimeters. Anything is normal.
Yes.
It's basically the radical cholecystectomy depends on the location of the mass. If it is fundus body, the wedge is enough. If it is neck and it is still resectable, then wedge is not enough. Then extended right hepatectomy is actually the part of liver resection which is needed.
Sir, then what you will educate of a patient who has a T2A lesion? A lesion towards the peritoneal side as such?
No.
Not toward, according to the latest AJCC
No,
classification.
T2A peritoneal side, wedge is enough.
We still do the wedge.
Wedge, you see, once we are planning a radical cholecystectomy, that time we will not leave the wedge, we will take up the wedge.
Okay.
But more important is that we are clearing the nodes. We are doing intra-aortic lymph node sampling, we are seeing nodes along hepatic artery, common hepatic artery.
Sir, do we routinely go for this, the aortocaval lymph node dissection? If this is positive, do we close the patients if it comes to be positive?
It depends. It depends on when you detect the. If you are preoperatively suspecting the intra-aortic node positive, there is a suspicion, you can go for FNA before the proceed for the surgery. But if you are still suspecting, you can go for a diagnostic lab, take the intra-aortic sampling, then send for the histopathology. If it is positive, you close the patient, and it is as good as meds.
Okay. And the role of staging labs, sir, in that? In those patients of cancer GB, sir?
There was pilot study from GB Pant, just a mention of that. There was pilot study from GB Pant for EUS guided FNA of the intra-aortic lymph nodes. And in fact, that pilot study then ultimately, at present, conventionally if we see that intra-aortic lymph node, if they are positive, we abandon the case. But now scenarios are changing. With the advent of oligometastatic gallbladder cancer definition, intra-aortic lymph nodes are not contraindication for surgery in a selected group. Definitely in a selected group of patients who have received chemotherapy.
So now the role of neoadjuvant or adjuvant, that's already, I think there is only one. Is there any role of neoadjuvant chemotherapy in CAGB?
Yes, there is a study from Tata and SGY people. They are doing a lot of the cases. The sort of locally advanced tumors which infiltrate the hepatic ligament, which infiltrate the CPD or CHD or the vessels. They put the patient on neoadjuvant and they have found a good results. But speaking in our scenario, we are not found much results with the neoadjuvant as far as the conversion is concerned.
We usually go for the surgery.
I have sent many patients for neoadjuvant, but they don't convert to resectability. Although this disease is stable, but they don't go for conversion.
Okay. That was all, sir. Thanks, sir. That was
Thank
a nice
you. Thank you.
presentation, sir. I think the people should.
Thank you, sir. Mike. It's an honor to declare the result of Hajra Ali Memorial PG paper, which was held earlier today. The award for the third prize goes to Dr. Raj Swethan, GMC Srinagar. Second prize goes to Dr. Elizabeth, Government Medical College, Anantnag. And the first prize goes to Dr. Gurveen Kaur, GMC Srinagar. The result of Mayasham Poster Award. The third prize goes to Dr. Manveer Singh from ESCOMS. The second prize goes to Dr. Raheel Mughal, SKIMS. And the first prize goes to Dr. Raj Swethan, Government Medical College, Srinagar. The award for Professor B.L. Kapoor Quiz Competition. The third prize goes to Dr. Akhilesh and Dr. Sunidhi, Government Medical College, Jammu. Second prize goes to Dr. Shahabuddin and Dr. Neeraj, Government Medical College, Anantnag. And the first prize goes to Dr. Haris and Dr. Raj Swethan, Government Medical College, Srinagar. The cash prize and the certificate will be given tomorrow during the valedictory session.
Thank you, everyone. We now move on to the felicitations of the panel discussion. To begin, may I invite Dr. Harbinder Singh to kindly come up on the stage. First, we take this opportunity to honor the moderator of this session, Dr. Manmohan Singh. Thank you, sir. Kindly take a seat. Sir, kindly take a seat. Now we extend our heartfelt appreciation to our distinguished panelists, for which I request Professor Dr. Fazal Parekh to come on the dais and felicitate the panelists. Dr. Nisar Hussain Hamdani. Thank you, sir. Dr. Mohammad Yunus Bhatt. He is not present here. Dr. Mir Saika Shafi. Thank you, sir.
Do you know, trust me, Saika has been our student in Sikim's Medical College. They used to come for clinical classes to Soura Sikims. And trust me, till date, I have not found a brighter girl than her. I keep on telling each and every batch, Maneka, I am not seeing second Saika. MBBS, we have always found her replying each and every postgraduate question of surgery, honestly.
Thank you so much, sir. Now, with due respect, I would like to request, sir, to present Award of Honor to Dr. Muzaffar Ahmad Zargar. He served Jammu and Kashmir Health Department for over 4 decades. We thank him for his exemplary service and commitment to public health. Thank you so much, sir. Kindly take a seat. To preside over the forthcoming session, featuring faculty presentations, I now invite our respected chairpersons to the dais and take a seat. Dr. Arshad Rashid Kema, Associate Professor, Department of General and Minimal Access Surgery, Government Medical College, Srinagar. Dr. Zakir Hussain, Associate Professor, Department of General and Minimal Access Surgery, Government Medical College, Rajouri. Dr. Mohammad Yunus Bhatt, Assistant Professor, Surgical Gastroenterology, SKIMS, Soura. And Dr. Varun Dogra, Assistant Professor, AIMS, Jammu.
Well, I guess for the final session, the best has been reserved, and I feel honored to call upon my elder brother, Dr. Shamsul Bari, to present his talk. On surgical, okay, younger brother, on surgical management and outcome of patients with sacrococcygeal pulmonary disease. Please, sir.
Thank you, Dr. Arshad. Good afternoon, everyone. I'll just share my experience as far as ये कुछ और इसमें कास्ट लिखा है, चेंज करो इसमें, यहाँ कुछ और है इसमें, नहीं इसमें कुछ और कोई टॉपिक है, नहीं मेरा नहीं है, ठीक है. So I will share my experience as far as the management of मैं देखता हूँ सर्जिकल मैनेजमेंट है, सर्जिकल का कहाँ पर है, सर्जिकल मैनेजमेंट हाँ जी, थैंक यू. Good afternoon, everyone. I would like to share as far as the management of sacrococcygeal pulmonary disease is concerned. Next. So, as all of us know that sometimes managing the pulmonary sinus may pose a challenge for surgeons in view of some high incidence of post-operative infections, inadequate wound healing, and high recurrence rate. Although multiple options are available, both surgical and non-surgical, but as such, there is no universal recognized gold standard as far as the management of these pulmonary sinus is concerned. Traditionally, surgeons have been using various methods such as excision with primary repair, excision with second healing by second intention, we have mass stabilization, we have best count, we have modified best counts, we have cardiac GIST procedure, and many others. But now the trend is to use flap techniques for these procedures, for this pulmonary disease. In view of the various advantages as far as this flap technique is concerned, which include recurrence rate is low, depth of needle cleft is reduced, tension-free sutures away from the midline, very good cost-benefit results, and very good patient satisfaction levels. Various flap techniques that have been used from time to time by different people include rhomboid excision with Limberg flap, modified Limberg flap, Z-plasty, VOI fasciocutaneous advanced flap, deformental flap, gluteus maximus advanced flap, and many other flaps are there. But nowadays, the minimally invasive procedures coming up, and people have shown good results with these techniques, such as we have trephine, we have endoscopy pulmonary sinus treatment, we have laser ablation, we have video-assisted laser ablation. But I will confine myself to surgical procedures only. As far as skills concerned, we have as many as 90 patients in the last 3 years, and all the have been done off midline and as far as procedure is concerned, it was a discretion of the surgeon which flap he or she may use. Now we have done Colorectal procedure in 29 patients, Limberg flap in 27, modified Limberg flap in 14, Z-plasty in 16, and Viva advanced flap in 4 patients. All the procedures were done under spinal anesthesia, and the patient was placed in prone position with the buttocks stepped apart. Now, as you know that in Colorectal, we have to take care of first of all, we have to identify all the primary and secondary openings. Then after we identified both primary and secondary openings, we have to mark a vertical line almost as much as 2 centimeters away from the midline. After that, we have to excise the incision. Then after excising the incision, we have to prepare a flap and close that in such a way that it comes away from the midline. Now you can find that now while giving this incision, one has to be very careful. The medial incision has to be vertical so that less skin is sacrificed, while as the lateral incision should be oblique and should follow the contour of the buttocks so that less fat is excised, less fat is sacrificed. Then after we have excised the sinus, then we have to prepare a flap. This flap has to be around 1 centimeter thick and should go at least 2 centimeters laterally. After that, we have to close in 3 layers. The first layer should connect the deepest part of the flap with the sacral fascia and the tissue on the other side. Then the second layer should be subcutaneous tissue, and the third should be skin. This is a patient with a pulmonary sinus, so we have marked the flap, marked this incision in an elliptical fashion, and also marked a line AB 2 away from the midline. Then we have excised the lesion in an elliptical fashion, creating a defect. This is a specimen excised, and then after that a flap is prepared. Once the flap has been prepared, we have to suture it. As you can see, the flap is almost 1 centimeter thick and actually gone almost 2 away from the midline. Then after that we have to suture first layer. After suturing the first layer, then we place a drain outside that, and after that second layer and a third layer sutured. It was first layer, there's a second layer, and ultimately a skin has been sutured. Then the second very commonly used method is the Limberg flap. So in that case, we have to first excise the lesion in the form of rhombus. As we know, the rhombus has 4 sides, which are the opposite sides are parallel to each other and equal in size. And the 2 angles, these opposite angles have to be angle A and C angle have to be 120 degree, while as angle B and D has to be 60 degree. We have a vertical diagonal and a horizontal diagonal. The horizontal diagonal has to be only 60% of the vertical. So AC is only 60% of the BD. After that, we have to extend the C in such a way that up to E in such a way that C is equal to AC, and after that we have to extend this line E either downwards or upwards, depending upon the choice of surgeon, in such a way that EF is parallel and equal to CD. After that, we excise the flap. I should have monitored. We should extend this pointer. So then we have excised this sinus in the form of a rhombus. Then after that, once the rhombus has been excised, we prepare a flap, and then ultimately we rotate the flap towards the defect in such a way that C goes to A, E goes to B, and F goes to D. F goes to C. So after that, we can take this flap on either side, either right side or the left side, depending on the surgeon's choice. And of course, the site of the lesion, site of the sinus. So it's a patient where we have done a Limberg flap with the flap taken from the left side, from the right side of the patient. The patient is in the prone position, the rhombus has been marked, then we have also marked the flap, then the excision of the sinus has been done the rhombus. After that, the flap is prepared, then the flap is rotated to the defect, and this is the final picture in the immediate post-operative period. Then this picture is taken after 2 weeks, and the right one is taken after 8 weeks. Then this is the flap where the flap has to be on the other side, on the right side of the patient. And this is the picture taken 4 weeks later in the same patient. Then we have the modification of the Limberg flap. It is only modified Limberg flap. It has got multiple modifications. As you can see, type 4 modification where the lower end this vertical line is tilted towards the donor side in such a way that the lower this end of the rhombus remains away from the midline at least 1 centimeter. Second one, type 5, both the upper and lower ends of the rhombus are shifted away from the midline, and in third one, the entire rhombus has been shifted to the other side. The aim of shifting the lower end from the midline is that because the recurrence rate is very high at the lower end, and we should try to remain away from the anal canal. So this is a patient where we have done a modified Limberg flap. As you can see, the lower end is away from the midline, the flap has been prepared and ultimately sutured. You can see that suture line is away from the midline. Then we have VY down the flap. Here, this sinus is excised in the form of elliptical fashion, and at the same time we mark the V flap. So this sinus has been excised, a defect has been created, and now this excised specimen. Then after that, the V flap is prepared. Once the V flap is prepared, it is moved towards the defect. You can see initially it was a V, now it is becoming Y. So this is a final picture at the end of the suturing. So V has become Y. That's why it's known as VY flap. The advantage of this VY flap is that it can cover a very big defects, and it can be taken bilaterally on both sides. So this is a picture taken 2 weeks later, and another picture taken 4 weeks later. Then we have Z-plasty or Z-plasty, what you say. As you know, the principle of the Z-plasty is that all the 3 lines, 3 segments should be equal in size. As you know, as in this case, we have AB central segment and two limbs at the upper and lower end. These 2 limbs are taken in such a way that they are equal to AB, and the angle at A and B should be either 60 degree or 45 degree. It should not be less, because if we take this less angle, there are high chances of necrosis of the tip. If you take a broad angle, it will be difficult to rotate the flap towards the defect. So again, this is a diagrammatic representation of this Z-plasty. Excision has been done. 2 flaps have been prepared, A and B. Now A goes to the place of B, and B goes to the place of A. This is a patient where we done Z-plasty. As you can see, the excision of the sinus has been done in the form of in elliptical fashion. Then the 2 lines have also been marked at the upper and lower end. Now the excision of the sinus has been done. This is excised specimen. After that, we have to create 2 flaps, flap A and flap B. Then after that, we have to rotate them. A goes to the place of B, and B goes to the place of A. This is final appearance in the immediate posterior period. This after 6 weeks later. Now, as far as our patient, the statistics are concerned, majority of patients were in the age group of 16 to 29 years. Most of them were males, and majority of them had a single opening, but many of them had 2 openings as well. Then, as far as is concerned, as far as the operative time is concerned, Limberg flap had the longest operative time, or around 73 minutes. Catechies and Z-plasty had a mean operative time of 68 and 67.72 minutes respectively. Then as far as completion is concerned, superficial wound dissection was seen in many patients. It was around 10% patients with catechies procedure. It was 7% in patients with Limberg procedure, but there was no wound dissection seen in patients with Z-plasty. Then as far as the recurrence is concerned, we saw recurrence in 1 patient catechies group, which are later managed by a Limberg flap, but there was no recurrence seen in case of Limberg flap or a Z-plasty. Then as far as the patient success is concerned, catechies procedure and Z-plasty had 100% satisfaction rate, while as 7 out of 27 patients who undergone Limberg flap were not satisfied because of very prominent scar in those patients, and this was found statistically significant. Then in conclusion, although the Limberg flap had a very low recurrence rate, but the patient's satisfaction rate was less because of prominent scar, particularly was bothersome for the females. Then as far as all these procedures concerned, Z-plasty had a favorable outcome in terms of post-operative pain, return to work, disease recurrence, and patient satisfaction. Thank you.
Thank you, sir, for a wonderful presentation. Just one comment, not a question, obviously. Experience with elliptical flap. I actually presented data about my elliptical flap way back in 2017 or 18. There was a conference organized by Fazal sir in Pahalgam on benign erectile disorders, and I presented data on. I was there at that time posted at District Hospital Badgam regarding the elliptical flap reconstruction of pulmonary sinus. I remember sir scolded me on one thing: why are you not recording it properly? Yes. And from that day onwards, I have been recording it, sir, and you'll be happy to know I have completed more than 300 cases now.
Right. And they all told me this story.
Yeah, I've already told you, sir.
Because we often meet. Thank you.
Thank you, sir.
Thank you very much.
Now the second presenter is Dr. Salman Khurshid. He is Assistant Professor ENT Department, GMC Nantnag, and he will present cosmetic rhinoplasty. It's a wonderful thing. He's making the people beautiful.
ठीक है ये मैं तो चला
Good afternoon. I'm Dr. Salman Khurshid. I'm going to present a topic on, my topic will be on cosmetic rhinoplasty or experiences at Government Medical College, Anantnag. So I will be taking you slightly away from abdomen for a while. Cosmetic rhinoplasty for an ENT surgeon means a surgery to improve functional and aesthetic outcome with equal importance to each. So our primary goal in ENT while doing a rhinoplasty is to get a very good functional outcome along with the aesthetic. So what is the importance of rhinoplasty for us? As nose is the most prominent part of the face, and rhinoplasty is a procedure to reshape the nose, which profoundly can impact the self-perception by aligning one's external appearance with their internal sense of self. But there are a few things that rhinoplasty can do for us. For example, it can reduce the dorsal hump, it can modify the nasal tip, it can narrow the nostrils, it can reduce the width of the nose, and it can change the angle between the nose and the upper lip and straighten or narrow the nasal bridge. However, the decision is deeply personal and an outcome may vary depending on the individual goals and emotional readiness of the patients. But one thing is for sure that post-surgery, many of these patients report feeling more like at home in their skin, which enhances their social interactions and self-assurance. We at this institute have performed about 100 cosmetic rhinoplasty since 2019, since the inception of this college, and along with changing some lives, we have also our own perception about the procedure has changed, and based on that, on our own experience, we identified several factors that lead to best aesthetic outcomes. So my points of focus in this presentation will be the hospital patient load, the rhinoplasty experience, patient selection in rhinoplasty, pre-operative assessment and planning of surgery, and intraoperative focus and keeping the patient safe. So as I said that the open approach cosmetic rhinoplasty, which was started about 6 years back, and we have by now completed more than 100 cases. And what is the relevance of doing rhinoplasty in a government medical college? It's very important for teaching. I believe that if a medical student has not witnessed an open rhinoplasty, he or she won't be able to understand the anatomy of the nose completely. And open rhinoplasties we do for extensive septal deviations and for nasal deformities, where we want the best functional outcome, and it's the only this procedure, the open approach technique, that can give us the best functional outcomes. And the best part is that it requires very minimal instruments. You can see a magnifying lobe, headlight, and a few instruments which are widely used in septoplasties, with some additions. So it doesn't put any extra load on the hospital exchequer. Only few instruments are needed. And of course, we need proper patient selection, and among those points, surgeon must assess the patient's motivation and mental health. Unrealistic expectations such as seeking perfection and hoping surgery will resolve unrelated life issues often lead to dissatisfaction. We're aware of body dysmorphic syndrome, where patients may fixate on perceived flaws, increasing the likelihood of postoperative regulator serial surgeries. So that's one warning sign. And the surgeon's expertise lies in achieving functional and aesthetic results which align with the patient's goals. And those goals should be achievable goals which align with that of the surgery and what the surgery can deliver. So it's important that the patient understands the limitations and have realistic expectations. And also that the patient, one thing we have observed that patients who are non-compliant or dismissive of instructions increase the risk of complications like infection, poor healing, or asymmetry. So surgeons must select patients who demonstrate responsibility and commitment to the process. There's a risk of litigation in these procedures, very high risk of litigations. It's especially common in poorly selected patients, those with unrealistic expectations and psychological issues, or a history of dissatisfaction with prior surgeries, who are likely to pursue complaints or legal action. But fortunately, we have not seen it so far here, but it's quite a risk. And for that, we need pre-operative individualized plan, and every patient should be analyzed and final individualized target set based on the pre-operative imaging, patient expectations, and surgical feasibility. So surgical efforts should be directed towards achieving the individualized target set pre-operatively, rather than adopting a new goal or trying to better what has already been done, as that can do more harm than good. One thing I want to highlight is the palpation of the nose to assess the shape and position and strength of the nasal structures. This slide can give an example where a bifoot nose was treated with open approved septorhinoplasty, a thin and weak upper lateral and lower lateral cartilage on palpation, which was corrected by incision and augmentation with support grafts, which was planned pre-operatively. Now, what should be the intraoperative focus? Our focus is on addressing the bone and cartilage, and osteotomies and cartilage excisions should be done in a conservative manner, as overzealous removal may lead to depressed bridge or drooping tip because of inadequate support. Both these pictures give an example of adequately done osteotomy, not an overzealous removal. And one important thing to address during the surgery is the septum. It's very important to address any deviation of the septum and perform septoplasty if necessary, as it leads to best functional outcome. What we perform is we perform the extracorporeal septoplasty, where we take out the septal cartilage in its entirety and then reshape and reposition its original position. A refashioned L-strut septal graft has been shown in the picture. This is an example of a traumatic supratip depression, which was addressed by using the buccal septal cartilage, which was refashioned and used for support. No extra cartilages or grafts were harvested from any other side. However, this is an example of a case where we had deficient septal cartilage and there was no graft available. So we had to harvest a rib cartilage and use it for support. Now, addressing the tip is very important in septorhinoplasty, and since it's the most prominent part of the nose, and patients often fixate on nasal tip, as it is an important landmark. And techniques like dome binding sutures and cartilage grafts ensures durability and prevent postoperative changes. The two examples shown are both done by different techniques. The first one needed a humpectomy along with tip elevation. The second one was treated with tip elevation only. No osteotomies or no humpectomies were done in the second case, on the right one. Again, the tip procedures have a very wide relevance. Sometimes you need to reduce the tip size, and at other times you have to create a tip.
Dr. Salman?
Yes.
Dr. Salman, you are running short of time. Please, a bit faster.
Yeah, sure, sir. So, addressing the cartilage framework is also important. Just in this case, where we have a collapsed nose, which was addressed by deskeletization and refixing with little graft support. Addressing the dorsum of the nose also important. You have to check the dorsum, and while doing the humpectomy, you have to look for the age, and it has to be done after 18 years of age to avoid any periosteal reactions. Like in this case, where periosteal reaction was found after initial good improvement, but patient developed bumpy nose after a few months. So, because this case was less than 17 years of age, I will just conclude. So addressing the soft tissues and skin is important, but rhinoplasty will address a deformed nose, but it will not have any impact on the pre-existing scars. And also there's an issue of thin skin versus a thick skin. Thin skin generally show better improvement in open cytorhinoplasties. And also keeping the patient safe in rhinoplasty is important. What we mean is that we have to constantly check our progress by using calipers and scales, and also we have to address the intraoperative edema by using cooling pads. And we have to take care of patient in the initial two weeks of the surgery, after the surgery, and we have to constantly motivate our patients and keep them well informed about the procedure. Thank you so much.
So continuing with where request all the honorable speakers to please stick by the time.
Respected faculty members, teachers and students, my topic is deformental flap. Deformental flap is a modification of Limberg flap that is commonly done and everybody knows. The idea of discussing this flap is because it's a very underutilized flap and can be workhorse flap in almost all areas of the body. It's a geometrical flap and modification about Limberg flap. The flap offers added versatility and can be used to cover post-resection skin defects as well as post-trauma tissue loss. The difference between deformental and Limberg flap is it is mathematics. It is more versatile than Limberg flap. We'll start with mathematics. In case of deformental flap, we make a defect into a rhombus, 60 and 120 degrees. Then we make an axis which bisects the short diagonal of the rhombus. Another line is passed along one of the axes of the walls of the defect. Then we bisect these two lines, and these two, the bisected line forms the incision line, and another line is line parallel to imaginary line joining the long axis, long diagonal of the defect. This is the geometry of flap. If you see, D is the defect, P is the primary flap. You can see how well it fills into defect, and then there is a movement in secondary flap which fills the primary flap. So there is ease of closure of secondary defect in case of deformental flap. This has added advantages once we are doing the flap or the areas which are cosmetically sensitive, or areas there is decreased vascularity, or the areas where mobility of tissues is less. Plus there is one more added advantage, that is the total rotation. Total rotation in the modified flap is almost 75% less than the common Limberg flap. We have done some modifications. At the point B of the defect, we make a small incision. Plus, you can see at the A, there is a small cross-hatched area. We leave this area if possible. In this area, the central red part is the malignancy. Circle around is the resection margin, and a cross-hatched area A is kept to aid in closure. This was a case of dog bite face. We converted flap into a rhombus, then we extended the short diagonal, extended one of the wall of the defect, then bisected the area, then make another incision parallel to long axis of defect. You can see in the third picture, the flap is raised, flap will fill the defect, and secondary defect will fill the create a defect. The advantages of there is no distortion over the surrounding areas. This is importance in the areas where tissue is limited. This is the area of dog. This is a case of dog bite scalp. Here again we formed a deformental flap. We try to make flap axial. It is based on the superficial temporal artery, and you can see the defect is closed by the deformental flap. Classically, in case of scalp, we can say that only 2 to 3 centimeters maximum can be covered by local flaps. But with this technique, we are able to close a large defect, which otherwise would have required a skin graft. So we saved the person from skin graft and later the procedure to deal with the allopathic area of the scalp. This was a case of superficial spreading BCC. This was again done. This was again managed by same flap. This is a case of BCC eyelid. The challenge here was that a small distortion would have caused ectropion. We planned a deformental flap in this same patient. This is the flap raised. This will go to defect, and secondary flap will move slightly downwards to cover the primary defect. The idea of doing the cumbersome idea of doing it in this pattern is because we have to see that tissue mobility should come from multiple directions. If we get all tissue from one direction, it would have caused ectropion. This is the final result of the same patient. There is minimal distortion and almost invisible flap over the face, and no ectropion. There is no distortion in both with open eyes or in closed eyes. This is again same flap over the scalp. This is again a BCC over the eyelid. We have designed same flap and with good outcome. This was a case of exposed pacemaker lead on the chest wall just below the clavicle. Again, we have designed the same flap. You can see at point A there is a small inked area, blue color area. We have kept it there. This area we keep intentionally there to avoid the suture line pressure over the area. So the flap P goes over the defect. The flap S goes over the P, and this is the after excision of the defect. This is after transposition of the flaps. You can see it is well closed and the tissue is derived from multiple areas, and flap is well set, well placed in the defect. So we claim some superiority over the Limberg flap, and we believe that it can be a workhorse flap in various areas of body. This flap is very underutilized due to some mathematics, and that mathematics can be learned very easily. Thank you everyone for a patient hearing.
Wonderful, Dr. Junaid. You have stuck to your time. Very nice presentation, and you have completed in timely. And your work speaks volume. Thank you so much.
Thank you, Dr. Junaid. Now, I am really happy to introduce to you, definitely it's not a satire, he is a younger brother, Dr. Amir Yusuf, Associate Professor here in the Department of ENT, GMC Srinagar. He is doing a wonderful job here. Amir, please present your talk.
Thank you. I thank the organizers. It's 6 p.m. in the evening and hall is still. And there is someone to listen to us that speaks to the success of the conference. I really congratulate Dr. Azir and his team. I have never seen, even in the international conference, at the evening there will be so much of crowd to listen to the speakers. So, no, this. I'll be taking you a little away from my passion is head and neck. I'm ENT, but specially trained for head and neck in Tata Memorial. So when I really saw this theme, I got fascinated delivering. It's not coming on the screen. Oh, thank you. Delivering value-based surgery to your doorsteps. I am trying to take you really to that thing. Have we done that? Have we been able to deliver our surgeries in the peripheral hospital setting to the doorsteps of our patients? So my talk will be on head and neck cancer in the South Kashmir, our insights and experiences over 6 years of our time in GMC Anantnag. So before we go really into our experiences, let's have some insights. What is the burden of head and neck cancer in the world, India and in our Kashmir? So this is the global burden of head and neck cancer. The WHO is giving us a observatory directory that's been set every second. There's an update of cancers, and Globocon estimates 2020 head and neck cancer, squamous cell cancer, the 7th most common cancer in the world, and 5th most common in the men, and 12th most common in the women. So there is male-female proportion 3:1. If we see the world scenario of most common lip, oral cavity, oropharynx, hypopharynx, and laryngeal cancers, so India is, we draw these correlative graphs on the basis of age standardization per lakh. So blue is the most common thing, and light green is the less common thing. I will be taking like that, so it makes you easy. So India is blue here. So common cause we know is the tobacco, areca nut, tobacco chewing. So India is an epidemic of oral cancers. So again, salivary glands, India is luckily in the light blue range. And nasopharynx, lighter blue. And thyroid cancer, lightest blue. I will be taking you to the India now. Again, age standardization over the 10-year time, lip, oral cavity, oropharynx, there has been, can I have the marker? There has been a proportionately increase in the rates of the cancers. Pointer. I can show this. Huh? Only graphs. Sorry, on screen. So there's a proportionately increasing trend over the years, but most commonly you will see males are dominating over the female. Male is blue, women's are down, there's the red line. So this is lip, thyroid, except thyroid, they are all the cancers. Now when you see the thyroid trend, the females are dominating over the years, and they are in uprising trend. There's a rising trend over the years. It is an Indian scenario. Now our state scenario, unfortunately, there's a gray zone. This gray zone means we don't have data in the director. Unfortunately. Maybe in future when we have started now the Regional Cancer Center and the SCIMS, they will be updating soon. This gray zone may turn out to be blue or lighter blue now. So there's a very good paper from SCIMS, changing pattern of common cancer in the 5 years in the Kashmir. This is 2014, this published 2021, but they have told us about 2014, 2018. So trend is, lung was initially the first, esophagus, stomach, breast, colon, thyroid. Now you see over the years, 2014 they have seen thyroid was the last, at the 10th. Now in 2018 it has come up. So there is a rising trend in our state also. So there is a rising trend of thyroid cancer. So there is a change in our state. Like I said, but you can see, Srinagar is the first over the years, followed by Anantnag. But my point is not Anantnag. My doorstep is not Anantnag. This is the footstep of Anantnag. But when I really joined this place, I thought we will be having small place to work, but this was a falsehood, because I have to work for the South Kashmir. South Kashmir means Anantnag, Pulwama, Ramban, Kishtwar, Riyasi, Udhampur, and we do get patients from Jammu also. So there's a proportionately, we are catering population of 35% of the Kashmir population. And this is and my work experience when I joined here in 2019, it was only me and Salman. The first things to set up was the team. So we, alhamdulillah, over the years, we have built, now we are a big team. And second thing was to set up diagnosis. So set up a diagnostic facilities for head and neck cancers. We have state-of-art navigation system, nerve monitor, we have harmonics, we have coagulation, we have state-of-art narrowband imaging system. Now we are doing regular tumor board meetings with the pathologists, with the radiation oncologists, with the not less than recently we have started surgical ICU. That was the missing link between major surgeries and so have we really delivered our value-based surgery to the doorsteps of South Kashmir? Our experience, 465 plus cancer patients operated, head and neck. And the number one, there's a drift, is thyroid cancer. 310 papillary carcinoma dominates 90%. There are few cases of medullary, few cases of follicular, but most common, female dominating, 80% of the females were there. They were all, this dip is all because we all know this is the COVID era. So I'm sorry for this. So there is a rising trend. Last year we have operated 80 plus. This year only 45 plus, which is half of the year. This is our experience. We mark the incision initially with the thread. We have published few other papers. So there is no worry of scar in the future if you plan your patients very well. We have done neck dissections, bilateral, unilateral. So few of the published research papers and few are ingoing. My residents are here. We are doing very good study on evaluating the thyroid. This is not only the malignancy management, is not only surgery. We are seeing over the years of 5 years now follow-up patients. We are seeing a lot of psychiatric illnesses in them. There's social discontinuation. There is some mental and physical well-being issue with them. So now we have started a study with the psychiatric people, evaluation the impact of thyroidectomy on physical, mental, and social well-being in the papillary carcinoma. So second common cancer in South Kashmir is the laryngeal cancer, as per our data. So we have done 67 so far. So most commonly, because of our good instrumentation, the OPD setups, we have FOL, we have a very good setup of diagnosing NBA. We have tried to diagnose patients in the early T1 and T2. And alhamdulillah, we are lucky to have most of the patients, about 21 were the T1, 18 were the T2, and 24 were the T3. That is a very good result because that follows the organ preservation protocol, and CTRT helps us to preserve the larynx. Few of the laryngectomies has been done. These are the laryngectomies, and thanks to our salivary gland follows the third, and parotid, we have done almost 50 patients of parotid. We have done a study of most commonly they are adenoid cystic carcinoma and mucoepidermoid carcinoma. So these are the few of the series of our parotid surgery. Less common surgeries, we have sinus tumor, paranasal sinus tumors. We have forehand technique for removing the skull-based lesions. And there was one of the tongue, Dr. Junaid will be interested in this. We have done submental flap for our tongue, few of our oral cavity cases. But why this change in our scenario? So because of the risk factors, we are missing these risk factors, which is alcohol and betel nut chewing. So our most common concern for me, though we have alcohol and tobacco is one of the leading cause of cancers, but my concern in South Kashmir is pesticides. There are few of the studies, but not as standardized randomized trial. Few of the review of literature are supporting this. We may start, we have initiated with this cost, we may start a study. Why is there is a one study from the Iranian group has done a 32 patient study. They have seen the concentration of pesticides in the adipose tissues. So another things that viral etiology like Epstein-Barr virus and HPV is most common, and asbestos and some nickel and woodworkers in the parental side is a known fact. So what can be done? What can be done for us is to have some programs for tobacco cessation, HPV vaccination, diet should be good, protein rich, and oral hygiene has to be good. And we can change simply. For pesticide people, we can encourage them to use the protective gears, and we can reduce 90% of the head and neck cancers by that. And regular health checkup, screening for high-risk group, healthcare provided training is very essential. And public health education for us, school health, and worship places needs to be motivated to have some programs. I thank you all. Any questions, most welcome.
Definitely insightful, I guess he deserves an applause for the amount of work that this department is doing. Thank you, Dr. Ahmed, for paucity of time. I'm not allowing any questions. If anyone has any questions, you could talk, sir. You want to comment, sir? You could talk, please. They could discuss already. You can discuss anytime you're here only.
You can have 1 minute. I stayed for whole day.
Dr. Ahmed is doing wonderful job. Seeing daily his work, he is an excellent asset for Jinshananga. He is a treat to watch how he is operating, what work he is doing. Yes, we know his father has been my teacher. He has been my teacher. Excellent, sir. I just want to congratulate you. Thank you.
Thank you. Thank you, Dr. Ahmed. Thank you.
The next speaker is Dr. Faq Sherwani, again consultant GMC Baramulla Manual Surgery. He will talk on basic life support. It is also needed for surgeon very much.
Dr. Afaq, please do not stick to that.
Respected faculty members, my teachers, colleagues and dear friends, a very good afternoon to all of you. Actually, you may find my topic a bit different from surgical. This is a basic life support training often done by this one, Jikasik on this, this one, by physicians or anesthetists. So as was desired by ASI and was discussed in the last executive body meet, I was interested with this job to present this. In the daytime, before lunch, we did a hands-on training of these postgraduates and other students. I'll try to stick to time, but it's very difficult to do justice with this topic in 8 minutes. Okay. So basic life support, which includes a CPR, that's cardiopulmonary resuscitation. Do we need to know as surgeons? Basically, this basic life support is for all. It's not limited to medicos. We can have non-medicos, even in developed countries abroad. Whenever you apply for any job, for a job of driver or a police watchman, whatever job you apply, you are asked whether you know this basic life support. So this is something which every one of us has to know, whether we are medicos. And as surgeons, as medicos, definitely we are going to do it in a much better way. Next case, okay. So cardiac arrest being the leading cause of death in many parts of the world can happen everywhere. So now first we have to define who are the patients we declare as having cardiopulmonary. Unresponsive patient, not breathing spontaneously, and if within 10 seconds we don't feel a pulse, the patient has a cardiopulmonary arrest and we initiate the chain of survival, that's CPR. So first is we shout for help, ask the patient whether the patient is unresponsive. Number two, we always call for help because this is not an easy job to do a CPR alone. So this is look, listen and feel. So if all the three criteria are met, we cannot find the carotid pulse, the patient is unresponsive and not breathing spontaneously, our job begins. This is the chain of survival, what we have been taught by the American Heart Association. Call for help, start CPR, use a defibrillator till the advanced help arrives. So the recommendations. Now we have to know only three things. See, a person who has a cardiopulmonary arrest, his heart has stopped, he's not breathing, and the airway is blocked. So what is our responsibility is that we have to provide these three things till the advanced help arrives. Now I'll just simply show you diagrammatically with some pictures how we have to do this in a very in a scientific way, so that we do some justice with that. The patient may get benefited. Otherwise, if we don't do it in a proper way, we are doing more harm than good. So first is chest compression. How to do chest compression? So the sequence is always CAB. Chest compression, opening the airway and giving breaths. Now the chest compression. It has to be, the patient has to be flat with lying up on a flat firm surface. You come from right or left. See the exact position where I'm putting the right hand. It's the lower half of the sternum, and straighten my arms so that whole of my weight of my body is transmitted to the chest. This is how we do chest compression. If you have a problem with your hands, some rescuer may be having some arthritis, he can use one more hand to hold the first hand. See, this is the diagram representation how we do the chest compressions. Okay, so another thing is that what should be the rate of chest compression? How deep we have to go? It has to be at least 5 inches. We have to push very hard and fast, and it has to go at least at the rate of 100 per minute. So if the first goal is achieved, you are doing chest compressions properly, and at the end of compression, we have to give time for recoil. Then airway. How to maintain this airway? Very simple. It's not something rocket science. It's a very simple technique. Head tilt, chin lift or jaw thrust. This is the head tilt, chin lift. See, we can see this patient having tongue fall. This as a cardiac. You can see this white line is interrupted. So by a simple maneuver like head tilt, chin lift, we are opening the airway. Or else we have an alternate method. This is head tilt, chin lift method. Okay, then we have one more method, that is jaw thrust. If you are suspecting a spine injury, you can give thrust back from behind to the jaws so that the airway opens. So your second target is achieved. Now remains the third one, that is giving breaths. Okay, so how to give breaths? If there are three methods, one is mouth to mask or bag to mask. Only three methods, depending on whether you have a mask, you have an embo bag, or you have nothing with you. Number one, this is how we do the head tilt, this mouth to mouth. You have to see that the head tilt chin lift is maintained, seal is made around the mouth, and the patient gives, the rescuer gives one breath, and his eyes are on the chest to see for chest rise. Okay, so this is one more. Now if you have this mask, so this is how we apply mask on the face while giving breaths. So there's a technique called EC clamp technique. This diagram clearly shows your C seals the mask and your E lifts the jaw. So this is the EC clamp technique. Okay, this is how they resuscitate a patient. One person is doing chest compression and another is giving breaths with a mask. Okay, this is now if you have an embo bag, this is the most efficient method of giving breaths. So this is how we hold the this mask. See again the EC clamp technique, by holding the mask with another hand you are holding the embo bag, and you are maintaining the head tilt chin lift because you want to open the airway to give an effective breath. So this is if you are two or more rescuers. So this is how you proceed with the CPR technique. Okay. Now one important thing, one point you have to remember. If you are alone, if you are a single rescuer, the ratio has to be 30 compressions to 2 breaths always for any age group. But if you are 2 or more rescuers, for adults the ratio remains the same, but for infants and children the ratio goes 15:2. This is a very important point you have to remember. Okay, now a bit difference in children. While in adults we find the carotid pulse, in children, since the neck is very short, we can find the brachial pulse or a radial pulse. Okay, and CPR technique in children, in infants, we have to use this 2-finger CPR technique rather than using our hands. Or if you are 2 or more than 2 rescuers, you can proceed with this 2-thumb encircling technique. This is how. I would have loved to play some videos, but problem is we have paucity of time. So again, in infants, one more thing, the mouth-to-mouth breathing has to change to mouth and nose, because in infant the mouth and nose are very close. The idea is because if you blow through the mouth, the air will come out through the nose. So this is mouth and mouth to nose. Okay. Now this is CPR with advanced airway. This we need not to know if an anesthetist comes, intubates. So one of your jobs is done, that is airway is maintained. Now you have to only do chest compressions and give breaths. Okay, one important thing, the last one is how to use a defibrillator. At the beginning of this lecture, I told you once you call for help, always ask that person to get a defibrillator. That is AED. Now we have AEDs, that is automated external defibrillator. These are available. This is one of the pics I have clicked at Delhi airport. We have these in malls, railway stations, everywhere. How to use this AED is very simple. See, this is the picture from Delhi airport. So you just open the bag, apply the pads, stay away. This machine has a beauty of analyzing the rhythm. It will tell you whether this is a shockable rhythm or not. Otherwise, at times you have difficulty in finding whether this we need to give shock or not. But this is going to do everything itself. Just apply the pads, watch, it will instruct you, apply shock, resume CPR. This is going to tell you everything from that side. You need not to worry. So when to stop CPR? Now is the end. When to stop? Either the help arrives or the patient recovers. Or if the patient does not recover, you are tired, or somebody comes, an expert comes and hitting. Roughly, we should continue at least for 30 minutes, we should continue this CPR. So, okay, once a successful CPR is done, if we are able to resuscitate the patient properly, this is the recovery position. Always put the patient on the right lateral side so that if there is the drooping of saliva or something like that, so it will come out, it will not cause aspiration. So I have been doing these programs since 2013. I did my BLS, ITLS and ERTC in 2012. So since then I have been doing these in GMC Baramulla, training people. We have trained thousands of people. See, this is hospital staff, medics and paramedics I have been treating, showing them how to use this defibrillator and all that. We have trained teachers and students. We have taken their classes in GMC Baramulla. This is training of police personnel and tourist guides at Gulmarg. This was a big show there in Gulmarg. So we had the Directorate of New Medical College. We taught these tourist guides and how to do this basic life support. And one session I did in a police academy Baramulla. We trained these cops that how to do this basic life support. And if you are, because they are the first responders, you cannot wait for medics always till the time medic comes. So the patient will be already dead. So this is the OT staff training in GMC Baramulla, how to use these AEDs and all that. So the nursing college, I took one conference at a nursing college in Baramulla. We taught these nursing students how to do this basic life support. This is one more, we have a skills lab in GMC Baramulla. I'm training these paramedics, medics, everybody around. This is the recent picture. A couple of days back, we did a big program at Baramulla, training these students. One program I did at on the World First Aid Day at this Dog Bungalow Baramulla, where we trained general public. And this is today's this program in downstairs. We trained the postgraduates from this place and others. It was just in the hall B before the lunch session. Thank you. Okay.
Sir, you are doing great service.
Thank you, sir.
Yes, sir, one more thing. That's true. That's true. Many people don't know it. I also came to know it today.
Oh, okay.
My humble request to you, whenever you are doing such programs, do it under the aegis of Jagasi.
It is under the ages of...
Okay, sir.
Just have a
Banner behind.
Where you are distinct that everything is done under the aegis of Jagasi, that will be...
Sure, sir. I'll, inshallah, in future, whenever I do, I am doing these, sir, regularly.
No, I know you are doing
in a year, I do 3-4 programs with it. So we'll be putting a Jakasi banner behind.
Yes.
Because, sir, this is not for, this is for common people.
That's true.
Everyone should know this basic life support, how to give SCP. It's unfortunate that we see even our doctors, they don't know how to hold the mask. How to open it. It's very simple, head till chin lift. How to give chest compressions. That's why we have been emphasizing always that all of us, and as medicos or surgeons, we will definitely do it in a much more better way. So in future, I'll be, inshallah, putting a banner of Jakasi behind it while training anybody.
Thank you.
Thank you.
Dr. Afaq, a wonderful job that you always do. Really great.
Thank you, sir.
Now coming to the last speaker for today, I would like to call upon the dais Dr. Mudassir Nisar Shadal. He is a senior consultant and he will be talking on why ETEP, exploring its unmatched versatility in hernia management.
Good evening, everyone. At the outset, I would like to thank the organizers for giving me an opportunity to speak in this session. And I'll be speaking on... it's not coming. The slide is not coming.
Can we have the presentation on the main screen? Audio visual people, please. Audio visual. Dr. Mudassir has been doing a wonderful work in the field of hernia surgery, and it's good we stayed back, reserving the best for the last session of the day. We are also getting a half image on this screen.
No, this is not the image.
No. This our display उसमें भी आधा आता है. Versatility आधी आ रही है. ये magnified है. I guess there is resolution mismatch, audio visual, because we are getting 800 by 600 on our screen. Yeah, it's now on. You are online.
So I'll be speaking on an approach which is close to my heart now. I've been doing for a couple of years now. This is ETP. So modern hernia surgeon has a myriad of options available to him in this era of the minimally invasive and patient-tailored care. This ETP took a birth in actually 2012 when its founder, that's Jorge Diaz, is from Colombia, introduced this technique. In 2014, there were few major publications which demonstrated its versatility across the hernia types. In 2016, its adoption begins to accelerate globally, and at present, it has become recognized as a standard of care for many complex hernia surgeries. My interaction with this founder was during a DI conference of AWR in 2023, where I took a hernia course under this as my mentor, and then after that there was no looking back. By definition, it is a set of maneuvers and strategies that we undertake to enhance the usable extraperitoneal space through a remote access by creating a large space, dividing the natural boundaries, and by flexible port placements. So why ETP for inguinals when there is already a procedure called TEP and TAPP? Why do we need an ETP as such? Because there are challenges with the traditional TEP technique. It has limited visualization and workspace constraints. It has a bit longer learning curve, especially for the novice surgeons. And once we adopt an ETP, it creates a rapid and a large surgical field. There's a better tolerance to the pneumoperitoneum and there are better ergonomics. It has especially advantages in a shorter pubumbilical distance. When there are previous pelvic surgeries, there are complex cases like large inguinoscrotal sliding incarcerated hernias, and especially in obese or post-bariatric patients. The workspace is extended, as I mentioned. There is no peritoneal entry. In bilateral repair, there is a single axis. Usually you can do the procedure through a single axis, and the learning curve is usually moderate. So what are the access options that can be in this technique? One is the PDB balloon. It is easy and quick, but it's expensive. Then there is an optical access, which is again quick, but there is an advantage of having a no gas leak, but it is expensive and has a bit of a learning curve because you may end up tearing the peritoneum. And then there's a telescopic entry, which I as a surgeon practice, and I'm sure most of the surgeons practice over here. It's cost effective, but there's a bit of a gas leak as an issue. But identifying and navigating the critical anatomical landmarks for successful ETP approach is the key. In every patient of mine, I do a surface landmarking. And here you can see this is at times called as an Jorge point. It lies about 3 centimeter above and 5 centimeter lateral to the umbilicus, through which an access is made. So this is one of the patients whereby an access is being done through the same point. As you can see, the incision is being made in the peritoneal incision is made, and what you can see posteriorly is the glistening posterior rectus sheath. Then you just get in, do some telescopic dissection, and after the telescopic dissection, this is what you get to see. Below you will see the posterior rectus sheath, above a rectus muscle, and an inferior epigastric vessel. This is the Hassan trocar, which I use mostly. It is economical, gives you a good seal. And then you put in a sort of a navigator. This is a spinal needle that goes lateral to it, and accordingly the port goes in. This is the first working port which goes into the space. This is followed by then a dissection which happens medially as well as inferiorly to find the pubic bone. And there is a dictum in hernia surgery: you follow the white and you will be right. And this is what is being done to stay in the space between the 2 layers of the transversalis fascia. Then in this technique, in order to gain a triangulation, then we divide the posterior rectus sheath medially It is about 5 mm below the linea alba. Care is taken not to injure the peritoneum. So here we get the space, and then this becomes a point to introduce the second working port, which then goes in and we start the dissection. Now the dissection goes laterally, and you will see I have deliberately chosen this video because here I am making I am creating a hole in the peritoneum. But I am trying to emphasize here that despite having a hole in the peritoneum, there is much better tolerance to this pneumoperitoneum. And had it been a TP repair, the space by now would have collapsed, and the surgeon at times would have been landed into converting it into a TAPP procedure. But it's because of the beauty of this space, there is a better tolerance to the pneumoperitoneum. And then we go ahead and go on to do the parietalization of the cord structures. We reduce the hernial sac. You separate the sac from the cord structures. Basically, the idea is to get the myopectoral orifice of Frouchet to make in a space for the mesh. The hole in the peritoneum you can easily close without any much of a struggle. You can see how this is mainly the beauty of this technique, that you don't lose much of the space and you can perform it with ease. That's for beginners. It's absolutely fantastic. If they are even venturing into a TP, they can start with an ETP. And then this is followed by placement of a mesh. You can put a couple of fixations and then unroll the mesh to cover the hernial defect. Now, over the past few years, there has been a much interest into this Reeve-Stopa retrorectus space. It was quite popular in 1960s, the Reeve-Stopa repair. Now there's a renewed interest because it allows large meshes to be there. It is a highly vascular space where there are low mesh infections. There is no intraperitoneal processes, so there are no adhesions. And there is minimal or no fixation required, so there is no low post-operative pain. And of course, once we are placing a mesh which is non-coated, so there is low cost as well. Much of the credit goes to this guy. His name is Igor Bliansky. He gave the concept of an ETP Reeve-Stopa repair, whereby the midline crossover is done, whereby the two retrorectus spaces are connected and a large mesh can be placed to cover the ventral hernia. So he took it to the ventral hernias as well. So there's a versatility across various hernia repairs. You can do incisional, you can do umbilical, you can do epigastric, Spraglian, complex hernias, where you'll find it has a good suitability, this technique. So again, emphasizing that it can be put across number of scenarios, even complex scenarios where there are loss of domains, where there's a recurrent hernia, femoral, Spraglian, parastomal hernias. It has worked everywhere. Now this technique of a peritoneal crossover, we go again 5 mm below the linea alba. You tend to open this retrorectus space. Here we see the marshmallow sign. There is a glistening linea alba. You cross and open the opposite retrorectus sheath. Here you can see how I even created a peritoneal rent, but that doesn't matter. You don't have to injure the linea alba. This is a volcano sign in reducing the hernial defects, the contents of the hernia, and then going down up to the pubic bone. This patient had an M5W1 hernia, that means infraumbilical. It had about 4 cm defect and was an incidental hernia and had a bit of diastasis of the recti as well. This is followed by its closure. I am actually here a bit of diastasis also, and I am suturing and reinforcing the linea alba as well. This is the backhand suturing technique which I am showing here. You can take the sac also. This reduces the chances of seroma formation. This is a 2O non-absorbable barbed suture. And this is again followed by closure of the posterior rectus sheath. It is being closed by the absorbable barbed sutures. Care is taken not to put too much of tension on these sutures. and this is followed by then the placement of a polypropylene mesh. Can I take a minute more or yeah? Yeah, so then now we have ETAP variants. I will not divulge into the details. Then now we have an ETAP pre-peritoneal, ETAP from below, from above. Then we have a Carolina TEP technique. They have the advantages of not disturbing the upper part of the abdomen. And then this space can again be extended laterally if there are two large defects. If there is a tension on the posterior rear, there is a narrow retrorectus space, or we are dealing with a poor or compliant abdominal wall and complex hernias and atypical locations. You can have a top-bottom tower or a bottoms-up tower. And my final thoughts are that it is a no-way-to technique. It is anatomical, it's safe in the experienced hands, it enables complex reconstructions. It's expanding boundaries in the hernia repair and is a game changer in the modern hernia surgery. And it's not just a technique, but a paradigm shift in the hernia management and is being adopted throughout the world. Thank you very much, and keep your passion for learning burning bright no matter what obstacles you face in your life. Thank you very much.
Thank you so much, sir. With this, we close the session. And
thank you.
Thank you. We truly appreciate the depth of your knowledge. We shall now commence the felicitation segment of this session, for which I would request Dr. Ejaz Ahmed Malik to come on the stage to felicitate the chairpersons. Dr. Ejaz Ahmed Malik. Dr. Ejaz Ahmed Malik is not present in the hall. Oh, okay, sir. Dr. Arshid Rashid Kema. Thank you, sir. Dr. Zakir Hussain. Thank you, sir. Dr. Varun Dogra. Thank you, sir. Please have a seat, sir. Sir, kindly have a seat. I request Dr. Nisar Ahmed Shah to felicitate the speakers. Dr. Shamsul Bari. Thank you, sir. Dr. Amir Yusuf. Thank you, sir. Dr. Afaq Yusuf Sherwani. Thank you, sir. Dr. Salman Khurshid. Thank you, sir. Dr. Mudassir Nisar Shahdar. Thank you, sir. Dr. Junaid Khurshid.
Thank you, sir. Kindly take a seat. Please. As we bring today's session to close, I extend my heartfelt appreciation to each one of you for your steadfast engagement, enduring energy, and thoughtful perspectives you contributed throughout the day.
As we move into the final day tomorrow, I encourage you all to join us with the same energy and commitment. Let's carry forward the momentum and spirit of this collaboration. Once again, thank you. Wishing you a restful evening and see you tomorrow.
Before we disperse for the evening, we request all the members of JCASI to kindly remain seated for a brief general body meeting that will commence shortly. Following the meeting, we cordially invite all the delegates to join us for gala dinner at Eden Resorts and Spa, Pahalgam. Thank you so much.
Thank you, sir.
Good evening, everybody. So